Like Dr. Mujib, Dr. Prasad Mailarappa to chair this session. So, Dr. Sridhar PS is running a little late, so he'll be coming in half an hour, he'll be joining in half an hour, 45 minutes. So meanwhile, can I request Dr. Vedang sir to chair this session, sir? Thank you. So, the first topic from 8:30 to 8:40, which was on, has already been dealt with on 26th, while he was showing the techniques of transperineal biopsy by Dr. Anant Shivaraman. So we'll be going with the second one. So over to the chairpersons.
You have this? So I'll just start it because chairpersons, the bio slide is there. You'll have to just introduce him.
No. I'm audible, no?
Yeah.
So, well, that's a habit now. Am I audible? Sorry. Now we'll play the video received from Dr. Amar Kishan. He is associate professor at UCLA, associate professor of radiation oncology, and very leading figure in the field of radiation oncology, doing a lot of international multi-centric stuff. And we have asked him to talk about local treatment in Gleason grade group 5 prostate cancers, locally advanced Gleason grade group 5 prostate cancers. Do we have the video, please? Amar said he will try to join in. They have a major power outage in Los Angeles, so his internet is not working. So he'll try to join in by phone. Yeah.
I'll be talking about optimizing local treatment for Gleason grade group 5 prostate cancer. Only 5 to 10% of prostate cancers historically have been grade group 5. Most cohort studies and trials have reported outcomes for patients with grade group 4 and 5 disease together. Though grade group 5 is a known adverse prognostic feature, per guidelines, grade group 5 prostate cancer is treated similarly to any high-risk prostate cancer. This has been an interest of mine for many years, and I was fortunate to lead a multi-institutional prostate cancer retrospective study of 1,809 men with Gleason grade group 5 disease, treated from 2000 to 2013 with either surgery, EBRT, or EBRT plus breaking, was published a couple of years ago. I won't bore anyone with the details of this design, other than to note that in any retrospective study, there's obviously selection bias that's at play. You can see that in this table here, age, PSA, biopsy score, and clinical D-stages across the different groups, prostatectomy, EBRT, and EBRT plus breaking. You can clearly see that these are imbalanced at baseline. Most of those imbalances tend to be favoring the prostatectomy cohort. We attempted to adjust for this using propensity score adjustment. This is imperfect, but we can at least see, looking at the right there, the standardized mean difference went from above 0.1 and as high as 0.58, all the way down to between 0.006 and 0.127, indicating a good control and limitation of some of the imbalances that exist here. Again, not perfect, all retrospective studies have confidence. Now looking at the fine print, this really was a RP-only group in general. Now, about 8.7% of these surgical patients received adjuvant radiation, and about 34% received solid radiation. That's low numbers, but at the same time, these are high-power academic institutions that really get real-world data that helps this practice. Okay, and when looking at the radiation group, you can see that EQ, median improved EBRT cohort is only about 74, meaning there were patients receiving low-dose radiation as well. The more important caveat, I think, is that when you look at the median duration of ADT, it's only about 22 months in EBRT, and we know that's insufficient, right? The minimum recommended duration for this disease group would have been 28 months, it would take minimum 24 months during the years 2000 to 2013, raising the possibility that even the EBRT group was undertreated. And if we look at the EBRT plus breaking group, you can see as well that the median duration was quite short at 12 months, Now the NCCN guidelines do say that a minimum of 12 months is okay, but here's the median. So EDT was likely underutilized as well in this group. Just to keep that in mind while thinking about the RP cohort being a little bit undertreated. And we also see some analysis of pelvic neural radiation. The RP trial from Memorial that showed an important impact to pelvic neural radiation in many of the EVRP patients did not receive that. Now, with that in mind, I'll go over some of the results from the study. We looked at PCSS and DNFS here, as well as OS. And what you can see immediately is that the EVRP plus security therapy curve here appears superior to the other groups, which are largely overlapping, both for PCSS and for DNFS. So there's kind of a non-proportional hazard with OS. In the first 7.5 years, EVRP may be superior, but then that really kind of converges with time. I think there are two major takeaways from this. The first is a resounding success for EVRP plus DT with only 12 months of ADT, so that's kind of a modicum of systemic therapy, very intense local therapy, kind of a team that you'll see in this talk. But the other major takeaway is that EVRP and RP were identical here, despite the fact that EDT was underutilized and many of these men may have gotten low dose EVRP. This is contrary to what has been published before, suggesting that RP was preferable. Definitely not the case in this real world data. Now, what is the optimal duration of ADT for this group of patients anyway? There are trials they have like PCS4 that suggests that maybe 18 months is okay for high-risk prostate cancer, but I was reading a superiority trial of superiority 36 months, and sometimes maybe it's not powered adequately, etc., etc. And so this is also something that I've been interested in, and I looked at this specifically because there's also a higher study which has shown that EVRP was freaky and getting away with 12 months median, whereas the EVRP group didn't perform as well with a median of 22 months. And so, again, looking retrospectively here at all high-risk prostate cancer, we did a spline model to try to find the optimal AD duration for DNFS, and we found this for EVRP. I should say this is high-risk EVRP. We had a duration of 26.3 months. Okay, so the 22 months would not have been enough. Many of these cases would have been undertreated. This is a really sharp slope going between 20 to 27 months. With EVRP plus 30, looks like 12 months was the optimal duration, and the slope is a lot broader here. And maybe with the median duration being 12 months, you're still including enough effective ADT that you're really getting your bang for your buck. That will work. Patients, that possibly explains the reason why EVRP plus 30 should outperform EVRP plus ADT in our prior analysis. This paper was just published in Oncology earlier this year. Now, going back to the question of surgery versus radiation, a very smart group, Germany wanted to look a little bit more detail at patients getting post-operative therapies. Their idea was, look, you have the EVRP plus 30 plus AD, clearly a winning combination, but what if we really went into the nitty-gritty of the different types of post-op management strategies? And so they did this. They had fewer patients, very few EVRP plus 30. Most of these patients had surgery, over a very broad time window, but they did hammer down some of the post-op details. I would note the median AD duration with the so-called max RT patients getting a very deep use was only 6 months, which I just showed you is probably insufficient, but it is what it is. With a surgical group with max RT, that's only about 8.9% of the patients, very similar to our 8.7% anti-RT rate. That really got adjuvant radiation plus ADT, the rest of their patients got surgery alone with or without salvage, or maybe they got adjuvant or RT alone without ADT after radiation, after surgery, I should say. And when they looked at prostate cancer specific mortality and all-cause mortality, what they found was that max RT was the main candidate. So this is similar to what we have shown actually, that the best PCSM and all that. However, they felt that max RT, they had surgery, radiation, and ADT was plausibly equivalent. And that's what their conclusion was. If you treat these patients with surgery and you do adjuvant radiation and ADT, you feel them just as good as patients that got maximum RT. And certainly well done study. And you might ask, well, what about the artistic study? Did that take a meta-analysis fine print, this trial, a meta-analysis really grouped Houston and Pete 9 and 10 together, first of all. And second of all, even with this group, we only have about 8 to 16% of patients that have this. So I would, it doesn't really apply to these, the highly graded cancers, where there may still be a role for adjuvant or maybe very, very early stages radiotherapy over solid radiotherapy stuff. So what's the summary here? Well, ERT plus Brady with a median AD duration of 12 months appears to have significantly improved efficacy over RT without a strict multimodality protocol and EBRT. Now, high-dose EBRT with 24 months of ADT may have comparable outcomes, at least with PCSM, but in the Western world, such variations of ADT are not always used. RT with EBRT and ADT may have comparable efficacy to a Brady boost with a median ADT duration of 6 months, but really, maybe surgery alone is not right. Again, based off of a couple of well-done retrospective studies, not a randomized trial, but very few randomized trial patients have ever had recently group disease. And these types of comparative trials are not conducted. What about cancer failure? Very really interesting question that we have to ask when we're talking about local therapy. We have great data here from Dr. Leanne Markey, who's very kind to share this with me. But as a retrospective analysis, 462 patients treated at 20 centers across India, median follow-up of 56 months. He presented us as shown in papers under review. Of patients with BCR, 77% had a PSMA FCT. And that really allowed him to analyze the patterns of failure in great detail. What he saw was that 80% of patients with BCR here had a distant metastasis. Only a very few patients had local only failure, and fewer still had regional only failure. The vast majority had distant mets, either distant mets only or distant mets plus some other type of failure. Being very important. And consistent with something that we had published in BC Group 4 or 5 disease a couple of years ago in European Urology, which is looking at a concept of the second wave and whether that exists and how important that is compared to the first wave. We recently updated this analysis looking at all implicated high-cost cancer that are showing the older study here is more relevant for losing Group 5 disease. And we can think about this as a 4-state model. There are patients that have a relapse-free state, develop a local failure, or they have a relapse-free state, they develop a distant metastasis, or they have a relapse-free state and they die of prostate cancer. Local treatment options, local treatment investigation is arguably only important in preventing a local failure from progressing their distant metastasis if we accept that patients dying of prostate cancer are generally dying of distant metastatic disease, not a local failure. And if we look at the clinical patterns of failure, here this is data from 6 trials, RT3, RTFC, and 3 ERTC trials from the older era with low-dose radiation and various permutations of short-term and long-term ET. And we look at whether patients who developed this metastasis either emerged from a clinically relapse-free state or they had a local failure diagnosed first. What you see in the first 5 years is that 80% of clinically detected metastases are arising without a clinically detectable local failure occurring. That's the first way you see that in all types of treatments that are done. And I would argue that's really similar to what Dr. Murphy reported in recently Group 5 in the PSMA era. We have much better immunity, still 80%. This is telling us the vast majority of distant mets are probably emerging from a potent member of metastatic disease that was present at the time the patient was diagnosed. However, as time progresses, you see an increase in the proportion of patients that are developing a distant met after clinically diagnosed local failure. With RT alone, that's actually 50-50 split from years 5 on, and our updated analysis of the intermediate disease, we saw a very similar pattern. Appears to be a generalizable phenomenon in prostate cancer. In the beginning, most of the metastases that are being seen are kind of occurring before local failure infected, but later on, we can really see the second wave. What does this tell us? It tells us that a large proportion of failures after definitive therapy in manipulation group 5 disease are distant failures. The optimal treatment is likely one that delivers both excellent local control and a measure of systemic therapy. Modern high-dose radiation with DET is highly effective as the therapy is very reduced, possibly the disorder of recent DET. RP alone is likely to be insufficient. Follow-up RT with DET may be sufficient for residual microscopic disease, but could increase significant toxicity. I'd like to thank you again for your kind invitation and attention. Please contact me by email for any concerns or questions. And I apologize if there's any background noise. I'm actually on vacation at the time I'm recording this. I think probably at the time you're hearing this.
No,
So,
take
thanks
it.
again for the invitation, and I hope to see you in person soon. Take care.
So we don't still have him online on Zoom, so we can have a discussion.
Can I have a question, please?
So, yeah.
Hey, Srinivas.
Hi. If Dr. Kishan is listening, great talk.
He's not online.
He's not online. We can have a discussion. Okay. I mean, what he's shown is that, of course, systemic therapy intensification is required in these aggressive Gleason grades. But the question is the local dose escalation. We have not gone beyond 80 gray, which is the standard. And there is some hint that even more than 80 gray could benefit progression-free survival, biochemical progression-free survival. But he said that the second wave could be contributed by the local failures. So in the setting of more systemic therapy intensification, hopefully with better systemic control, can dose escalation still play a role is a question which we need to answer.
Yes, Srinivas, I think your question is relevant, but if you see the 15-year data of Kiel, Seattle, and William Bimo is almost about 60 to 66%, between 60 and 60%, 66% for the high-risk group. You're not talking of any low risk. So that shows it holds on. If you do only external beam, around 7-8 years, most of them fail. But in our country, if you just give EBRT or more of ADTs, then these people are above 75, 80. So they are going to some die of some other disease, and we lose follow-up. So you get if you see British Columbian data, you will give a lesser ADT, increase the dose. So we are talking of what we have prescribed, but we have never seen the inhomogeneous doses inside the prostate when you do BT boost. So that is the advantage, I feel. And I have my own data of 95 patients. Most of them have died of heart problems rather than, but we have around 72% 8-year data.
Vivek, the question what I asked was that the dose escalation in GG5 through brachytherapy or external beam radiation, would it be beneficial? We are making essentially the same point.
Exactly.
But what we shown in our 462 patients of exclusive grade group 5 cancer patients, Dr. Vedang and others will bear with me, is that despite not using brachytherapy, we had more than 90% overall survival.
That is 5 years.
Yes.
See, sir, that 7-8 years is the crucial period. You see.
So again, you're talking about the second wave. That is what I'm saying. So can we escalate the dose?
You call it anyway. What I'm saying is, see, I have practiced only EBRT till 2012, from 2006. So all these people around 7, 8, 9 years, they fail. Either in the bone, distant, wherever. So those do not happen when you use a BT boost. And BT boost, the beauty is that inhomogeneous high dose escalation. We only talk of whatever, 15 gray, 12 gray into 2, whatever. But
okay. I think we'll point taken, Vivek. So
I request you to add an arm for this group. And
yeah, but there are, unfortunately, there are very few brachy practitioners, especially for the Gleason grade group 5 cancers. So this is not grade group 4. This is grade group 5. This is only 9 and 10. And out of your 70 or whatever patient, there will be only a few who are only grade group 5. So that is one issue. Second is, I would like to highlight that from the summary of what Amar Kishan said, high local control is important, and that is provided by radiotherapy to a high dose, either using brachy or dose escalation with EBRT, and or surgery, of course. But to add that extra punch after the surgery, adjuvant RT is needed for most patients, and for radiotherapy, adjuvant ADT is needed for most patients. I think that is the take home. And if we put all these together, these two modalities are same. And just to summarize, Indian data, and I think I request Dr. Raghu and Dr. Rawal that this is the kind of collaborative effort that SOGO should do to put together 15, 18, 20 centers and produce this kind of data. This is the one I was telling about in the council meeting. 500 patients, Indian patients, all Gleason 10, 9 and 10, treated in a similar way, and we have our own data. It will be out in print soon. So that is what SOGO should do. Thank you.
So I have two questions. One, I
yes,
would
Ganesh.
ask Dr. Santosh Menon, who's sitting here. He would have seen some prostates radical with grade group 5. What is your experience on seeing extra prosthetics and all? That is one question. Secondly, Santosh, you can maybe come somewhere and answer. To ask Dr. Rawal sir, somewhere in the slides, Amar Kishan had mentioned that surgery with adequate multimodality would match the outcome. So today, sir, how would we select patients for surgery with multimodality? And Vedant, question to you also. In your that 460 data of GG5, fine, that was the survival outcome. What is the local problems which this has? We know many patients who are GG5 who have a bad local growth, a bad LUTS, urinary symptoms, and their quality of life is bad. So, sorry, but there are three questions.
So I'll take the first question, Ganesh. So you said the GG5 tumors on radical prostate, the issues, the main issues, I think at surgery only you would come to know that they are more adherent, and extra prostatic extension and margin positivity in these tumors are large. They are generally large volume tumors.
When we do the Indian 4+4s, there is, unifocal somewhere here, there, and
Yes.
we go by the raves as after
And
surgery.
another point, as a pathologist, what I want to, the 4+5 and 5+4, we have to now really look at the cribriform pattern of pattern 4. They are really bad tumors. They throw early metastasis. They have more margin positive. They are high volume tumors.
So message to surgeons here is, if we are looking at GG5 and you plan to operate, think about radiation, adjuvant, plus hormone straight away. I think we'll take comments from sir.
Yeah, as far as surgery is concerned, you can't do in every cases. You have to select your cases properly. It's not that on DRE you see extracapsular disease and you go ahead and remove that and you come through tumor, and that's not the idea. These patients, when we operate for the surgery, we examine them properly, we do MRI, and if there is a small extracapsular extension, even on DRE or MRI, I'll go ahead because I know I can take the adequate margin. And you have to, change your surgical approach, like Radius sparing we will not do. We'll go from anterior approach, and we go really wide, not saving the neurovascular bundle, and do very good lymphadenectomy, extended lymphadenectomy, so that we can properly stage the disease and then decide the adjuvant treatment. But then this is only in selective cases, not in all. It's always there. But then you have some cases where there is very high PSA and disease is still in the prostate.
Right.
You can offer the surgery, and some patient you have PSA even less than 10, and the disease is, extracapsular, lymph nodes are big.
Right.
So every patient is different in this situation.
Would age also be a connecting factor?
Actually age is it's not a 100% criteria, but above 70 we generally do not prefer, and if the comorbidities are there, at that time also, in those cases also, we do not prefer to do the surgery. Problem of the age and comorbidity is, especially comorbidity, heart problem. If you add ADT for 2 to 3 years, that also somewhere, as somebody made comment, that plays a role. Many times the patient, he goes because of cardiac condition and all. That also you have to think.
Right. So that was very nice comments because I wanted to bring out surgical from a very senior person. Raghu.
Can I comment? Good morning. See, we have been fighting which is better, which way to deal with. There is a meta-analysis separately analyzed for high-risk prostate cancer, organ-confined prostate cancers, and locally advanced prostate cancers. The meta-analysis of 10-year overall survival, difference between multimodality versus going for surgery alone or radiotherapy and hormone therapy alone. Multimodality will give 12 to 14% survival advantage at 10 years for even high-risk localized and locally advanced prostate cancer. It's very, very clear. So, probably for high-risk prostate cancers and locally advanced prostate cancers, multimodality is the way. And now, neoadjuvant hormone therapy and intense neoadjuvant hormone therapy is coming up in a big way. That is going to probably improve the results even 10 years and even 15 years. So we should, every patient of high-risk prostate cancer should be.
So, two small comments for you also. Multimodality is in both surgery, radiation. Secondly, neoadjuvant intense with Abira will again is come in radiation. It will come in this way if at all neoadjuvant comes surgery.
No, I am not talking. Hormone therapy and radiotherapy is not multimodality. I am not talking about that multimodality. Multimodality means surgery plus radiation.
You are saying surgery with multimodal. Surgery related multimodality.
Surgery with radiation.
Okay.
Well, I don't completely agree.
Yeah.
Each meta-analysis of retrospective studies have got a lot of stuff going on inside that, and we are not going into that, number one. Number two, right now we are talking only of Gleason grade group 5 cancers, and your the meta-analysis is not related to that. Number three, just before Ganesh, you asked me about the
question, the local
control. I am actually looking at the draft of the paper. The grade 2, late grade 2 toxicity is 20%. These are moderate toxicities, some bleeding, some urinary.
Right.
And grade 3 toxicity, which is more severe, that we are worried about, and we have to see them multiple times, some clots, some catheterization, is about 4.1%.
Okay.
This is in the community, 20 centers, all treated with IMRT.
Okay.
So this is the community Indian data. 5% is, there may be some underestimation.
So just for the thing, do we have data where how many had required a TURP because of these kind of obstructions? Because TURP done in GG5 patients sometimes is a difficult job. Not always many landmarks are clear to the urologists.
We know that about 20% of the patients had a TURP before. I think 15% had before. But I don't know after.
Yeah.
Ganesh, I have one. Can I make one comment?
I think you said that 18 to 20% of these patients will end up with a surgical procedure, either TURP or a stricture or something. And that's a very measurable situation. Once post-TURP, post-radiotherapy TURP, patient most of the time is incontinent.
I think before...
I just want to add one more point really.
But...
hello, sorry. And that is exactly what I agree. 1 in 5 end up in this. And they are incontinent at the end. Come what may. They say disease was better than the treatment.
So you are saying 1 in 5 patients need a TURP after that?
Some kind of surgical thing. And what happens is now, and it sometimes ends up in suprapubic permanent. It's happening.
So those are 5%. So this I am talking not from my experience. This I am talking from actual data. So I can always say in my experience, nobody has this problem. I can easily stand here and say that in my own experience, we don't see any toxicity. But this is data that we are showing.
So the data from Brazilian journal recently published, post-radiation, if they progress, if they are cured, it's fine. If they progress, there are 4 complications described. One is need for cystoscopic clot evacuation, pelvic pain, requirement of DJ stenting, and difficulty in passing urine, requiring re-TURP. All these put together were 52%. All these put together.
Must be in Brazil.
No,
not here.
This is the data. You are talking about data. This is also data.
So And I will tell you post-op what happens.
No, I'll have to comment. See.
Anyway, I think this was not the point of this talk.
Vedant, but let us take 2-3 comments.
Yes,
I think
of course.
this is good discussion which we want in SOGO.
What Dr. Raghu is saying, whenever you use one modality, there is inherent problems of that. When you use 2-3 modalities, you will have to consider all that. I mean, if you go on doing multimodality, yes, there is no end, but see what the patient is undergoing. So this is the problem. And if you see Abdullah's robotic data, group 5 is only 39%, 10 years. If you see EBIT BT boost, it's approximately around 60%, worse come worse. So there's a 20% difference. If you see Ascend RT 8-year data is about 74% with boost. So that's too much.
So regarding Dr. Rawal's and Dr. Kulkarni's comment about 20 to 30% patients requiring TURP and suprapubics, were they 20% of those 4% who had grade 3 toxicity? Because in routine practice, we don't see this kind of pelvic pain or requirement for a DJ stent or TURP or...
Absolutely.
It's absolutely
But that
not
happens
seen.
with the surgeons also. The
I tell
patient
you
goes
my
to another
personal
clinician.
experience. My personal experience, one of the patient who was related to father of a worker in our hospital, he had high risk disease. I suggested radical prostatectomy. They went for radiotherapy, and in Bombay, after that, they came to me with SPC hanging. So I'm saying the literature. Your patient may be very highly selective, nice patient. But this is the literature which says, and once you do TURP in this patient, that's the horrible situation.
There are a couple of things. See, once post-radiation, if they develop any urological complications, they will not come back to you. That's number one. They will land up with urologists. We should also know, as urologists, we should also know, if you go with multimodality treatment, the risk of SUI is more, risk of bladder neck stenosis is more. So these two things are, complications are more if you go with multimodality treatment.
Rather, I have now very good approach from like talking with radiotherapist. If the patient is having LUTs or high residual urine or median lobe is enlarged, better to do TURP before radiotherapy. These patients, they do.
We strongly recommend that, sir. Yeah. We strongly recommend that.
Dr. Rawal.
So, yeah, I'll tell the audience the reason why we did this analysis. Because in the community, there is a perception about 2 or 3 things. One is that radiation is not enough for GG5 patients, radiation and EDT. Number 2 is multimodality treatment is the best treatment in these patients. Number 3 is brachytherapy boost is required or higher dose escalation is required. So we evaluated these 3 points, and that is the reason why we did this study, and it is actual data in a community setting of protocol. And these are captured from 20 different institutions, reputed institutions.
I think about this data we have spoken, so we'll go ahead with the next.
So that is the reason we need to do these.
So I think my strong suggestion...
already said we need a collaborative research.
My strong suggestion would be we should see the similar data for surgery from India.
That is my point, yes.
That will be the best thing to do after this meeting. See Gleason grade group 5, all operated with prostatectomy, and see the outcomes. I think that should be one takeaway.
Sir wants to comment. He's standing for a long time.
I'm just asking, you're saying multimodality. I agree, we are saying multimodality. So at what point of time we will say no to surgery? Dr. Rawal mentioned high extracapsular. What about high volume disease near the apex? Would you actually take that up for a surgical resection or send them to radiation and say no surgery now? We will probably consider it later. So high volume disease, extracapsular near SVs, possibly you will take. But high volume near the apex, are we going to take them for surgery?
Apex, is technically, if you do a surgery at that area and if you try to achieve negative margin, patient probably will be incontinent. That's the only thing which you are worried of. If on imaging you see this very well encapsulated high volume disease at apex, it's a very rare situation rather, which you are talking about. Rather, if sometime you do see you may have to change the plane on the apex. You saw the radical prostatectomy done by Deepak Dubey. That doesn't happen. You go in extra plane and you remove it out. It depends on the decision of surgeon at that time. On imaging, I'm sure if it's very high disease burden at the apex, you will not proceed for the radical prostatectomy on imaging. But if it is equivocal It depends on your skin.
Thank you, sir. I think we'll move on.
One more last point, that
Right.
was, for historical purposes.
Yeah.
We used to see patients being put in prosthetic stents, and 2 patients we had to remove the stents, which was much more difficult by open way.
Okay. All right. So the takeaway from all this is, in the next SOGOCON, we will have GG5 post-op data. Raghu, post-op GG5 data.
We'll do that.
Next SOGOCON. That's the task. Thank you. We have a very related talk now. Dr. Paul Sargos is from Bordeaux, France, and he is the PI and the first author on one of the trials, the AFU JETOG 17 trial that was formed, that was part of the artistic meta-analysis of salvage versus adjuvant radiotherapy. And he'll talk whether in this scenario, is there still a role of adjuvant treatment, or it's all about salvage?
Good morning, ladies and gentlemen. My name is Paul Sargos. I'm a radiation oncologist in Bordeaux, France. And first of all, I would like to thank the scientific committee, especially Dr. Mercy, for these invitations. And we'll talk to you about adjuvant radiotherapy for the radical prostatectomy, and is the strategy still relevant for locally advanced prostate cancer? So, 3 randomized phase 3 trials have evaluated the benefit of adjuvant radiotherapy versus observations. The ERTC 22911 trial, the AERO trial, and the SOGO trial. We can see on this curve that adjuvant radiotherapy has demonstrated a statistically significant benefit in terms of biochemical progression-free survival or clinical and biochemical progression-free survival. Only one trial, the SOGO trial, has demonstrated the metastasis-free survival benefit. But there is a lot of limitation in this study, especially the detectable PSA following radical prostatectomy and potentially the use of ADT in the adjuvant setting that is not a standard of care in this situation. Moreover, when we look at the curves, for example, here the red curve, we can see that half of at-risk patients, despite the pathological high-risk findings, will never present a biochemical relapse. It means that if we propose adjuvant radiotherapy to all these patients presenting pejorative features, we will overtreat 50% of these patients. So, the French Association of Urology has given the level 1 evidence for the patient's informations over the adjuvant radiotherapy strategy. If the salvage strategy seems a relevant option, we didn't have any strong evidence to propose this approach until recently with 3 randomized trials. The first one was the Radicals RT trial, the second one was the RAISE trial, and the last one was the French GDF 17 trial. All these trials were phase 3 and compared adjuvant radiotherapy, the standard of care, with an early salvage radiotherapy strategy in case of biochemical relapse. But in the RAISE trial, for example, with 323 patients randomized, we can see that a few patients were with really high-risk pathological features. For example, when we look at the Gleason score here, only 15% of these patients had a Gleason 8 to 10. Similarly, when we look at the seminal vesicle movement status, here only 20% of the patients in this trial present this pathological high-risk feature. So this is low-risk patients, and probably not the same but in the old-fashioned arrow SWOG and ERTC 22911 trial, confirming the benefit of adjuvant. Here are the RAISE results showing that adjuvant radiotherapy is not superior to salvage radiotherapy in terms of freedom from biochemical failure in this population of patients not really with pathological high-risk features. We have the same findings in the Radicals RT trial, randomizing patients between adjuvant radiotherapy and salvage radiotherapy when PSA failure appears. The results confirm that adjuvant radiotherapy is not superior to salvage radiotherapy when salvage radiotherapy is proposed early with low PSA levels. Finally, here are the curves from the GDF 17 trial published in the Lancet Oncology, and we also show that there is no benefit in terms of event-free survival in favor of salvage radiotherapy. These 3 trials have demonstrated that adjuvant radiotherapy seems to be a new standard of care in this situation. All those 3 trials were included in the meta-analysis called ARTISTIC. It was a prospectively planned systematic review and meta-analysis of aggregate data. And here are the plots showing that adjuvant radiotherapy is not superior to salvage radiotherapy for patients with pathological high-risk prostate cancer. Nevertheless, in the artistic collaborations, we can see that patients were not really at high risk as described in the old-fashioned adjuvant radiotherapy trials. Here, evaluated by the CAPRA-S risk strategy, only less than 30% of the patients in the radical therapy and the RAVE trial were considered at high risk of biochemical relapse or high risk of events. So, the first question really is salvage radiotherapy a new standard of care for these patients with really high-risk pathological prostate cancer? We can discuss this point in the following slides. We can discuss because due to the limitations mentioned before, with a small number of patients presenting pathological high-risk features in the artistic collaboration, a lot of experts were not convinced by the data and want still to continue to propose adjuvant radiotherapy for these specific populations of patients presenting a combination of pathological high-risk features. And we can see here editorials or comments published in the journal asking to the best timing of post-operative radiation therapy after radical prostatectomy. Following the artistic publications, Tilkia has conducted a retrospective study including 26,000 patients with a follow-up of 8 years. From their database, they show that adjuvant radiotherapy can give better results in terms of all-cause mortality for patients combining pathological high-risk factors. For example, patients with PT3, T4N, lesion 8 to 10, probably have better results in terms of all-cause mortality when he is treated with adjuvant radiotherapy. So here are some bullet points. Adjuvant radiotherapy probably can be considered as a standard of care for patients with PT3, T4, and lesion 8 to 10, especially when an early salvage strategy is not possible. In daily practice, if you cannot see your patients when the PSA starts to rise and propose this early salvage strategy, you must discuss the adjuvant radiotherapy approach in your clinic. But when we talk about risk in this population, there is 2 types of risk. The risk of local regional or biochemical relapse, but also a risk of distant metastasis. And we can see here in red from the ERTC 22911 trial that adjuvant radiotherapy only conferred a benefit in terms of clinical progression-free survival, but not in terms of distant metastasis-free survival. By analogy, for localized prostate cancer treated with radiotherapy, we have data showing that long-term ADT present a benefit in terms of clinical progression-free survival when compared with radiotherapy or radiotherapy with short-term ADT. And long-term ADT also has demonstrated a benefit in terms of distant metastasis-free survival, especially in the ERTC 22961 trial. I mean, do you think really that adjuvant radiotherapy is the best way to reduce the risk of distant metastasis in these patients with a real risk of distant metastasis following radical prostatectomy? The answer is probably not, because we need to combine treatments in prostate cancer. We can see that ADT can control the distant metastasis risk, but in the adjuvant setting, there is no indication to prescribe this treatment. Here are the EAU guidelines in 2022, giving a strong recommendation: do not prescribe adjuvant androgen deprivation therapy in lymph node negative patients. So adjuvant radiotherapy has no clear impact on metastasis-free survival, and adjuvant ADT is not a standard of care. So adjuvant radiotherapy seems to be the benefit in terms of local regional control, in terms of biochemical control. If we want to have better control in terms of metastasis-free survival, probably we need to combine radical prostatectomy with adjuvant radiotherapy and 2 years of ADT here bicalutamide in the SPCG-15 trials. This triple approach perhaps will be the new standard of care for patients with pathological high-risk features following radical prostatectomy. So we have to propose adjuvant radiotherapy, especially if early salvage radiotherapy is not feasible. But how to propose this salvage radiotherapy strategy? Data from the Genitourinary trial. In this trial, patients presenting biochemical relapse following radical prostatectomy were randomized between radiotherapy versus radiotherapy plus 6 months of dose. We can see here the results showing the benefit in terms of progression-free survival and metastasis-free survival with the combination of salvage radiotherapy with 6 months of dose compared to salvage radiotherapy alone. The subgroup analysis from the Genitourinary 16 trial showed that all patients seem to benefit of the addition of 6 months of dose when combined with salvage radiotherapy. But do we need ADT for everybody in the salvage setting? We can see here the RTOG 9601 study comparing salvage radiotherapy with salvage radiotherapy combined with 2 years of bicalutamide 150 in the salvage setting. You know well the result from this trial. There is a benefit in terms of overall survival, specific survival, and metastasis-free survival in favor of salvage radiotherapy combined with 2 years of bicalutamide 150. However, in this trial, we can see that the benefit of hormonal treatment appeared only for patients treated in a late salvage radiotherapy strategy. It means that when patients have a PSA less than 0.7, there is no benefit with the addition of 2 years of bicalutamide in terms of overall survival. In this direction, in 2019, during the ASCO meeting, Dan Spratt has presented this result, showing that men with levels below 0.6 nanomolar per milliliter show no benefits of the addition of ADT, and the decision to add ADT to salvage radiotherapy should be balanced depending on the PSA level before the treatment, but also pathological high-risk factors found on the specimen. And of course, it's a tailored strategy we need to discuss with our patients about sexual function and cardiovascular morbidities to reduce the risk related to the side effects of the systemic treatment. So, what are the perspectives and how to optimize this strategy, how to choose the adjuvant radiotherapy or the salvage radiotherapy strategy? We have data using Decipher, genomic test evaluating the risk of biochemical and metastasis-free survival relapse. And we can see that only patients with Decipher high risk will benefit from the adjuvant radiotherapy strategy. It can authorize us to personalize our treatments. So in conclusion, the question was, is adjuvant radiotherapy still to consider for some patients? Yes, probably. Salvage radiotherapy is a standard of care when we have the possibility to give this treatment early at the first phase of PSA. We don't have to wait for positive imaging in this setting, and we need to evaluate the integration of PSMA or MRI in this salvage in clinical trials. Adjuvant radiotherapy must be discussed for young patients with pathological, very high-risk features, and ADT can be associated in the salvage setting, not in the adjuvant setting, depending on PSA level, other pathological factors, but also comorbidities and sexual activity. What are the perspectives? New hormonal agents can be associated with salvage radiotherapy and ADT when patients harbor pathological high-risk features, and doses conditions and can be re-evaluated based on imaging strategies. We need biomarkers, and this cipher is probably the most relevant biomarker actually in this population. Thank you for your attention.
I don't think Paul is joining us online. So I hope the debate will not be as fiery as the last one. And is Ganesh here? Okay. Questions and comments from the audience, please.
Vedant, actually we have got a lot of data on adding hormone to salvage, but we don't have any data on adjuvant with hormone. So personally I feel that there is something is there with hormone that has to be extracted in the adjuvant setting also. So is there any trials or any evidence having hormone in the adjuvant category?
I don't think there is good level 1 data that adding hormones in node negative adjuvant benefits. Or rather there is enough data that it doesn't benefit routinely. So in node positive, there is a hint that there may be, although a lot of people still don't do hormones even in node positive in the West. I think in India the trend is to more give the hormones. Is that your practice also?
Yeah, in the salvage setting we are...
No, adjuvant. I am saying adjuvant.
Node setting anyway we are giving for 2 years.
We are giving. So I don't think there's very good...
So in this trial,
yes.
I think was it not better to have the adjuvant with hormone versus RT with hormone in the salvage setting also? Because we are comparing an unequal scenario.
No, but in these trials, hormone was not given with salvage. In these three, no. The Jeto radicals, they did not have.
No, they had
adjuvant and salvage, but no hormones with anybody.
Salvage also was not.
No hormones. The salvage trials with hormones were there. Another Jeto and a RTOG trial. Okay. That was salvage only or salvage with hormones. There are two different trials. Okay. Sir.
So I want to make a comment in continuation with the previous comment. We see a lot of patients who undergo radical prostatectomy, and after that, these patients sometimes are offered hormonal therapy, and radiation is not considered well in time. So I think when we are talking about what SOGO should be looking at, I think SOGO should be looking at standardization of these practices. There are a lot of, unplanned such things, unplanned such treatments which happen. Dr. Kulkarni, if you allow me, can I ask my question also? Yeah, okay, thank you. So my question is that sometimes we get patients who undergo radical prostatectomy without elective lymph node dissection. So how do we take a call on their adjuvant treatment? And my second question is, any personal experience of using biomarker-based decision for adjuvant radiation therapy or adjuvant treatment after radical prostatectomy?
I would ask one of the surgeons to answer. If the nodes are not dissected, which often they are not dissected, we see in the community, what should we do? What should we do? Is that adequate surgery? If not, can radiation help?
Let me get to the point which Ginil raised. And I distinctly recall Patrick Walsh used to believe, you can correct me, that moment the disease is in the seminal vesicle, it's a systemic disease. See, he was of the opinion that you should give ADT lifelong. I do not know whether that holds today. That was 90s. That was the 90s. Maybe you can answer that.
Yeah. We don't do ADT, of course. I don't agree with Pat Walsh, and I think most people don't on that point anyway, but and many others too, but definitely this point. But the one thing I will say, STAMI had this really nice study which showed that there's two types of seminal vesicle invasion, actually three types. One was direct contiguous invasion, and then the other one was it goes outside the prostate and then comes in the seminal vesicle. And the third is two independent deposits. And the type 3 is truly systemic disease, I think, because that's a separate metastatic deposit with no connection to the parent tumor. But the other two are probably direct extensions, almost like T4, if you'll think. So depending on subtyping of how the seminal vesicle invasion is, you can decide what, how to treat these patients. But it has gotten pretty sophisticated now, with circulating tumor cells and other things, that you have other ways to image these patients to truly determine if it's systemic disease before you make a judgment call on that.
Coming to the question about after radical prostatectomy, not doing lymph node dissection, see, standard of care in high volume center is doing lymph node dissection, even if it is a low grade. You can do a limited dissection, even if it is low risk. One has to do the lymph node dissection. Most of the time you will find negative lymph node in the low risk patient. But the situation which Vinita is saying, this can occur sometime with a low volume center, sometime new surgeon, and then he actually had done radical prostatectomy first or second. But most of the time it is like this. But then how to decide? It's very simple. You do the PSA and take a call from there. If the PSA is negligible, less than 0.2, 0.01, you don't bother for that. If it is high, then you can take on imaging or radiation or whatever, hormone and all.
Dr. Pradhan.
Quick question is on the choice of therapy when you're adding hormone. Is there equivalence on agonist, antagonist on one side and the monotherapy with bicalutamide? Are they equivalent when you use them in your in these regimens?
Okay. Before I answer that or even attempt to answer that, may I just make a comment on what Dr. Rawal just said? Sir, so you're saying if a patient with low risk prostate cancer has had prostatectomy alone without lymph node dissection, it may be okay to observe and see, wait for early PSA rise and then consider. But for high risk, if that happens, would you still do the same, recommend the same thing, or you'd say, let's go ahead, because the chance of lymph node metastasis is much higher, 20-30% at least. Would you not recommend treatment immediately for that? If the nodes have not been dissected.
I'll still see the PSA.
No, we can see the PSA. We wait.
Because it's a very good marker. It will tell you whether it is in a situation where, high risk doesn't mean that lymph node disease is there.
30%?
It may be 70% it is not there.
Okay.
So even if the margin positive, why these trials came radical and all, before that we were advocating don't give adjuvant radiation therapy because 40% of these patients, the margin positive, they don't fail. Because when you can go through the margin, but then you're using diathermy and taking care of the microscopic disease.
Kaushik?
I will just add to add to Vinita's question's answer. One of the things that we do, most of my patients who have undergone surgery and come for radiation, they would have had their pelvic nodes dissected. And depending on the positivity or negativity, we take a call. But if it has not been dissected, then again the PSA, how quickly the relapses happen is what I use. If it is, again, it is not a scientific thing, but it's something our surgeons are together we decided. Early relapse basically portends to a high biological activity and therefore we do it.
One more point, just to take on from what he said. We have to decide that the lymphadenectomy has a therapeutic benefit or is just a staging benefit. And they're the proponents of the staging benefits. They say that, well, if the lymph node dissections, if lymph nodes are positive, this is systemic. So therefore go to ADT. Why go for local treatment? 2 local treatments do not make anything. Instead of that, 1 local treatment followed by systemic treatment. Now, these debates is going on since 90s. We haven't
I
come to
think
any.
Since then a lot of light has been shed on the harms that long-term ADT, certainly permanent ADT can do, and I think one has to weigh that, whether really it's worth giving it. Your answer to your question, the two, sir, Dr. Koneti, you can.
I just had a quick question. With the wide availability of PET scans and so forth, PSMA PET, when do you start using that? Because even if the node dissection has not been done, PSA is now going up. Why not do imaging and then decide what
we do it? We do a PET. Most of us, I think, do a PSMA PET at PSA of 0.3, 0.4, 0.5.
And most of the patients, pre-operatively itself, with the PSA, with the biopsy report, we have a rough estimate of how much is the nodal positivity. We have the nomograms. And most of the surgeons who are operating, they'll have a clear-cut idea what he's going to do with that. And this is an isolated event where nodal dissection is not done. And most of the cases is done.
Yeah, PSMA PET scan is probably useful, but even after biochemical recurrence, if PSA is 0.3, PSMA is not going to pick up all the cases.
30%.
Maybe 20-30% it will pick up. Whereas 70% it may not pick up.
Regarding the type of ADT, those two trials one used 6 months of LHRH analog, one used 2 years of bicalutamide, different continents, different risk groups. In general, I think, put a bottom line to this, if the PSA is around 0.5, 0.7, that is when ADT starts to help. And to make life simpler, we just use 6 months of LHRH analog. The testosterone recovery also happens reasonably quickly in that. Srivatsa.
I have a comment on Dr. Raval's remarks. Sir has said that if the lymphadenectomy has not been done, we will like to wait for the PSA to rise. Now, we very well know in the setting of locally advanced disease, where we have found that all the prognostic factors, they are better achieved if we are adding adjuvant treatment early in adjuvant setting rather than the salvage setting. So if we are going to wait till the time PSA will rise, especially in high risk cases or then we will not going to give the advantage to the patient of that adjuvant treatment. And I think like in other cancers, if the treatment has been done or the surgery has been done incomplete or insufficiently, then I think it's better to go for an
Fine, point taken. We'll have to move on. Srivatsa, I'm sorry unless it's a quick comment without raising another little volcanic.
Just a quick comment. I was just thinking that generalizing ADT in all these patients may not be required.
You're talking of adjuvant or salvage?
Adjuvant and salvage, both settings. Okay. See, if the primary histopathology said that it was a node positive disease, only then will probably ADT make sense. If it was a margin positive disease, node negative disease, may not help.
Thank you. We must move on.
Next talk is on side effects and complications of radical treatment by Saurav. He's a surgical oncologist, Narayana Health City.
He's a uro-oncologist.
I don't know, I started off as a urologist, then somebody told me uro-oncology. I trained, in several big oncology centers, so I've started calling myself a uro-oncologist with some interest in doing other parts of urology. Morning, everybody. Thank you for inviting me. I am no expert at side effects and complications. I have one conflict of interest. I'm a surgeon, so I'll talk more about surgical complications, but I've got a couple of slides on other aspects of side effects of treatment. I work at the Mazumdar Shaw Center, which is very far from here. It is easier to get to Delhi than to my place, especially in this weather and the beautiful roads of Bangalore. I just heard this morning that in Cambridge, they have grown an embryo with a functional heart and a brain. But I tell you, they still can't fix a human attention span. So the background is that I'm going to try and keep my slides very, very, I get really confused with all the graphs and all. So the first thing is, why should we talk about side effects? I think the first thing is we need that understanding so that we can help our patients through this process. It helps in counseling them, and of course, if everything goes pear-shaped, then you've got a plan in your head. So when we meet the patients in clinic and we talk to them, so what we find is if you prepare them well for the side effects, they tend to do better. Even if they're bothered, they cope with it much better. The next one is, what is the difference? We talk about side effects. These are just undesired effects, but they're predictable in some ways. And we as clinicians, recognize this and make a plan for it. complications are undesired occurrences. So, as I said, I'm a surgeon, so, some side effects. We make people incontinent, we make them lose their erections, we can make the bladder necks really, really tight, and then some side effects which we're not aware of. And then there are complications, if as a surgeon you recognize what not to cut, but if you do cut, you can get into trouble. My biggest problem always has been, since I've been doing radical prostates, is that, what is my incontinence rate? And I think the biggest problem is how you define it. So I think a reasonable definition is that you use a pad a day, that's kind of acceptable. And if you look at most of the literature, it gets to 70% at 3 months, and 90% are, reasonably continent about a year down the line. I started as an open radical prostatic person, then lab, then robotic. There are loads of data on there, and I'm quite surprised, and I think my colleagues who have done much more than me will answer that question, whether actually it makes a difference. I personally do think it makes a difference. There's this paper from, unfortunately, these are companies that run the insurance stuff, so they will always show that all are equal. But in real life, I guess it is a bit different, although the PROST study says that it is equal. And I guess partly the problem is that, there's no homogeneity. So if you have people who do 500 radical prostates a year, whether they do it open or lap or radical, they'll have better results. The next thing is how do you, which way do you get to the prostate? So there's very clear data now that if you use the Red-Seer sparing approach, you tend to, give them better early continence, although in the long term probably it evens out. Again, large sort of multi-center analysis, looking at, what happens if you, measure the membranous prostatic urethra. I don't know how you do it. My radiology colleagues may tell me. But apparently the size matters. So every millimeter extra on the membranous urethra on the MRI, and you can tell your patients, well, you're less likely to be incontinent. I think this is a real, this is what actually helps with continence. So people with, if you preserve people's bladder necks or you reconstruct it properly, they tend to do better. This is a huge meta-analysis, 4 trials, more than 2,000 patients, and they tell you that, if you do the bladder neck properly, your patients will do well. And this is what we see in real life, I guess. Preserving neurovascular bundles helps in the short run, but as time goes by, they all even out. And I have absolutely no idea why this happens. In fact, there may be an initial improvement in the continence levels, and then they start to fall a few years down the line. What happens to the erections? Men who are less than 60 have a better chance of recovering their erectile function, no matter what you do to them. It doesn't matter whether you do open surgery or laparoscopically. I guess, because you have better nerve sparing techniques now, robotic surgery probably offers an advantage. So we know that, neurovascular bundles, if you spare them, you have better continence and erectile function. So pre-op sexual function is really important. So if somebody is sexually inactive prior to treatments, they tend to do worse than people who are sexually active. And then, these are the neglected side effects. I mean, nobody talks to their patients about it. I've never personally talked to my patients about this. But apparently it really does bother them. So, there's almost 25% of people will develop this. And thankfully it reduces with time. Now, this is uncharted territory. Vedang and all of you can contribute to this. Dr. Rawal and Dr. Kulkarni and several of us surgeons, were jumping up and down. And this is, this is a 5-year cumulative data. So patients post-radiotherapy, 5% will develop hematuria, 12% will be incontinent, 24% go into retention, and 11% have climacturia. So I don't know. This is data from several studies. Long-term bowel and bladder toxicity, 13% grade 2, 2% at grade 3. I'm sure my radiotherapy colleagues will, be able to tell me better. Second malignancy, not talked about much. Bladder cancers, it depends on which paper you read, but this is a meta-analysis and it shows up to 3 to 4%, colorectal 4% maximum, and rectal tumors 1.2%. I have very few take-home messages. Prepare your patients preoperatively well so that they are less bothered. Open versus robotic surgery, I guess robots matter. That's my personal opinion, and I think loads of my colleagues may agree to that. Red-sear sparing does help for early continence, but in the long term doesn't matter. Bladder neck preservation is the only thing that I honestly feel does help. Pre-treatment sexual function is important. Neglected sexual dysfunction is troublesome, and we should counsel our patients for this. Second malignancies are uncommon, but they do exist, and I'm sure my radiotherapy colleagues will help me to understand better. Thanks.
Thank you, Saurav. Good discussion, very precise. Usually we say that human errors are considered as the third leading cause of death after MI and RTA. This discussion is open for discussion.
So we can discuss some of the things in the panel that is next. So may I request Dr. Kaushik Bhattacharya, the moderator, to start his session. And I must say that we have failed as chairpersons. We have let it go for too long. I apologize for that, but we had a good discussion. May I call the panelists, please? Kaushik, you will call the panelists. Please go ahead.
So, I welcome Dr. Ginil Kumar, Dr. Indranil Banerjee, the panelists are sitting so far away from me. Dr. Indranil Banerjee, Dr. Vinita Goyal, Dr. Tanvir Shahid, Tanvir, Dr. Bharat Rangarajan, Dr. Nilesh Reddy. Okay. So, we surgical oncologists and radiation oncologists tend to fight a lot inside the hall. Outside, we're all friends. And let me see whether I can avoid a fight here. Now, the topic is localized prostate and locally advanced prostate. And just the two previous speeches and the discussion that followed before me that showed that there is no consensus. We know a lot about ourselves, but we don't know the other side of the story. So let me see, I will quickly jump to this. None of these two cases that I'm going to discuss is what I would call ideal, but that possibly reflects how things work out in the community. And I would be happy to ask for your opinions on this one. The first gentleman is a 67-year-old male who on a scheduled health checkup was found to have rather high PSA of 11. Okay, so what would you do at this point? From the audience, what would be the first thing that you would ask once you have a patient like this? What is the first test that you do? Yeah, please, go ahead. You can take the question at will. I mean, I will not point it to anyone.
I can
please, go ahead.
So, as a clinician, usually we have a thorough examination to assess the clinical
Yes,
status.
fair.
Like
Any
rectal
investigation that you would ask for?
Then I'll proceed with a biopsy.
Yes.
Because he has already 11 nanogram PSA. So definitely a biopsy will be the next step after.
Now,
can I make a comment? I would like to repeat the PSA.
Pardon?
Repeat the PSA.
Fair. Okay, let us say for the repeat PSA also is high. I understand where you're coming from, perfectly valid.
So I think we should do multi-parameter prostatic MRI
Yes.
before we start. with-
Now, the doctor who was seeing the patient did not do any of those things because...
I also agree with that.
Yes. The doctor who was actually seeing the patient did not do any of this and he ordered this. So that shows how market distorts your practice. Possibly this patient would have never been advised a PSA PET scan in Europe or America, but he got this. But well, no harm done. The patient shows that prostate gland is moderately enlarged, SUV max of 13. It's a pretty much organ-limited disease in the anterior and the apical part. Then what? That is the time the patient was referred to an oncology center and they got an MRI done, which essentially shows organ-confined disease, a 2A. There is no spread outside the tumor in any form. This was the biopsy. Transcardiac biopsy was Gleason 3+4, grade group 2, and 3 out of 8 course positive. Please?
In the SOGO faculty group, I have sent the publication from PGI Chandigarh, which has been published in radiology, impact factor 29, and we have showed PSMA guided way, guided biopsy can be done on the same day PSMA is being done.
Fair enough.
Yeah, right. So I think that depends on the thought process of the individual, how we practice it. But yes, that has made changes in PGI Chandigarh in practice of biopsy for cancer prostate.
Fair enough. That's point taken. Now, this is a favorable intermediate patient. And what would you do for this patient in that case? I mean, it's open to both the surgeons and the radiation oncologist on the board. We have the question of surveillance, prostatectomy, robotic assisted radical prostatectomy, radiotherapy plus minus brachy, ADT followed by RT, and SABR. What would be the choice for you?
So one more thing I want to add. Usually we proceed with the metastatic analysis before we proceed with the
for this patient.
Treatment.
Well, willy-nilly the patient got the PET scan done and that shows organ-confined disease.
So in this candidate, I'll prefer a radical treatment. Since he is 67 active patient, I'll prefer a radical prostatectomy and my preference is a robot assisted. Definitely my radiation oncologist will also be making a comment on this.
So I think it's fair to do a discussion with the patient and give them the option of both radical prostatectomy as well as radical radiation therapy and help them choose the guided treatment. I expect that the treatment outcomes with radical prostatectomy versus radiation therapy with 6 to 9 months of hormonal therapy are quite comparable. Yes. So I think both the options need to be discussed.
Anybody with a difference of opinion on this one?
Definitely I will be putting radiation as an alternate option because from at least in intermediate category and young patient, I feel that a chance of having a radiation can be opted as a second option.
Okay. So I will tell you what happened to this patient. As far as the data goes, it's a completely toss-up. You can do either. There is absolutely no way that you can choose one treatment over the other as per the guidelines, as per the outcomes. No way. So the typical standard thing that you say, you ask the patient to choose, you depend on what is the available expertise in the institute, whether you have a good surgeon, good radiation oncologist, and that's fair. That's fair. In this case, I would possibly not consider observation because if you look at the PROTECT trial data, definitely any form of intervention will be better than not doing anything over a long run time when the patient is young. So often it boils down to the question of what are the side effects. And if you look at the quality of life of radiation versus surgery, I would say that radiation and surgery offers very, very similar quality of life and you have very little to choose on the basis of that. Though the type of side effect that you might have is different and that is possibly a determinant in choosing the treatment. And this is from Resnick et al., possibly on the highest duration of data, which shows that urinary function is worse with prostatectomy, better with radiation. Bowel function is worse with radiotherapy, as you would expect. Sexual function, after 10 years, all are gone. So therefore, you tell it to the patient and say, well, what is it what you want? What kind of toxicity you want to live with? And let them, choose. Well, in this case, the patient chose radiation. I mean, to be very honest, my choice for the patient was surgery, but the patient chose radiation. But since the patient chose radiation, Vinita, you tell me what kind of dose fractionation would you have liked?
Generally, for last 12 years, I have been practicing.
Can you please get the mic to your mouth?
So we've been practicing moderately hypofractionated IMRT and IGRT, which means 68 in 25 is my standard treatment. And I would not consider this patient for nodal radiation. It will be prostate-only radiation therapy.
Only prostate, no pelvic?
No.
Okay. Anybody else? Anybody else? Is there any radiation oncology else in the group? No. So, okay.
Can I ask a question to Dr. General? I know you are the moderator. Can I ask a question?
Yeah, sure.
Okay. So you said that you would offer radiation therapy as the standard, as the second treatment option.
In this patient?
When I talk to my patients, I generally offer surgery and radiation therapy as two equal treatments.
Yes, yes.
Nothing is second or first here.
No. I will. Okay, I will modify myself.
But my question is, my worry when I refer these patients for surgery are only two. One is incontinence, and the second is the requirement for post-operative radiation therapy. I would like to avoid two local treatments as far as possible. So other than, is there any way of predicting who is likely to have incontinence, not have incontinence?
In this category of patients, why I'm more confident about surgery is because almost all the patient can have a nerve preservation, and the morbidity can be reduced almost to a very low level, even though our combined, put together, our continence rate is maybe close to 5%. This patient, literally, we may not be seeing any incontinence for long term, and erectile dysfunction also can be reduced to some extent, and chance of getting a radiation, I will say in intermediate category, is very, very low, and a lot of patients actually will be having a PSA progression, even if it is PSA doubling time, beyond 2 years, even if there is a recurrence happens. So all these factors put together, the chance of getting a lifetime radiation as a second treatment, I will say, is almost negligible for this patient. And in the side effect, this thing, we can see that the side effects of all radical prostatectomy reduces to such a low level at 2 years. And long-term issues related to radiation increases when the patient live longer.
I get your point. My thought of thinking of surgery for this patient was similar. I thought that the patient is very unlikely to require adjuvant treatment, and being young, I think over time the toxicities accumulation with surgery essentially goes down, and therefore radiation was possibly the second option in this patient. Yes, please.
No, why didn't you add an arm of only brachytherapy? Stone and Stock and Janita Group, Moran.
The reason, okay, I will tell you. The reason that I did not run is because in the setup where the patient was there was no good, option of accessing brachytherapy. That is the only reason. Otherwise, I agree with your point completely. Point again. I will agree to that. Vedant, you wanted to say, please, doctor.
How comfortable are you in this patient just treating the prostate with radiation and not treating the lymph node?
I will come to that. I'll come to that. Okay. So yes, Vinita, your point is perfect. And if I just look at some data, there is a meta-analysis of the non-inferiority trials that had looked at hypofractionation over conventional fractionation, and that shows that without any additional penalty of long-term toxicity, there is no difference in the outcome, overall survival. Therefore, definitely the short course radiation or hypofractionated radiation is the way to go as of today. And CHIP is often the trial that people use. I personally use CHIP unless I think of otherwise when I address the pelvic nodes. And so what do you add RT to the pelvis, Vinita?
So based on the POC-RT data, I would add radiation therapy to the nodes only in the high-risk patient. This is the intermediate risk patients. I agree that Dr. Rawal's question is a very valid question. Had this patient undergone a surgery, he would have had lymph node dissection, while we are not addressing it. But I think the incidence is quite low, and there is no benefit of adding radiation?
So I'm so happy to say that this question has been attempted to answer from India. Though we have strong support of the GETAG and the RTOG trial that showed that there is no benefit of adding pelvic radiation, and that is considered standard of care by most of the guidelines. I was so glad to read the European Association guidelines, which throws a spanner in the works by mentioning the poverty trial, that is one trial that can actually question this status quo, and possibly the dogma created by the GETAG and the RTG trials need to be addressed in a bigger trial. Poverty has its limitations of being a small trial, less numbers, but it has possibly questioned the status quo that was generated by the GETAG and RTG trials. And personally, I do add pelvic radiation. What I do is that I usually treat by the CHIP protocol if I'm not treating the patient with pelvic RT, but if I'm adding pelvic RT, I switch on to poverty trial of 68 in 25. I'm surprised that nobody, yeah?
Kaushik, I would like to...
Please.
So I would completely agree with Vinita here. This is not the patient where there is either evidence or a very strong biological rationale to add pelvic RT.
I agree.
In intermediate risk prostate cancer, what you will do is increase the toxicity.
Yes.
What POP-RT did was in high and very high risk prostate cancer, where the chance of lymph node metastasis is more than 20. In fact, the median was 40%. If the chance is so high, it is going to help. With this 5% or less than 5% chance of lymph node metastasis, I would strongly urge against adding.
Precisely. That is why I showed the CHIP as my choice of treatment in this patient.
Yes.
CHIP as
So
my choice
the
of treatment.
take home would be that for intermediate risk, certainly this favorable, I think this is unfavorable intermediate risk, along with ADT, we would not want to increase the toxicity by adding pelvic RT.
One question can I ask?
Yeah.
In the surgery, we say that around if there is more than 2% chance of lymph node metastasis according to nomogram, we have to do a lymphadenectomy. And why radiation oncologists are not trying to have that criteria for giving a radiation?
So two things. It has been incredibly difficult to prove that pelvic radiotherapy helps even in high risk cancers. Over 40 years it's taken to prove that. Now, when the risk is even 20-30%, now for a 3%, 5% risk, adding pelvic radiotherapy will certainly add toxicity. And so the benefit is unlikely to be there. I'm not sure how much a pelvic dissection adds to toxicity or other things with surgery, but certainly pelvic radiotherapy will add to toxicity. So unless there's a 15-20% risk, the benefit is substantial. You don't want to add that toxicity because finally it may still not improve overall survival.
Sure.
And we also add ADT. That takes care of the microscopic disease as well. So, and you don't do that with surgery.
If I can hasten the discussion quickly, has anyone thought of adding, has anyone thought of doing SBRT in this patient? If you think of it as from the audience, from the panelists.
SBRT is a valid option for this patient. The reason I did not say yes for SBRT is because so far I have not been practicing SBRT.
But would you advise SBRT?
But then there is enough scientific evidence, and I am also a converted person after Friday's workshop, to start SBRT.
Yeah, I will just mention the Amar Kishan's review article on this one, where they have seen 2,000 patients over 12 phase 2 trials, which beautifully showed that in terms of toxicities, and in terms of, outcome is definitely very, very exciting. And in terms of toxicities, it is possibly the least. There is a learning curve in SBRT, there is no denying that, and case selection is absolutely vital. But if you have the facilities and the ability to do it, I think that should be one of the very strong options for this patient. Now, I will quickly move. Obviously, as an intermediate risk, there will be some degree of involvement of the ADT. So, Bharat, can you tell me what sort of duration and agent that you would be preferring for ADT in this patient?
This patient, along with RT, most likely 6 to 9 months of ADT.
Fair.
Mostly 6 months, if 9 months, 9 months. And agent, theoretically not much of a difference between the agents, but any of the agonists, triptorelin or Zoldex.
Is there any data to use ADT with SABR, either from the audience or from the panelists? Anyone can throw light on this? Because this patient would have received ADT if you have given a conventional fractionation. Does SBRT in any way negate the need of ADT in this patient?
No.
So we'll still give ADT?
Yeah.
Thank you very much. So I have less time, I will rush through this, but this I thought was the more important case. Is a 70 years old male, ECOG 1, no comorbidities, evaluated for LUTS, and PS was very high. There was a grade 3 swelling in the DRE, and this patient actually was first advised MRI, even the PSA would have not have been a bad thing. Prostate hypertrophy, predominantly transition zone with border breast infiltration, focal tutu lesion in the right mid and apex shows to diffusion restriction, pyretes 4, raised colon peaks. Truss-guided biopsy was done in this patient, which showed grade group 3. There was no intrarectal, but cribiform was present, and somebody in the morning pointed out the importance of cribiform being an aggressive form of disease. 5 out of 15 cores positive, 30% involvement, no PNI, no LVI. What would you do in this patient now? Audience, please. Panel, please. I would request the other panelists also, yes, please give their opinion. I'm not calling out anyone by name, but you feel free to pick up the mic.
I do a staging walk-up.
Pardon?
Staging walk-up.
Staging walk-up? Yeah. So it's a risk group high. I will come to that. Anybody would offer germline mutation study in this patient? Is there a role of that? Given it's a big disease, high-risk disease, what is the evolving role of germline mutation in this?
With the cribriform form, I think we should offer for this.
Pardon? You will offer? Yeah.
Yes.
Anyone
Is
who...
there any family history?
No.
Actually, there is no family history. We doesn't routinely go for germline.
Good.
But in high risk, there are some evidence to say that there is some benefit by checking the somatic mutation, but we are not doing it routinely unless there is very high or the chance of lymph node.
So certain indications are coming up for germline mutation studies like high-risk prostate with family history, high-risk prostate or big prostate within 60 years of age, history of multiple cancers, and certain ancestry like Ashenka's U, etc. And a list
also the two forms, intraductal and cribriform, are higher association.
Okay. So BRCA2, ATM, CHEK2 gene, BRCA1, HOXB, the multiple types of MMR genes have been advised, though it's an evolving field, but maybe in a few years' time we will have more clarity on this one. This patient underwent a metastatic workup as you asked for, and it showed a large prostate, almost entire prostate is involved. There are small nodes in the pelvis, which are kind of equivocal, and there is no metastatic disease. What would you do for this patient? What are the treatment options?
Is it symptomatic? Urinary symptoms are there?
Let us say it's not there.
Big prostate.
Big prostate?
Yeah, then approach is surgical.
You'll prefer surgery?
Yeah.
Okay. Anybody else?
High-risk carcinoma prostate. I think I would differ here, and I would consider this patient if he has obstructive symptoms, because on the imaging the prostate...
It is there, but it is manageable, yes.
So in case it is required, maybe he would require a channel TURP, plus I would consider him for neoadjuvant hormonal therapy, radiation therapy followed by adjuvant hormonal therapy.
Fair. So these are the two clearly... Yeah, please, Dr. Kiran.
At 70, with this finding, I'll give two options if he is a patient with less comorbidity and going to live for 10 years, because I prefer a multimodality treatment, even though there is no strong evidence for that. But these two options, I would definitely, if I am counseling the patient, what I will say is a radical prostatectomy may be a good option to start if you are ready for a multimodality treatment.
Now, these are two definitely very valid schools of thought. I want to throw a little different spin into this. Why has not anyone thought of ADT plus, abiraterone plus, prednisolone plus RT? As per the
actually, if there is if I am convinced about lymph nodes, I will add abiraterone according to our present protocol in our department. Otherwise, if there is no lymph node, I usually doesn't go for adding abiraterone.
Anybody else from the audience? Would you have any opinion on this one? There is this, yeah.
The Gleason's grade is also 4+3.
Pardon?
Gleason's grade is also 4+3.
Yeah, I mean,
so
why or why not? I mean, you have right now the data from the Richter et al. Trial, which Reinhardt, Richter, I forget the German names all the time. Yeah.
Hi, Dr. Kulkarni here. Hello.
Yeah.
Here.
Please, sir. Yeah.
Sorry. Since you asked, my point is, lymph nodes are only in pelvis, what you said just now. So it is not still M+. So it is still a loco-regionally disease. And to add ADT for this with is no, actually, at this point, no. Unless you are thinking of ADT with radiotherapy. There is no additional. And second hormone therapy, abiraterone, no, at this point, no.
Okay.
The role of abiraterone in this setting has been defined by the Stampede meta-analysis
That's right,
of
Stampede
two
meta-analysis.
trials, which clearly says that either PSA more than 40, Gleason grade group 4 or 5, and T3B and more disease.
Good.
In two of these three risk factors are present, then abiraterone there is a benefit.
Fair. So the reason I'm asking this is that this has suddenly picked up. And the point has been made very nicely by Srinivas, that though there is a benefit, but it is limited to a very, very defined set of patients where the benefit has been shown, and it comes at a cost of toxicity. I had one patient treated recently. The patient was seen outside by Sanjay, you know Sanjay, a good friend. And I will need some more time. You have to please allow me. So the patient did actually, of course, from one patient you cannot draw conclusions, but the patient had significant toxicity out of prednisolone and had to discontinue the treatment. So going back, again, as you have pointed out, all the options that have been discussed are all valid. And we'll come back to the same thing that we did for the previous patient, that you have to boil down to the toxicities. The patient underwent robotic-assisted laparoscopic radical prostatectomy, bilateral extended pelvic node resection in the month of April. And I work very, very closely with a group of urologists who are excellent, and I trust their ability to do the right job, and I was perfectly okay with it in spite of that. But let us see what was the HP report. Adenocarcinoma, GG3, interrectal not identified, cribriform was not identified, EP was identified. There was a bladder neck invasion. It is wrong, I think. It was not identified. SBI was identified, LVI is seen, apical margin was positive, margin positivity at ink margin, 3 nodes positive, PET3B, N1, M0. Bagged and big disease. What would you do? Now, was this patient the right patient for surgery in retrospect?
I will say still that surgery was a good choice, because these things we are able to understand. The pathology we could able to understand better with the biopsy. Otherwise, we would have been thinking about one Gleason 3 intermediate risk, Gleason 3 plus 4 plus 3 plus PSA this 23. But this patient with multimodality treatment will be having a better, probably better survival than compared to.
One question is that, is there any, I mean, today everybody would be doing robotic for this, any kind of surgery, but just to run through this, I will come to that again. Just to run through this, I just wanted to tell you that how, if this case was being discussed 3 years back, maybe this few slides were relatively meaningful. But presently, I think there is no question of not going for robots. There are data which shows that there is no great benefit in terms of oncological outcome. There's a big Chinese, there are multiple meta-analysis actually. And there's at least one randomized trial that shows similar functional outcomes and oncological outcomes, though there are caveats in interpreting the oncological outcome. I like this paper very much, which shows population-based data that is showing that with RRP, there's an increase in the survival on a propensity score matching. Now, of course, there are limitations to population-based data, but this presently, anybody who has a doubt about the RRP being still under investigation, I think that rests with it. That being said, my question was about the margin in this patient. Now, everything else in the patients was basically biological. The margin positivity is the only thing that is treatment related. And we know that once you have margin positivity, the outcomes are really, really bad. Is there any way to predict a patient where you know that there will be margin positivity and therefore avoid it from the surgeons here? Or anyone for that matter?
Actually, we had a study with the MRI in our institute. We made an Indian nomogram about predicting the margin positivity with the MRI and clinical factors. So this found to be very useful. So more the pre-operative prediction is an important factor. Still, if there is small amount of margin, we are using cautery and all this cutting current. So these may not recur, like apical margin, may not recur in majority, but when the pathology is bad, we assume that there is a possibility, and I'm sure that our radiation oncologists will be able to tackle that.
Sure. Anybody else on this matter where you can possibly reject a patient for surgery with the fear of possible margin positivity?
No.
Yeah, please. Sir.
I would say, I agree with Ginil completely. I mean, apical margin is probably the least impactful positive margin, right? If you look at all the margins, lateral margin, basal margin, and serial order of seriousness. I think the other thing too, the randomized trial from Australia of open versus robot prostatectomy did suggest that there may be, at least in the early experience of the physician or the surgeon, margin positivity rate may be higher in robot versus open.
Good.
So that's a factor when you're deciding who's going to be the case. If it's experienced, it doesn't matter.
So one of the things I understand that determines margin positivity...
Dr. Kaushik, you need to wrap up early.
3-4 minutes.
Yeah.
So one of the things is that there are studies, as he mentioned, that can predict positivity of margin, which could be used of PSA, Gleason 6 versus 7, stage 2 versus 3, EPA positive, negative, seminal vesicle involvement, pelvic nodes positive, negative. They are positive predictors of margin positivity. Also, there is another trial that shows high PSA more than 10, blood loss more than 200 ml, T3 stage, and these are the higher risk predictive predictors of margin positivity. And margins are actually high with initial days at least. So margins are very, very important. Now this patient has got T3B and 1M0. We know what next?
Adjuvant radiation and hormonal therapy.
We just heard that artistic metalysis told that there is no role of adjuvant therapy. How do you put it?
This is a very high risk CA prostate.
Anybody from the medical oncologist here? Yeah.
I think definitely, in spite of this is a very high risk prostate, margin positive, but just one margin and 3 nodes positive. He would be, benefit.
So the point I want to make here, as well as the previous two speakers they made, was that people who nod their head in glee after looking at this forest plot are actually not getting the full picture. The artist trial actually includes a lot of heterogeneous studies, and the segment that is not really included are this kind of patients, and you see the patient is already relapsing within a few months. So this patient is going to definitely come back for radiation and possibly a Capra score, although artistic analysis did look at the Capra score and said it is not relevant. But you need to sometimes look at very high risk patients and not be so regressive and offer radiation, more adjuvant radiation, more easily. Anything on this? Anything else?
Quick comment, because there is more than 2 lymph nodes. This patient most probably is recurring at a distant site, can be a metastatic rather than a local recurrence. And the early PSA process also.
Yes.
Can I make a comment about margin and margin and node positivity? See, if you operate these patients, and the margin positivity rate comes down with the experience.
True.
Even in robotic also, as the people have started doing a lot of robotics, so the technique improves, as happened with the radiotherapy also. If you do
Absolutely.
bad radiotherapy, there's a good
Absolutely.
radiotherapy.
I think this is a very important point when people are talking about radiation toxicity, stenosis and all that. I just want to tell you that it totally depends on the experience of the center, as margin positivity depends on the experience of the surgeon.
So and then margin positivity rate, if it is margin positive, just don't jump for adjuvant treatment, because 40% of these margin positive, especially when they are focal, Gleason 3+3, they will not fail. So you just follow them up. About the node positivity, 1 or 2 node, just see if there is extra nodal extension is there. If ENE is there, this patient is definitely a high risk and he may fail. But if ENE is not there, these patients do quite well for a long time before they fail.
Thank you very much. I think if nothing else is there, we'll call. Thank you very much. Thank you all the audience for your participation.
Thank you, Dr. Kaushik.
Bye.
So, going on to the next topic on testis and penile cancer discussion, I request the chairperson, Dr. K.S. Gopinath, Dr. Kumar Prabhu, and Dr. Zishan to please chair the session.
If you have radiation, they're very heavy. You can't have them. Exactly.
Physician.
Good morning, ladies and gentlemen. After a heavy dose of radiation and hormone therapy and surgery for prostate cancer, we'll move on to a very important, useful to large surgical community, especially the testis and penile cancer, where a lot of urologists have forgotten the topic. Though it is a common problem for most of the surgical oncologists, and this session will be very useful. Now I call upon Dr. Amit Joshi to speak on challenges in optimizing systemic treatment for testicular cancer in India. Thank you very much.
Good morning to everyone, and thank you, organizer, for this topic, which is very close to my heart, and we all know that it's a very curable malignancy. So when this topic was given, I was not sure what to, because it looks like to be an essay exam in examination. So what are the challenges we face in our day-to-day setting when we see the testicular cancers? So I think these are some diagrams. This is just tells the story. What these are the real challenges. I think if Gagan and Mahendra are there, they remember that I just forced them to operate this patient in an emergency at around 11 o'clock, and Aman sent me a photograph after surgery around 1 a.m. in the morning. So these are the challenges that what we face in day-to-day setting. Similarly, this is another case few days back we saw in our OPD. So these are the real challenges in oncological, and if we know that the curable malignancy, how curable is this? So just a quick review of the whatever the latest data available with this, and these are the two, this ICGC, this is the updated, this was 10 years back, this was, and this is the latest updated. If you see the good risk, the survival which was there already in the 90% range, it has marginally improved to 96%. Similarly, in the intermediate, there was a slight improvement from 79 to 88%. But if you see the poor risk, where the survival was in the 2011 around 10, this was around 48%, and it has jumped to 67%. So that means the patients who are in poor risk group, 2/3 patient will be cured if we treat them properly. So why? So the question comes: why this survival has improved? The same BP was used 10 years back, and still the survival was low. So the main factor which are considered for improving the survival of especially the poor risk, is the more use of cisplatin per etoposide based regime. Many more oncological centers are there which are treating them properly. And I think from my experience, the most important is the consequent utilization of the post chemotherapy surgery, which is very important. As I will subsequently discuss, we see a lot of large volume disease. So post surgery, so whenever we discuss the patient in JC, we just push to as for this surgery for these patients. These are very complicated surgeries, but still we want to. So I think the one factor which has improved the survival is the post chemotherapy RPLND mass dissection, and subsequently the improved supportive care post surgery, post chemotherapy, increasing use of guidelines and expert center available, the use of multidisciplinary team where the surgical oncologists, medical oncologists. So I think these are the factors which has improved the survival of poor risk patients. So just a quick for the TMS data, it's a 2014 to 17 data. It's around 150 patients we see, and then we analyze the patient who were on our follow-up. So it's around NSGCT, since the survival is mainly, so we focus on this. So we saw around 226 patients out of 333 of NSGCT, and rest were the seminoma. So these are the numbers. The stage 1 in a very less number, around 16 patients were of stage 1, and then all other metastatic group or good risk were 27, intermediate were 37, and see the number of. So if you club the intermediate and poor risk, which more or less behave same, 2/3 of the patient are still in the very high risk group compared to the good risk, and very few patient of stage 1. And if you come to the survival, when we look to the survival, The 5-year survival for as expected for stage 1 was 100%. For good risk, it was still very good with 96%, and intermediate group was around 73%, which was around, these are more or less similar to the international data. But when we come to the poor risk, the survival drastically reduced to the 48%, which in the current series is close to the 70%. So these are the group where we need to do really some work to improve the survival of this group. So the first and biggest challenge in our setting is the advanced stages presentation. Patient present late, by the time they present, disease has already gone to that. So if we look to the, compared to the data of our with the UK data, it was it's 210 to 2014 data. So if you see the number of patients presenting in stage 1, around more than 2/3 are stage 1. And hardly the stage 2, 3 hardly pay. So majority of the patients, what they are seeing in Western world are the very early stage disease. And if you see, only 7% of our testicular patients are in this very early disease, and rest of them are either in the intermediate and poor. So our problem is a intermediate and poor risk group, where the survival has to, the measures has to be taken to improve this survival. And the early stage group is very, very rare because patient comes to late to us. So this is same, the ICGC, when we compared these two numbers with that, the intermediate and poor risk group, these comprises of the around 2/3 of the patient, whereas in the Western world data, it's around the good risk. So even in an advanced stage, they see more good risk compared to us, where we see most of the patient in an intermediate and poor risk group. So the real challenges to us is the majority of the patients present into their general physicians or surgeon. So they mistake as a hydrocele hernia and delay the referral. Scrotal architectomy, when we look to our database of the RPLND, we found that around 17% of patients are still going for a scrotal architectomy. When there is no evidence for that, still a chunk of the patients are going for scrotal architectomy, violating the principle of surgery, upstaging the disease, and that subsequently leads to the decreased survival, delayed presentation. So I think this is the area still as a group, as a society, we need to work on that, and we should make the measures to decrease this as much as possible. So what are the steps we can take to improve this issue? So I think the most important is that the general physician surgeon at the district level, and they should keep emphasizing on the differential diagnosis to keep testicular cancer is one of the diagnoses, especially in the young adult patient. So they should not make it as a hernia and hydrocele and just leave it. So they should be aware that in a young patient, any testicular swelling is not the hernia and hydrocele. You have to do workup. And with the wide availability of the USG, which is available in most of the district places and taluka places, at least in patients who are which are not very clinically fitting into the hernia hydrocele, get a USG and see, and with the availability of the referral tumor markers, I think at every district level. So this area which we can work on, that we should make the general surgeon, general physician aware about this important aspect and need of early detection and the need of the cure for this patient. And the other thing which we can think on, that availability of the, because the other problem which we saw, that even these are the young adolescent males, they usually, because of the social demographic structure, they do not present to the, they hide this testicular swelling and they do not tell their parents and all that. So and we know that in our country, with the availability of the social media, if we can put some of the videos regarding the, and most of the time they have approached for this. So if we make some videos available regarding the self-testicular examination, need to contact, so they should not delay telling to their physician, which may help up in improving the survival for these patients. The other thing which I told you, this is very common scenario in our JC. If you see 5 testicular patient in a post-chemotherapy, 5 will be like this. 5 will be like this, large. So technically any lesion which is nodal disease which is more than 5 centimeters is N3 disease. But if you classify, we see N7 also. So 8 centimeter is N3 and 10 centimeter is. So definitely the survival for a 10 centimeter lesion will be less compared to the 6 centimeter. So definitely that needs some sort of change in the classification also. And similarly the poor risk, anything which is more than 50,000 and 10,000 for AFP beta-ICG, but we see the level in lakhs which presents with the this type of lung metastasis with high beta HCG. So I think some sort of a different category in a classification of a concerning like a very high risk or very poor risk may remove this group, and the survival may look better in terms of this. So what we discuss in our OPD, the adrenaline draining RPLND, which I think Gagan and Aman and Mahendra are there. So whenever we see, we call it the adrenaline draining RPLND. So around 40% of patients require RPLND after chemotherapy, and which is a complex surgery. There are very renowned neurosurgeons are there. They know that doing a RPLND, it's an 8, 10, 12-hour job. So, so this availability of the expertise should be there. So availability of the dedicated uro-onco surgeon and infrastructure. Even the surgeon is ready to operate, whether the infrastructure to take care of that ICU, the post-op care is very important. It's not only the surgery which is important, the post-op care. So that measure should also be. And the other thing which we have observed that around 15% of the RPLND will require vascular cover. So even our neurosurgeon is ready. We don't have that much of a, at least in a government hospital, we need to depend upon the outside vascular surgeon for this. So this also leads to the delay in the overall management. What are the ways to overcome? So this is a very good platform. Training of the neurosurgeon, the surgical oncologist during their tenure as during their fellowship, they should be especially emphasized on the need of this training which are dealing with the RPLND and future prestige. So if we train them while they are doing their surgery, not for the uro-oncologist but for the surgical oncologist, they should be well enough trained to handle these of RPLND. And the other important thing is workshop for in-hand training, simulator training, at least for the neurosurgeon who are not doing very routinely RPLND, but in a year they come across some RPLND. That will also help in gaining their confidence to improve the they take the challenges for this type of RPLND. So these sorts of videos, simulator training, and all this may improve the survival if we train them properly. And just few slides, chemotherapy is quite dose dense, requires adequate expertise, but with the availability of the various medical oncologists, this factor has improved over time. And this is just the data of our around 25% patient will develop grade 3 or 4 toxicity. So fortunately, with the more number of medical oncologist availability, we are still able to handle the toxicity of BP. So 1/4 patient will develop grade 3 or 4 toxicity for management of these toxicity.
Amit, so, how many slides more?
3 slides more, sir. So
running short of time.
Yeah, so the other reason for delayed presentation is the poor result is the chemotherapy completion rate. So around 17% patient is still in 2014 when we saw 17% patient were not able to complete the treatment. So we should make every effort for improving the compliance for this treatment so the patient will complete their treatment. So we try to involve some social worker voluntary organization which they need to talk to the patient, their family, telling them the importance of the completion of the treatment, managing their financial aspect, stay in Mumbai. So the ways to overcome is to form a dedicated social service network for these testicular patients. So the family and telling them the importance of completion, making them all the financial arrangement. So this way will improve the compliance of the treatment for these group of the patient. So I think the teamwork is the key in optimizing the testicular cancer patients, and I hope that in future this number 47% at least we can touch those 60% in poor risk patient. Thank you.
Thank you, Dr. Joshi. Any comments? Jagdish, you are with us from 1977 doing this procedure. Why a medical oncologist from Tata Hospital should get excited to talk about RPLND? And if Murali Kamath would have been there, he would have torn him into pieces. One of the operations taught to all surgical oncologists at TMH in 1977 was to learn good RPLND and good pelvic node dissection. As Amit was telling, it is not a difficult operation. Anybody who works who is interested in cancer, these are the two important procedures. We will do it. Today, the morbidity and complications have reduced in RPLNDs. So, only question Amit did not answer was, after giving neoadjuvant chemotherapy, when we should take the patient for surgery, how long we have to wait. These are the two important. Jagdish, you want to make a comment on that?
Well, what he has given the thing is absolutely correct. It's a teamwork, clearly said that. Now, of course, there was a teamwork. With our times, it was mainly surgical teamwork. But now the teamwork includes medical oncology, radiation oncology. The important point which he raised was when to timing of the surgery. Obviously, the timing of the surgery is depending on the marker levels. One of the points which we used to face then was the non-secretor tumors. I do not know whether that still holds, because of late, ever since last 20 years, I have not been doing too many testicular tumors. But that non-secretor patients would have a primary surgery. And that's what one, of course, the other thing was bone marrow sort of, a rescue was a high dose cisplatin was thought of then, in 90s. I do not know what is the role on that. But this is it. This is it.
I think one comment which I'd like to make about Amit's talk is RPLND, which you said. So this is now has evolved into robotic also.
I know, that's why I was coming to that. We have revolutionized into minimally invasive RPLND procedure. Nobody should carry home the message that RPLND is a very difficult procedure. You need to have a vascular surgeon whenever you are doing this procedure.
I agree with you, sir.
Our fingers and thumb is good enough to control the vena cava.
Gopinath sir, I have a point to make here. Let us also not give an opinion to the audience that RPLND is a very easy surgery. It is done good in high volume centers. Tata Memorial Hospital had the legacy of doing it as RGCI does it. And I think the robotic series, obviously there was a learning curve. There is still a learning curve in those who will begin doing robotic RPLNDs. So I guess it's not a ball game of every urologist to do RPLNDs unless trained for it. That is what Amit was probably trying to make.
Yeah, no, the Ganesh point taken, and that's what I was going to make the RPLND, if it is required, it should be referred to the cancer center or high volume center or tertiary center. The thing I just say that evolving thing in RPLND is robotic, and we are fortunate to have a lot of cases, and because we do it, we have maximum number in the world. Even MSKC, MD Anderson, there is no surgeon is doing robotic RPLND.
Yes.
And when we see in America, there are 10, 12 cases, we have 42 cases when we have done robotic RPLND, but it is in selective cases only, not in all cases. You can define, and there's a small node, maybe having a lot of desmoplastic reaction, he will not be fit for robotic RPLND, but a big node around 5 to 6, 7 centimeter size with less desmoplastic reaction, you can still offer the robotic RPLND.
So the timing for this post-chemotherapy is usually 4 to 6 weeks. We repeat the tumor markers, and most of the time we usually take within the 4 to 6. Regarding the mature teratoma, so what we decide in a day-to-day practice is if the tumor markers are not falling or there is a paradoxical increase in the tumor size. So that means that despite a chemotherapy, we start with the chemotherapy, patient is not clinically improving, the clinical symptoms are worsening, and then we consider. So, but that number is not very common, sir. Mature teratoma, not very commonly we see in practice. So most of the time after completion of 4 cycles, we consider for RPLND.
Dr. Amit, just a small chemotherapy question from a surgeon. I'm here, Anand here.
Anand, yes.
So based on for the poor risk NSGCTs, so what's your take on the JETUC 13 trial, where people tailored chemotherapy started with BP and unfavorable fall in markers switched on to TIP. There's a significant DFS benefit but no OS benefit.
Yes.
But for much smaller DFS benefits, we give 4th and 5th line of chemotherapy. For much smaller DFS benefits, here there's a significant DFS benefit. So why hasn't it really taken on?
So the thing is that if you look to that paper, the toxicity of that chemotherapy in that scenario is around close to 30%. So that is in a Western, but in a controlled environment. In our setting, when we have to deal with the overall, wherein busy OPD, they requires admission, lot of supportive care. So if we lose 2 or 3 patients, whatever the benefit we are achieving in other patient will be negated with that. So
Anand Raja, we will have a discussion during coffee time. Last question from the...
No, I just wanted to make a small comment. From our center, about 8 years ago, in one of the international conferences in SIU, we presented a video and a paper on control of the aorta in the supraceliac area for all these complex RPLND. That makes it significantly safer in difficult situations, and all the vascular injuries, etc., in case they occur, the patient can be salvaged by just controlling the aorta in the supraceliac area, which is something which most surgical oncologists can do relatively easily. We don't need cardiac surgeons for that.
Okay, sir. Thank you very much. We'll go on to because this is a topic we can have a lot of discussion on various aspects of RPLND. We will discuss during the coffee break. I'll invite Dr. Priyamvada Maitre to speak on post-BEP conundrum in seminoma.
So there will be no coffee break. Coffee is available outside.
Okay.
And secondly, plaques for faculty here are available at the registration. Please pick up yours. Thank you.
Good morning, everyone. It's my honor and privilege to stand before all of you as an expert audience. I hope that you will find this talk useful about post-BEP conundrum in seminoma. So the BEP chemotherapy in seminoma, I don't need to tell you, it is a standard first-line regimen for stage 2 to stage 3 seminoma. 3 to 4 cycles are what is recommended by the NCCN. However, post-BEP residual mass is a problem that we see often in our tumor boards. Post-chemotherapy, up to 60 to 80% of the germ cell tumors show residual masses. In the NSGCTs, 30 to 40% of these turn out to be teratomas. 10 to 20% are viable and differentiated GCTs, and 40 to 50% can be necrosis or fibrosis only. However, in the seminomatous histology, there's a lot of desmoplastic reaction and fibrosis, and also there can be a situation of multiple residual masses. These can take up to 1 year to resolve radiologically, and often it is difficult to differentiate the residual masses from viable disease. So the problem basically arises on how to identify the viable disease. There is a high false negative rate of biopsies, which is the standard first line investigation. The surgery in these cases, I don't need to tell this audience, is morbid and difficult, as we were discussing just now. The radiography, that is the CECT, has low specificity for these residual masses. If the size of the residual mass is more than 3 centimeter, there is around a third chance that there could be residual disease. This is from various surgical series. And there is the new investigation, that is PET CECT, about which I'll go in some detail in just a few seconds. There is also some role of biomarkers and radiomics, but in the routine clinical practice, these are not really feasible or practical. So FDG PET-CT is the one modality which has been explored extensively in the post-chemo seminomatous masses setting. And this is the landmark SEMPET trial published in JCO way back in 2004. This was a prospective multicentric trial in Europe, and they looked at post-chemotherapy residual masses in which FDG PET-CT was correlated with either histopathology if the mass was resected eventually, or with clinico-radiological follow-up if the mass was not resected. They also correlated the size on the CT scan, whether it was less than or more than 3 centimeter versus the eventual viable disease in the histopathology or follow-up. This was a small trial of 51 patients, but nevertheless very important in such a rare tumor. So this is how they defined their true positivity and false positivity, and true negativity and false positivity for PET scans as compared to the HPR, which was the gold standard. The results of the SEMPET trial showed that FDG PET-CT outperformed the CT size criteria in these tumors. So if the PET scan was positive, all the patients turned out to have viable disease. That is to say, there were no false positives in this cohort. And the PET-CT also had 100% sensitivity if the size of the residual mass was more than 3 centimeter. So basically, PET-CT was not missing any viable disease. This was their results, and as you can see, the positive predictive value for the PET-CT was 100% compared to the CT size criteria 3 centimeter, which was only 37%. So the take-home message from this trial was that if the FDG PET-CT was negative and the mass was less than 3 centimeter, these patients could be safely observed because the PET scan had a high negative predictive value as well. So when it was negative, it was indeed negative in 95% of the cases. But if the PET scan was positive, then there was nearly a universal chance of viable disease, and the patient had to be recommended for resection if possible. However, how many times have we seen this situation? It was too good to be true. From the various retrospective studies, including this very large retrospective study from the International Global Germ Cell Group, they looked at the similar situations of PET-CT versus histology or clinical outcomes for this residual seminomatous masses. And importantly, they observed that the positive predictive value for PET scan, even with various subcategorizations, was only about 30%. So the investigators cautioned against taking clinical decisions based on the FDG PET-CT positivity alone, in contrast to the SEMPET trial. Now, these are some other studies which have also looked at the positive predictive value for the PET scans, including some data from Tata Memorial Hospital also. And none of the studies except the SEMPET trial could reach the positive predictive value of 100%. The average value was around 30%. So identification of viable disease is a problem. And once identified, how do we treat it? The FDG PET-CT did correlate with the size of the residual lesion, but if there is no PET-CT available and the residual mass is more than 3 centimeters, such patients are usually recommended resection, because if we observe these patients, there is almost a 50% chance of progression. And once this is a recurrent or a progressive seminomatous disease, the 5-year DFS actually drops down quite a bit. But if we resect all of these masses, only about 30 to 40% would end up showing viable disease in the histopathology. And of course, there's a question of surgical morbidity when we are going to resect all of these patients. As Dr. Bakshi was just saying, it is quite a morbid procedure and not to be taken lightly, only possible in high volume centers, and not every patient has access to those. So is there an alternative? Can the radiation oncologist help? Well, loco-regional radiotherapy is logical in this setting because it is inherently a radiosensitive histology. This is an RT-naive setting. The patient has received first-line chemotherapy, but there has been no trial of radiotherapy in this setting. And evidently, the option of radiotherapy, if proven to be effective, would be less morbid than whatever salvage therapy options we have, that is resection or autologous stem cell transplant, or even further second-line chemo, which is often not as effective as the first line. So in the pre-PET era, there was an exploration of the role of radiotherapy for these patients, and this is the landmark study from UK. This was done way back in 1978 to 1990. More than 50% of these patients had a residual mass after first-line chemotherapy. They went on to have either salvage chemotherapy or chemoradiation, which was practice-based. So this was not a randomized trial. And only a few patients ended up getting resection eventually. What they showed was that the site of the residual mass mattered, not the size. And the abdominal masses tended to do better with salvage therapies compared to the masses in thorax or visceral organs. And importantly, most of the relapses occurred in the residual mass. So it makes sense to give some local treatment for the residual mass. Radiotherapy did not improve PFS in this study. This was the take home for so many years. But when we read the fine print, neither did resection. Although only a few patients ended up having surgical resection, it also did not improve eventual survival. Being an older study, the details about radiotherapy doses, fields, and coverage are not known, and also there was not very much detail about the toxicities. But in the PET-CT era, which is where we are now, there is a rationale that the PET-CT can be used to select patients better for loco-regional radiotherapy. Now in this setting, we don't really need a very high dose of radiation because this is inherently a radiosensitive histology, and a lower dose of radiotherapy of 30 to 36 gray, which can be tried for salvage for these patients. And IMRT can further reduce the toxicity. So we have looked at our own patients because this has been a frequent problem in our tumor boards, as I said. And in this retrospective data, we looked at stage 2 to stage 3 seminoma, patients who have undergone standard first-line chemotherapy and had a residual mass in the response PET scan done 4 to 12 weeks post-chemotherapy. We stratified these patients by SUV max 3 and size 3 centimeter, and we classified them as low risk, which was SUV less than 3, high risk, that is SUV more than or up to 3, and a very high risk group which had a higher SUV as well as a size of more than 3 centimeter. This was a cohort of 69 patients, and the eventual selection for radiation was practice-based. It was based on the tumor board decision. This was not a randomized trial. And I would just like to draw your attention to the failure rates and the local failure rates. So when we compared the patients who underwent observation versus radiotherapy, we saw that the radiotherapy rates did better. There was less local failure as well as overall failure in patients who received radiotherapy. Also, the positive predictive value of PET scan, as I told before, was around 30%. Now we can see, this being a small study, we cannot say that it was powered for these endpoints, but there was a difference in the PFS, although no difference could be detected in the overall survival for observation versus radiotherapy. And this has prompted us to launch a randomized control trial in this group of patients. So this is our ProSem trial running at Tata Memorial Center, Mumbai. This is a phase 3 multicentric randomized control trial of FDG PET-CT based risk-adapted radiotherapy versus observation for post-chemotherapy residual mass in advanced seminoma. These are our inclusion criteria. The patients with seminoma stage 2B.
Can you come to the conclusion, please, Priyam?
Yes, this is my concluding slide. Yeah. And these patients will be having a PET-CT scan at least 10 weeks after the chemotherapy with a residual mass and with a SUV max of at least 3. And we would have already ruled out the presence of viable disease by a biopsy if feasible. And the surgery is deemed non-feasible by the tumor board, only then these patients would go on for randomization. They would be randomized to observation versus radiotherapy, 3D CRT conformal radiotherapy of 30 to 36 gray. And this trial has a sample size of 74 patients. They will be followed up with a twice yearly FDG PET-CT. The primary endpoint will be 2-year progression-free survival. The PI for this trial is Dr. Vedang Murthy, and we are also going multicentric with participation from Adyar Cancer Center, RCC Trivandrum, and CMC Vellore. We have already started enrollment on this trial, and till date around 6 patients have been already randomized. So to summarize, residual mass is a common scenario in advanced seminoma post-BEP. Serial FDG PET scans may help in identifying the viable disease. SUV value and size may help in predicting the risk of progression. These patients should go for complete resection if feasible. However, if not feasible, then do consider locoregional radiotherapy for a feasible salvage option, which can at least help in giving good local control and delaying progression. This is only a lower dose of radiotherapy with given conformally. The toxicities should not be too much of a concern. Thank you so much.
Thank you, Dr. Priyamvada. Dr. Kallur, anything you want to add on the role of PET-CT in seminomas? Because she has highlighted it very well, usefulness, and PET-guided biopsies, which you are fond of, can be utilized whenever there is a fibrosis to assess the viability of the disease.
Yes, sir. Especially in our department, we are heavily PET-driven. I will go by what she has told. PET will play a major role in all your prognostication and helps in biopsy. Planning your radiotherapy, definitely it will help. I'm going to talk about the same thing in my next topic. Thank you.
Thank you, madam. We are running short of time. We move to the testicular, from testicular we move to the penile cancers. I invite Dr. Mahendra Pal. He'll be talking on indications and principles of lymph node dissection in penile cancer.
Thank you, SOGO, for invitation. So this talk is on indication and principle, lymph node dissection of penile cancer. So short in the GND or LND we can say. So first of all, we should know about something, concept about the lymphatic of the penis. And the few points are, penile lymphatics, normally cancer does not spread by the escape lesions. Regional lymph nodes, inguinal area, it is not a METS, systemic disease, it's a lesional disease. The cloacat node, it is the junctional node from the inguinal to the pelvic region. Crossover, it is very important thing, penile lymphatics have crossovering of right and left groins, but in the pelvis, there is no crossovering of the lymphatics. Coming to the indication that why we should do it, when we should do it. So coming one by one. So as we all know about that, up to 1/4 of the patient harbor metastatic disease in the lymph node who has a clinically normal inguinal area. And this article also again supports the same thing. Coming to this article proposed and they concluded that wait and watch policy for the inguinal nodes has a higher risk of developing recurrence and reduced survival rate. This paper again say when the patient having a local recurrence or regional recurrence is a patient has a 38% survival rate compared to the 91 who has local recurrence. This article from the Antonio, why it is important because this article is answering most of our questions. And in this paper, the stage 2, stage 3 are the main component of the patient. Around 75% of the patient compromising of this group. And if you see immediate delayed lymphadenectomy, so we can see in the graph, early lymphadenectomy has a better survival rate than the delayed lymphadenectomy. And if we have any positive node in immediate lymphadenectomy, again it has a reduced survival rate. Now comparing when the delayed lymphadenectomy has a positive node, it has less survival rate. Again, another topic, whether it is done later on stage or simultaneously. So again, the next graph is showing that penile surgery done with the inguinal node dissection have a improved survival rate compared to the delayed lymphadenectomy. This article again concluded that early resection of lymph nodes assist with the improved survival rate. So now question arises, can we predict inguinal nodes involvement better than the study or anything is there? So the Ficara has proposed one nomogram which is based on the only T staging of the tumor, and they found that there is a 0.877% concordance of the predicting of inguinal node involvement. Our study from the Tata Hospital and Dr. Keval Patel from the RGSI, they also found that basing on the radio or pathological basis, we can predict the inguinal node involvement. But does every patient needs dissection of inguinal dissection? No. A compliant patient having T1 lesion without LVI and no poor grade, surgery can be omitted and they can be observed. What guideline says? EU guideline strongly recommend to perform prophylactic GND patient who has T1 G2 disease and having palpable inguinal node who are positive on the FRAC. And these guidelines say the same thing. So before addressing node dissection inguinal, we have to stratify the patient as per these guidelines and then go ahead with the GND. Now coming to the principles. What are the principles of every oncological surgery? Are the two, this is to achieve good oncological control and to minimize the complications. So we will go one by one. Achieve oncological control, we should know the template of the nodes, the draining area of every cancer, and so that we can achieve R0 at the nodal part. So for the penile cancer, it is very important to know the anatomical thing. Superficial and deep inguinal node are the first draining nodes as they don't have skip a node. Without that, second line nodes like pelvic node will never be involved. And the most commonly involved nodes are the middle part of the, that is called group of Dessler, group 1, if you can see over here. The 5 zones are there. So anatomical knowledge is very important while performing node dissections. Types of GND, it is a modified, superficial, radical inguinal dissection, and ilium-inguinal when we involve pelvic nodes also. Approach can be open, laparoscopic or robotic assisted. Now coming to the boundaries of the modified and superficial. So almost boundaries are the similar. Only thing is that what is different between superficial and inguinal node is that incision is little bit longer. We remove all stations like 1 to 5 zone, and both the cases we preserve the great saphenous vein. The technique, any incision can be used around the groin, but we should avoid vertical incision because vertical incision can compromise the vascularity of the flap. So horizontal incisions are normally useful. The most important thing to reduce the complication of GND is raising the proper flap between below the scarpa fascia. If we can find the smooth surface below the scarpa fascia, that means we are in the correct plane. If it is not smooth and having some flat globules, that means we are in the wrong plane. Again, the clipping of the lymphatics and the branches of the vessels are important to reduce the post-op complication like lymphoria and the lymphocyl formation and the bleeding. When we do radical granule dissection, as we can see, the femoral vessels are exposed that we have to cover with the sartorius flip, should be done. And again, excessive force for the skin retraction may lead to skin edge necrosis, and that may lead later on flap edge necrosis. So for this, if we have doubt of excessive retraction during the surgery, we should freshen the margin of the skin so we can see the viability. Other thing is that we can use ICG to see the viability of the skin margins. Now, when we have such large nodes and there is good skin defect, we have to need a help of a plastic surgeon, so that we have to anticipate before the surgery so that we can plan accordingly, because once skin is lost, it cannot be reverted back and we cannot do anything. And also, any suturing under tension leads to, again, complications. So what are the complications? Like flap necrosis, wound dehiscence, wound infection, lymphoria, lymphoma. The most dangerous is the femoral blowout. It is a lethal and patient can die before reaching the operation table. And these complications are reported to be 28 to 85% of the patient. Now comparing the techniques, open or robotic assisted. So robotic assisted has little bit less complication rate compared to the open surgery, but which one we should use? It depends on the experience and the availability. These articles are comparing between the robotic and the open, and they found that ecological comparability in these two articles. How to do the complication? So these are the bold things are more important. We have to maintain the proper thickening of the flap, avoid unnecessary raising of the flap and unnecessary detection, clipping major lymphatics, primary closure or reconstruction, don't suture under tension, and if possible, down scaling of the template as per the indication. When do you proceed to do a pelvic node dissection? So as guidelines says, EU guidelines, NCC guidelines same says, the more than 2 nodes having extracapsular extension, and NCN says more than 3 positive node or having the more than 4 positive node should go ahead with the pelvic node dissection. So to summarize my talk, when to do, how to do, how much to do. So we have to stratify the patient before addressing the granule dissection, because some patient we can omit this surgery. We can choose, and based on that stratification, we can do modified superficial or radical granule dissection, and should be done early and must be bilateral. Principle we have to follow, we have to try to complete this principle, achieve this principle, oncological control and maintaining the complication. All approaches, whether open, laparoscopic or robotic, are safe depending upon the experience of surgeon. So at last, whatever indication and surgery we do, our aim should be reflected by the patient's eye, which the arrest of cancer growth and at least or with no complication. Thank you.
Thank you.
Yeah. Thank you. I know there will be a lot of questions going to be on this subject. We are running short of time during coffee break. Thank you very much for your presentation.
Thank you,
the city of Bangalore, Chennai and Vellore belt a high incidence of penile cancer we see. Way back in 1988, we published the first TFL flap after inguinal block dissection to reduce the morbidity. Then, as you was mentioning, excision of the skin and reconstruction is a very important thing. Otherwise, all flap necrosis was a nightmare. So we published 1994 usefulness of TFL flap after inguinal lymphadenectomy. That there we concluded at the time decreasing incidence of lymphedema and lymphoria after utilizing the tensor fascia lata. Another publications of multiple flaps after excising, even the skin is not involved. Because this belt, every surgeon who deals with the penile cancer should have overall knowledge of surgical anatomy and small areas of reconstruction. Thank you very much. We'll go to the next presentation.
Next, we have a talk on neoadjuvant and adjuvant treatment options in penile cancer. May I now request Dr. Ajit Veniyur? Online, okay.
Good morning, everyone, and let me begin by thanking the organizers, especially Dr. Vineet Talwar, for this very kind invitation. Now, penile cancer is not a subject on which, medical oncologists spend a lot of time thinking about. But for all that, it is an important topic, not least because of the psychological impact it has on the sufferers. So I'm bringing regards from the Royal Hospital in Muscat, where I'm currently working. I never knew this, but actually, penile cancer is quite high in India. I can see this incidence as per the SOGOCON report of 2020, and India is one of the countries with very dark blue incidence and very dark red mortality rate. It's surprisingly high. If you see this incidence, in fact, you see that India is among the top 5 countries with very high incidence of penile cancer, and compare that with right at the bottom is Kuwait, the Gulf countries where I work, very low. And this is of course because of the protection afforded by circumcision, neonatal circumcision. It is, of course, circumcision protects it, and it is caused partly by HPV, human papillomavirus, smoking and poor hygiene. So another reason why we should encourage our boys also to take HPV vaccination. Penile cancer is calculated by early defined spread, and imaging is not adequate for detection of this micrometastatic disease. So as I think our surgeons will know, upfront surgical staging of the inguinal lymph nodes is crucial. Once you rule out distant lymphadenopathy, say pelvic lymphadenopathy by PET scan imaging, we should try to stage the inguinal lymph nodes. And unfortunately, again, surgery alone is inadequate. Although you may think it is resectable and you have resected it, you have done a good job, and it has a tendency to come back, relapse in other lymph nodes, eventually become metastatic and cause the death of the patient. So the obvious answer is to add additional methods of treatment, which is of course chemotherapy or radiation. Unfortunately, because of the rarity of the disease, there is very low level of evidence on sequencing, which should come first, whether you should give chemotherapy first or surgery first. So most of the data is either phase 2 retrospective, and phase 3 trials have not been done so far. And once the disease becomes metastatic, the game is usually over, and I will deal with that a little bit later. As you can see from this large data set from Netherlands, more than 2,000 patients, stage 1 to 2, the survival is not bad up to 80%, but once it becomes lymph node positive in stage 3, the outcomes are poor, it drops to in fact 50%. And this is the lymph node positive stage that one must concentrate on and try to improve the outcomes. As I mentioned earlier, surgery alone is not good enough for these patients. So, where can we sequence the additional therapy? One is of course adjuvant, which means you have undergone, the patient has undergone the surgery, now it has come, pathology report in front of you. And the recommendation is that if the patient has positive inguinal or pelvic lymph nodes, that's PN2 or 3, and at the bottom you can see PN2 means greater than 3 unilateral inguinal lymph nodes or bilateral, and that's N2, and N3 is extranodal extension. And depending on the patient's condition, he can receive either just adjuvant chemotherapy or adjuvant radiation or both, combined chemo radiation. So multimodal care. And the standard of care as far as chemotherapy is concerned is the TAP regimen, which is paclitaxel, cyclophosphamide, and systematic fluorocycles. So you have done the surgery, you found a pelvic positive inguinal or pelvic lymph nodes. Please consider adjuvant therapy if the patient is fit for it. This is not best data as I mentioned. This is a multi-institutional study of 4 centers across USA and Europe, of which 43% took adjuvant chemotherapy. And you can see those who took chemotherapy, the median overall survival is almost doubled. If you just purely surgery, it is 10 months, but if you take adjuvant chemotherapy, it is 21 months, which is really an impressive difference. But of course, this is retrospective multi-institutional data, and really need clinical evidence to confirm this. But something to be seriously considered. But if you are smart enough, before blindly going for surgery, you should think of whether you can give chemotherapy after. Chemotherapy or radiation, where speak mainly on chemotherapy. We call that neoadjuvant therapy. The recommendation is that any patient who presents with an unresectable primary tumor, bulky inguinal lymph nodes, or pelvic adenomatous imaging, which usually a PG PET, you should consider neoadjuvant chemotherapy because they have very low probability of cure with surgery alone. And of course, if it is unresectable, there is no chance of resection. So you should seriously consider giving neoadjuvant chemotherapy, which is standard of care again is 4 cycles of TAP. What do you mean by the first and third are very clear. It's unreceptable or there is FDG PET showing pelvic adenopathy. What do you mean by equal lymph nodes? Multi-equal. So NCCN has given very clear-cut recommendation on this. If you can calculate lymph nodes with less than 4 cm with high-risk features in the primary, or any of the others, that means more than 4 cm, unilateral lymph nodes, mobile, bilateral, fixed, all of them, you should go for a biopsy. If percutaneous, if it is negative, if it is positive, then you can go ahead with chemotherapy, but if it is negative, it's preferable to do an excision biopsy. And then, if either of them are positive, seriously consider neoadjuvant chemotherapy, and then of course, go for surgery. And this is the NCCN recommendation. I think it's fairly clear-cut how to deal with the equine lymph nodes. The data on this, there is a phase 2 data from MD Anderson into an entry, clinically staged into an entry renal cancer without distant mets. They gave 4 cycles TAP. As you can see, 50% responded, 73% underwent surgery, and in fact 10% they couldn't find evidence of disease. They were in pathological CR. And the overall survival is more than about 17 months. Like I told you, the baseline, these sort of patients don't do well, survive less than a year. So this is a significant improvement in survival if you treat them upfront with neoadjuvant chemotherapy. There are multiple smart tests. There's a meta-analysis on this, 14 studies, about 400 patients, and the results are more or less the same. Response rate is about 50%, pathological response is around 5%. That means no disease in the specimen that you submit. And the taxane platinum did best. The interesting part is even if the patient didn't clinically respond, they showed stable disease, they still did better than those who didn't take neoadjuvant chemotherapy. So seriously consider neoadjuvant chemotherapy. Metastatic disease, one doesn't immediately say it is game over. We have a patient who is with metastatic renal cancer. He did surgery, radiation, he did SBRT for lymph nodes, he did metastectomy for the lung nodes, lung mets. And he's alive and well 4 years down the line. So even if the patient comes with metastatic disease, especially polycometastatic, very few metastatic sites, you can give cancer induction chemotherapy with again, TAP is the best response rate of almost 65%. There are other options also, immunotherapy is under trial. So just because the patient comes with metastatic disease, don't have to give up. There's still an option. A few of them might actually get cured or long-term survivors. As I mentioned earlier, there are no phase 3 trials, but the phase 3 trial is in progress. It's called Impact trial. I don't go into the details of it, but basically, patients with bulky equine lymph nodes, they are randomized to neoadjuvant chemotherapy or chemoradiotherapy, and depending on the response, they have not got chemotherapy upfront, they get given adjuvant chemotherapy. So this is a large trial, more than 400 patients, and the results are yet looking forward. So I conclude here. So relatively rare cancer and there's no level 1 evidence. But once the lymph nodes are involved, surgery alone does not have very good results. And you should seriously consider incorporating chemotherapy or radiotherapy. As I mentioned, what would you fit these modalities? And the best results, of course, we have to wait for the impact trial. So I thank you very much for your patient listening, and I'll be happy to take questions.
Thank you, Dr. Ajit. We have Dr. Ajit online. If there's any question, we can have a question for discussion. Please, sir.
Dr. Ajit, thanks a lot. It's a great talk. What about impact trial? Any update on that?
No, just recruiting. I think it will take some time.
Say that again, please.
They're still recruiting.
Dr. Ajit, you're not clear. Can
I'm sorry. They are still recruiting.
Yeah, they're recruiting.
It has not been published. The results have not been published.
Now, can I ask somebody or anybody's experience in when you give chemotherapy to these patients? So you have maximum experience in especially N2 and 3 disease. Are you comfortable giving in chemotherapy all the patients? Because not all the patients will respond. So how do you manage these patients?
Sir, response rate is very poor after neoadjuvant chemotherapy in our setting, where we see locally advanced disease even in a younger generation. In the past, we have done the study with Dr. Doval, who used to be here, but response rate is very poor. Surgery is the best outcome results what we have achieved, R0 and other thing. Even those residual disease we left behind some time, we give a post-operative adjuvant therapy, survival figures are not very great. Response to this disease, even with modern chemotherapy, responses are not very good. Only the 30 to 40% response, not more than that. We have not seen R0s like breast and other areas of the whole thing.
So
thank you very much, Ajit, for you. Thank you very much, and I thank Dr. Raghunath and his team of SOGO who invited us to be here to participate in today's morning session. Thank you very much. Thank you.
Thank you, sir. So for the next plenary session, I request Dr. P.S. Chowdhury, Dr. Prakash Ramchandra, Dr. Linu Jacob, I request the speakers to be on time.
Good morning, everyone. So we come to the next plenary session, and that is on PSMA. I have here with me Dr. Kallur, who is a good friend and a very accomplished nuclear medicine physician in Bangalore. I must say one or two words about Dr. Kallur. Kallur is for standardizing imaging protocols and standardizing newer radiopharmaceuticals, Kallur is always first amongst us to do so. I still remember in 2014 when we were trying to standardize PSMA for imaging, trying to convince the clinicians that PSMA is good. Kallur already had a data of about, I think, 50 or 60 patients, which he presented in the British Nuclear Medicine Society meeting, and that was fabulously taken at that point in time. So I think we have come a long way now for PSMA imaging as well as treatment. So what is current and what he has out of his box, he'll be speaking to us, Dr. Kallur. He'll be speaking on current role of PSMA PET-CT, utility and challenges.
Thank you, Dr. Partha. I thank the organizers for inviting me here to talk on role of PSMA PET. I was hearing a lot of talks, some discussions about the PSMA PET scan in one of earlier talks. I hope I'll be showing you some of important things what are happening because of this. These are the clinical scenarios, how it is going to help you. Can we help in initial diagnosis? Can we tell whether it is benign or malignant? Yes, we can. How it will help in biopsy? There was one discussion in the morning. Now you have done a biopsy, proven. Now you want to know whether it is localized or metastatic. Now, after that, what are the therapy options based on this? Whether you want to do only surgery, radiotherapy, hormones, or combination of all these things. How PET-CT is expected to play a role in radiotherapy plan. And after all these things, now next these patients come for follow-up. So you want to assess the effect of radiation or your therapies. Now we want to tell you whether there is a good response, residual disease, partial response, progression. And there is a clinical entity where you might come across with the patients treated elsewhere. They are coming to you because the rising PSA. Now here you have to diagnose whether it is a castrate-resistant local disease or castrate-resistant metastatic disease, because you have different treatment options here. And sometimes the patient might come to you straight away with a metastatic disease only, and this is also PSMA will help you to identify the volume, the metastatic volume or the disease burden, and also once you start treatment, how it is going to help. This was a landmark study in 2012. Until that time, from 2007 up to 2011, I was doing a choline scan because that was the standard at that time. And moment it came in 2012, we started adopting it in our practice. What is PSMA? Prostate surface membrane antigen is highly expressed on the cancer cells, prostate cancer cells, maybe 50 times to about 1,000 times. And we have an antagonist now which will bind to PSMA. That's why you are getting such a high contrast information and better diagnosis. There are 2 PSMAs available in the country now, gallium-68, which is quite popular across most centers in India, and places where gallium is not available, there are some centers do F18 PSMA, basically both do the same. And the cutoff initially were published was around 4 SUV, anything less than that you consider benign or anything more than that is malignant, but we have experienced a lot of problems. This is how. Initial diagnosis. Now the patient comes to you with, say, an enlarged prostate. We do a PSMA scan. We have encountered certain problems like this. I will be explaining you. This is one study published by Professor Baum, and he said it is very good, high specificity. And here is my case where PSA is almost 9 and SU is 6.8. This is benign disease. And biopsy proven prostatitis, but in subsequent we have SUE only 3.4. This is a biopsy reported as chronic prostatitis, but the patient comes with a metastatic disease. So there are problems here to diagnose initially T stages. I will be talking about this later at the end of my talk. Now, why we shifted from choline to PSMA? The same patient here, you are seeing only one metastatic disease. The same patient, we are seeing multiple metastases here. So, and these are all our cases, only head-to-head comparison we were doing. Metastases are there in colon scan, but very next day we did PSMA scan and you are seeing extensive metastatic disease, better appreciated. Next question was specificity, whether it is only meant for prostate cancer. We had one occasion where the patient, we did FDG PET scan for oropharyngeal malignancy. Patient had esophageal cancer. We noticed one uptake in the prostate also. We called them next day. It was a nice opportunity for us. We called the patient next day and did a PSMA scan, and it is seen only in the prostate, but not in the esophageal cancer or oropharyngeal cancer. We were very happy at that time, but as we started accumulating the data, it can go and accumulate in other malignancies also, which I will show you later. Now comes biopsy. Morning there was one talk, whether PSMA scan will help you to do biopsy. Many times you come across patients come with a sampling error. Repeated biopsy can be avoided. In our center, we routinely do this. If biopsy has not been done, just to give an example, a typical 5 o'clock position here, patient goes to sonologist, we know that it is only localized there, put a needle there. So this is how we identify the problematic area where it is PSMA most avid, put the needle there and you are going to avoid the sampling error and you have the diagnosis. Now you have diagnosed, now comes next, local disease versus metastasis disease, because early differentiation between these two is of paramount importance for you. Because in subsequent follow-up, these patients, PSA level higher than 2 nanogram per ml, salvage radiation therapy is almost ineffective after prostatectomy. And stable PSA level in the first 2 years after diagnosis does not preclude possibility of a lethal cancer later. And what are the salient features by this PSMA scan in these metastatic setup? We always found in 84% of the cases when PSA is less than 2.2, 84% of the cases had always one suspicious area. And if it is PSA was more than 2.2, 100% of these cases we always found that there is a metastatic disease or a suspicious area. Now this will also help you to do a proper staging, very easy. PSA 7 here, but you are seeing primary disease here, pelvic nodes and left supraclavicular node. And here is a case where prostate tumor, lymph node metastasis, extensive metastasis, again extensive metastatic disease. And these are the cases which you would have never sent for any scan. PSA 0.07, but we have found out a disease here, metastatic disease. And detection at a low PSA level is very important for you to do proper therapy for these patients. Now we established long time back, there is no correlation between PSA values and the disease burden. I'll show you some cases. PSMA now is the investigation of choice to know the disease burden. Gleason score 7, PSA 7.1, look at the disease here. And we see this type of bizarre extensive metastatic disease in our day-to-day practice. The moment we see a hepatic disease, we know that these patients are not going to do well at all. Their prognosis is very worst. We have seen very bizarre pattern of metastasis, testicular metastasis, penile metastasis, thyroid metastasis, and which would have otherwise never thought of. Many times we get the patients for metastatic survey. These patients would have come from an orthopedician or a general physician. Patient would have gone for a back pain. MRI done, metastasis seen, then search for metastasis, primary will start. We typically, most centers will do FDG scan, and we don't see any other primary. We hunt for any prostatic lesion there. If we see, we call the patient next day and the diagnosis is established. Bone scan is now redundant in most centers. The published review data shows that PSMA PET scan is far superior to your conventional or even F18 PET bone scan. 96 versus 73 or 85%. We were rolling in 2000 until 2012, do MDP bone scan. Then we came out, we started doing F18. We said instead of MDP, start doing F18 bone scan. It is better. Same patients, you are seeing more lesions here. Now, why we don't want to do a bone scan? Because of this. Because we miss marrow disease. So CT scan looks absolutely normal here, and here are metastatic disease. Frequently, whenever you send, so separate bone scan is not required at all now, don't do. And surprisingly, even today, some of your trials, clinical trials are still recommending bone scan. Probably it will also disappear shortly. We frequently see a solitary bone lesions like this. And it will be really problematic for us to stick our neck out and tell, because the disease is very small in primary, one lymph node and straight away metastatic disease. It makes a lot of difference for your patient management. And whenever we see any lymph nodes and one lesion we see like that, we don't hesitate to pronounce that it is a metastatic disease. The next patient group is rising PSA. Now here in 8 months time, the disease progression is there. Now we have done a PSMA scan and you are able to show where is the disease. So here it classifies as castrate-resistant disease. And this is a case where rising trend. We were doing a choline scan earlier. In 6 months, we are not expected to see such an explosive growth here, even though the PSA value is 0.64. Probably we were missing it in the choline scan those days. Carcinoma prostate referred to us after radical prostatectomy. PSA never came down, and we were able to demonstrate an external iliac lymph node. Probably it was there, it was missed in the earlier conventional investigation. So whenever we are doing a radical prostatectomy, please consider PSMA scan. Now the patient you have done, diagnosed, therapy, some or the other therapy done, now you want to assess the response, therapy response evaluation. Now let us see some good examples of a good response to therapy. Extensive metastatic disease, lymph node and skeletal metastasis, on hormones, excellent response, everything has resolved. A case here, a lot of rectal involvement is there, extensive lymph node metastasis were there, on hormonal therapy, PSA drops from 400 to 7, excellent response. You have a good objective evidence here. Now examples of local recurrence. Here again, castrate resistant, we will be able to tell you why it is important. Once PSMA PET scan will also define a phenotype of a disease where presence of PSMA is generally associated with an active but dysregulated antigen, your androgen receptor therapy. Examples here, how it is going to help you in the management, why you have to always consider PSMA scan. This was a patient, our own, that time we were doing colon scan. In between, patient lost for follow-up. Only record shows that PSA 1.5 from 14. But in 2013, the moment I was doing a PSMA scan, gallium PSMA, PSA was 2.3. Then we know that something is happening here. We were able to demonstrate only local disease. It is castrate-resistant local disease. Now you have an option here. You can re-irradiate or you can intervene by surgery also. So this is how a PSMA will help you to do even in these locally recurrent tumors. Now examples of castrate-resistant distant metastasis. There is a study called Stampede where they showed that adding a chemotherapy will definitely help these patients, and PSMA scan was one of the important aspect of this study. And just to give you an example here, our own example, extensive disease, hormone therapy started, it has regressed, but PSA goes up marginally. So if you just see here, very difficult to identify any significant improvement, any significant increase in the disease. But when we see a very close attention we give, we can see that some lymph nodes have increased here and vertebral metastasis come. So we are able to predict that this is relapsing. It is becoming castrate resistant. So at that time, you can go for different therapy. Examples here, even after starting a chemotherapy, the patient has progressed. Patient has progressed here also, first one, second one image. There is sometimes we see different type of responses also. Vertebral metastasis have responded, but the patient is now having extensive hepatic metastasis. That shows that the disease biology has changed. Another example of a disease progression here. And another prostatectomy done, and within 1 year we were able to show that there was some problem here. Patient refused to believe, came back after 1.5 years, there was the same progression in that area. Now how it is expected to change your radiotherapy plan? Morning there was a discussion about radiotherapy, how PSMA will help. I'll just show you. Now you can do a CyberKnife, SABR, etc. These are all our own cases where we are showing a very intense uptake and only limited to prostate. You can use CyberKnife. You can see the radiotherapy plan here, very well localized, and giving high dose radiation here only to metabolically active lesions here, so that you are going to avoid radiation injury to surrounding structures. Bladder you are avoiding and rectum you are avoiding. When you add PSMA data to radiotherapy, and in intermediate group or high risk group, 16% of the time you are going to change your radiotherapy plan. So this is a case where there was a small lymph node which was not appreciated at all. The moment we said that it is seen, the radiotherapy plan has changed. You are including radiotherapy portal in the beginning only. With this, you are going to have definitely better progression-free survivals. This is the case how the radiotherapy plan will change. They were planning for excellent radiotherapy only for prostate. Moment we said that there was a bone metastasis here, that was also treated in the same setting. Now you want to assess your given radiotherapy, how it is working, your radiotherapy. Show examples here. Colon scan at that time we shifted to PSMA. No evidence of PSMA. Radiotherapy has worked wonders here. Excellent response here. Excellent response once again here. And sometimes we see even after radiotherapy a small focus, know what to do. So this is the time when you can discuss in your tumor board, because now even after radiotherapy there is a lesion here, whether re-irradiation possible by CyberKnife or a surgery may be an option here, and we have ruled out any other distant metastasis. This is how a PSMA scan will help you to plan the patients who come with a local recurrence. Now comes to what is called as metastasis directed therapy. Lot of new papers are coming in your peer-reviewed journals. Earlier I used to tell that the PSMA PET may change the way you are going to handle these patients who come with a metastasis. Now I am going to definitely say it will, because a lot of papers are coming now. So many algorithms have come. I will not go into details for want of time. And here there can be, when there is a castrate, it is sensitive, hormone sensitive case, 3 scenarios might come. It may be only with bone mets, it may only with visceral mets, or it may be combination with all those things. And these permutation combinations are there now. In many papers are coming, depending upon all these variabilities, are all based on a PSMA PET scan now. Then the beauty lies in the eye of the beholder. What is that you are going to say that it is oligometastasis. Now more or less most of you say that around 5 number of metastasis, you can still direct radiotherapy only to that and have definitely a better progression-free survival. This is a study published by radiation oncologists called Oriel study. In simply they had divided oligometastatic patients, they treated with only local radiotherapy, and others they did not. And those who received radiotherapy for oligometastasis, they had a better outcomes. This is one of our case which we started doing in 2010. That time colon scan, CyberKnife was given. He was doing fine for almost 3 years. Then PSMA scan picked up one external iliac lymph node. He was refusing hormonal therapy right from beginning. He received radiotherapy only to that lymph node, and in 2015 we said there is one more lymph node has come now. So here, this is when he agreed for hormonal therapy. So 5 years he avoided hormonal therapy, definitely a better quality of life for the patients. How it was possible? It is possible because of what is called as MDT, metastasis directed therapy now, which is going to be reality. A lot of papers are coming. New ASCO guidelines say that you add chemotherapy also along with hormones for metastatic disease, the survival is better. So here they are showing a better survival curves here. This is some of our cases here. Metastasis, hormones given, responded well. 2-3 years down the line, he came with extensive metastasis, again docetaxel response. So this is how PSMA will definitely help you to assess whether your therapy is working or not. Now I have told you all nice things. What are the problems with this PSMA? Dark slide, the dark sides, that's why I am showing a dark slide here. The problem is benign versus malignant. There are other malignancies also which will show some uptake. Hemangiomas, peritoneuma, some diagnosis, I'll show you some of the images. So these are the cases where the patient was, this is our case where there are lymph nodes, patient was on hormone, PSA dropped from this 1.5 to 0.25, but the lymph node progressed. What was this? The patient also had renal cell carcinoma. This was biopsy proven. Later it came out that these are metastases from renal carcinoma. So it is not from prostate. So we have to be careful about all these things. So there are a lot of studies have been done. Many malignancies show PSMA expression. But where is the expression? It is not on the tumor cell. It is in the neovascularization within the tumor bed. Only prostate cancer show the PSMA expression, 12 out of 12 in this study, and all these things there is no expression. So many malignancies can also show the uptake. And this is the case where you will come across with the patients with a very rapidly growing tumors not responding well. And you can see here PSMA is negative, and neuroendocrine differentiation, we have done a Dotronox scan and extensive metastatic diseases in here meant for therapy. Size does matter because smaller lesions we are not able to see. That's why in the early stages, the lymph node, they were saying we were diagnosing 4 or 5. These patients we were doing RPLND, and that disease we are seeing much more lymph nodes than us, what we were showing in the scan. But now with the advent of, this is what you want to know. You want to rule out N1 disease because this has a prognostic implication. With the new imaging modality, you can see here even the 2 millimeter lymph node, you can see beautifully the image here. So small, such a small lymph node also, it is impossible to decide based on the conventional imaging. There can be PSMA expression and androgen deprivation therapy. Sometimes when they are, another 3-4 minutes, can I have? There is a high androgen activity and low PSMA expression, low signal activity on the PET. The moment you give androgen blockade, the PSMA expression can go up, and this is where I am showing you that initially not much well expressed, PSA drops down because of your therapy, but there are more lymph nodes are expressing PSMA, so we have to be aware of these things. Lot of studies are there now in your peer-reviewed journals, all are based on the PSMA now. I will not go into detail. One word about PET MRI. When you are planning a radical surgery, better do MRI of the pelvis for better T staging, because that will give excellent information. You can fuse with the N and M staging of the PET, you will have excellent results. So the best solution for you will be pelvic MRI, N and M staging, PSMA is the best. Theranostics, one word, lutetium and actinium, there are 2 things. These are again based on the PSMA scan. Based on the PSMA uptake, we are deciding what type of isotope to be used, whether we can use lutetium or we can use actinium, extensive metastatic disease actinium, and this is how the patients benefit. And this is one of the famous slides shown by all of us, phenomenal responses with the theranostics. This is one of my extreme cases, a doctor who refused any therapy, treatment naive, He presented with a metastasis. Straight away he asked me to do therapy. I was reluctant to do what he forced me to do. Extensive metastatic disease, primary tumor also, one dose, you can see the response. This is going to be the future. You have to be open for these ideas. One dose, you can see excellent responses here. We are going to come up with endoradiotherapy. This is only one case I have done because I am a dependent specialty. None of you are going to send these cases to me. Very easy. We can just put a drop of radioactivity. This is what is in-house developed iodine 131 1095. We can even add actinium also. Excellent. Why you have to consider, for you surgeons I am telling you, in future you want to do radio surgery for these patients. When we treat like this, you can expect no bladder radiation, you can expect no rectal radiation. It will not cross beyond the prostatic capsule. So if you treat with actinium, the dose delivered is 250 grays. So you can think about it. And yet even urethra or bladder rectum will not get the dose. We do have a lot of research tie-up with the industry and the scientists, and we try to publish all this data in 2015. This paper was never accepted in any international journal. Finally, we had to publish in our Indian journal. Today it is one of the highly cited paper, and it is in your one of the important your web portal. I was surprised to see that this pops up first, because in all these years we have been telling that this is good for almost all 13-14 clinical scenarios you are going to see in your day-to-day practice. So PSMA imaging, is conventional imaging obsolete? I think yes. This is one trial is going on. As per this trial, they have concluded that PSMA scores heavily over conventional imaging. And I request you to consider lutetium or actinium PSMA therapy very early. Don't send it at the end when they are doing very bad, or life expectancy is not more than 3 months. Don't send. We are seeing excellent responses, and I thank all the urologists because you are very early adopters compared to your peers or your other colleagues in USA. In USA, a lot of noise is happening only because now in 2020 it was approved. When we were talking about this, nobody agreed for what we were doing. I'm wholeheartedly thank from my whole organization from nuclear medicine. You have adopted, and I keep telling Dr. Raghunath that your patients in India get the best treatment solely because of that PSMA scan. I thank my colleagues also. Thank you.
Thank you, Dr. Kallur. That was an excellent presentation. Before I open the floor to discussion, I just wanted to ask you one question or tell the audience your views on that. In the initial staging of prostate cancer, there is many a time the reluctance from the clinician side to do a PSMA scan. They say, everyone says that it's only a multiparametric MR is good enough to stage.
I showed one case where multiparametric image they did and radical prostatectomy, they came with a lymph node metastasis. So when you are planning any radical treatment, please consider it is going to change. We have seen n number of cases. My urologists, they love this, they do it. They have their own reasons. Maybe it is not available at their places. But when you are planning radical, I have n number of cases to show that. So radical surgery you are doing, better do this. And you fuse, I told you also, fuse because you need great anatomical details. Fuse PET MRI for the pelvis, you have great anatomical details. But N and M staging, nothing to beat. So that will change the way you are going to practice. Your outcomes will change, and you are mentally also you are prepared. When you are doing radical RPLND, so you know that he has described some nodes in this area. When they do surgery, they may see much more nodes, but at least we'll tell them carefully look at this lymph nodal stations.
So leaving aside the distant metastasis, which you may pick up in a PSMA scan,
even in the primary stage,
in the primary staging and the lymph node staging,
it will help.
Dr. Chaudhary,
how many times have you seen that it could be upstaged?
Dr. Chaudhary, can I make a comment?
Yes.
See, the PET scan in early disease, like before radical prostatectomy, there is a guideline that in low risk prostate cancer, there is no need of doing PSMA PET scan because it is not going to change the treatment. But in intermediate, the best use is it in high risk.
High grade, intermediate and high grade, high risk.
There probably you can plan your surgery according to the imaging And only thing that don't decide the local treatment like radical prostatectomy on the PSMA PET images or the report, because that locally it overstays. It will tell you the bladder neck is involved, the seminal vesicle involved. For that, MPMRI is the best.
Yes.
But for the
I do
nodal
agree.
status, knowing the metastatic disease, oligometastatic disease, I think PSMA PET is very
Yeah,
good.
exactly. I think we should know that what to expect and what not to expect and do the investigation. You're very right in saying that. That's what I wanted to know from him as well.
Other thing which is evolving with PSMA PET scan, the many time you see in a patient when he is feeling PSA only recurrence or having the CRPC M0 disease, or sometime you have isolated testicular metastasis or sometime bone metastasis, isolated lung metastasis. These things are coming up now with PSMA PET scan. I have 2 patients where the isolated testicular mets was there. We did orchiectomy and the PSA.
Yeah, even we had a penile metastasis and we published the data, you will be knowing.
One of the slide you have shown that there was an unusual PSMA uptake at the distant site. What is your experience about the concurrence of the unusual PSMA uptake and the biopsy? Because it will going to decide the sensitivity of the PSMA. Because sometime if you are doing it in a low risk patient or a localized disease, it will going to change the entire treatment planning. So what is your experience about the concurrence of your PSMA activity versus biopsy confirmation of that lesion?
Yes, we published in that paper that that patient luckily underwent a radical prostatectomy. Wherever we were showing a very high SUV, that was associated with a high Gleason score. And these patients are also more prone for high BCR, biochemical relapses. Now, a lot of papers are coming, so you have to always be careful about whenever these patients come with a very high PSA value, they are usually high-grade tumors and relapses are very high.
No. I am talking about the biopsy of that distant side. Like
actually, I will like to respond to Dr. Saurabh's comment, and Saurabh assists what he's talking about. We have a series of cases, unusual cases, where we have seen PSMA avidity at unusual site where you can't think of it is going to be CA prostate metastasis, like breast adenoma, meningioma, like this, paraganglioma, and we have reported and we have questioned, is the PSMA PET, PSA should be removed, means it is not prostate specific.
Yes.
And then
I told you also it is not prostate
so
specific.
I think what he's trying to say, we have proven that this is not metastatic.
Yes.
So what Dr.
I do
Saurabh is
agree.
trying to say, when the lesion is unusual site, yes, you must
have to do biopsy.
Yes, that's
biopsy is mandatory. I showed you also where I can go wrong. Dark slide.
Chaudhary, one more point. I mean, post-COVID, what we have found in last 1 year is those patients who had this COVID infection, their lung shadows are coming up in PSMA as well.
Yes.
And we are not knowing whether these are related to metastasis or something, and that's a really big problem.
Yeah.
And I have to go hammer and tongs with the chest physician, prove me this is COVID, this is... yeah.
Could be a non-specific
So I think in that case, the pattern of the PSMA uptake also gives quite a good clue.
SUV value,
It's
right?
not the SUV, it's the pattern of the uptake and the distribution.
Okay.
So if there are no more questions on the floor, thank you, Dr. Kallur.
Thank you, sir.
And it was a nice presentation.
Thank you, sir. So going on to the next session, I call upon the chairperson, Dr. Jain Kulkarni, Dr. Karthik, and Dr. Ravi. So, a quick word to the chairpersons. The best 3 prize poster the best 3 prize poster presentations has been cancelled. So we'll be going directly on to the second topic. And poster presentations, the prizes has already been announced by Dr. Raghunath yesterday. And the prize money will be given later. What else?
Yeah, prizes we are going to give after this session. We'll be calling all the winners and we'll be giving their prizes. Thank you.
We'll be going to with the second one, sir. Dr. Brindas. Yeah.
Good afternoon. Is it a penultimate session? Yes, I think it is a penultimate session. So Dr. Brinda Sitaraman will talk to us on support group and need for holistic cancer care. I am sure this is the most important. In fact, this will be the most important thing which we are looking at. And currently, that's the buzzword, that support groups are important and ultimate care to the end. I think a very important topic. We're looking forward to, ma'am.
Good afternoon, and first of all, at the outset, I wish to thank SOGOCON, the organizing committee, for being so progressive in their thinking to recognize and give due recognition to a very nascent science, even universally, the science of psycho-oncology. I'm sure in the past 3 days there has been so much of deliberation from all our oncologist colleagues about how to improve, survivorship amongst, our patients. Because of medical marvels, we have come a long way, and for several sites of cancers, today we are both, very vociferously we're able to say we've come very close to conquering cancer. So from living, the transition now for patients is towards survivorship, which is obviously life. And we are addressing a huge population of patients now who are moving into survivorship. Obviously, the goalpost is also changing from a physician's perspective now to what is it that the patients are reporting in terms of their life, as in the quality of life, which is generally a buzzword that we oftentimes use. In the last couple of decades, to be very precise, the past decade, I would say, there has been a surge of interest to understand what is it that the patients are reporting vis-a-vis the medical outcomes in terms of their life as in quality of life. Several articles now are focusing on our care providers and patients are on the same page. Is it something that, what we see is something that patient is not experiencing or is experiencing? So there is plethora of, data pouring forth in scientific literature. For positive time, I'm just going to give just a bird's eye view, just to put things in perspective of where we stand and how dramatically the goalpost has shifted. So therefore, patient-related outcomes is all about what the patient is saying and not anybody else. This made its inroad majorly in clinical trials in the last few decades, but slowly it's making its entry in clinical care. And you'll be amazed to know that even to prognosticate now medically, patient-related outcome factors have been kind of, incorporated in most studies and in most trials as well. So the patient-related outcomes obviously looks at a whole bunch of things. When we talked about symptoms previously, it was only the physical symptoms, but now comes the physical, emotional, spiritual, social, occupational, so on and so forth, all of which have a huge bearing in tailoring treatment to the needs of each individual patient. It's also enhancing the doctor-patient communication, because obviously now the physician wants to understand the patient a lot better in terms of his expectations and so on. And obviously, it has a huge bearing on treatment outcomes as in quality of life. If you look at this report, which is just hot from the oven, you will see how genitourinary cancer actually is the main focus of majority of studies on patient-related outcomes. So the next few slides, I'm just going to kind of spin past you, because the slides are self-explanatory, and like I said, because in the interest of time, I won't be going into details. What is it that we are seeing in terms of patient-related outcomes? Alarming. 64% of urological cancer patients require, mark my words, professional psychological intervention. That's not to discount the 26% require nothing. They have distress or difficulties of some sort, which are kind of manageable through non-professional means. But bulk of patients are crying out there for some help or the other. Specific sites of genitourinary dimensions have been looked at. And if you look at this, systematic review, it's very disappointing. Pre-treatment versus post-treatment, the depression and anxiety seems to stay with patients, and some studies have shown almost lifetime. Patients, through this review, also have reported that their needs were completely unmet, as in addressing intimacy issues, physical concerns, psychological, and even informational needs. Look at body image, which is another important issue that has a huge bearing on overall quality of life and psychological well-being. The news is not good again. Despite whatever techniques that we are trying to use in order to preserve the organ and improve the functionality, somewhere we are falling short of helping patients restore themselves in their entirety. I also talked about how we have gone into specific sites, and interestingly, if you look at this data very closely through the systematic review, 70% of patients with penile cancers seem to report sexual difficulties, which obviously distorts their psychological well-being and has negative impact on quality of life as well. Unfortunately, it doesn't stop at this. It brings about serious relationship issues, including, practical changes, as in, their physical functioning and so on becomes limited. And vast majority of the studies have reported suicidal ideation in patients. Prostate, which is extensively studied amongst all the GU sites, seem to indicate that close to 60% of patients require professional psychological intervention. And this, I'm afraid, I should apologize upfront. There's not too much data from the Indian segment. To be honest, even in the GU, internationally, there are very, very few studies. And what is really so wanting from the Indian setting is the data. It is not, we don't know culturally how exactly, our patients are responding to various therapies and what is the outcome. So renal cancers, again, the news doesn't seem to be very good, be it anxiety, pain, nervousness, whatever, the distress is given. We move to childhood cancers, where children now live to see adulthood. Unfortunately, there seems to be a whole series of issues that they have to live with throughout their, lifespan, distortions of various sorts, including neurocognitive difficulties, which oftentimes limit their, academic and career prospects as well. As this socio-cultural fabric is changing, more and more families are becoming nuclear, and the support network is dwindling. Care providers have come into sharp focus as well as important, people in the overall patient-reported outcomes. And they are known as hidden patients because they're actually patients in the making. And the blue box puts things in perspective in terms of the distress experienced by family members. And the last line, I think, just meets us in the eye. More the patient's impairment, worse is the quality of life of not only the patient, but also the care providers. Therefore, unmet psychological needs brings about distress of various sorts and have far-reaching clinical implications. Patient compliance, dropout rates, and so on is on an increase. And if you look at that red little box there, there is enough and more evidence through, hot area of science called psychoneuroimmunology, which seems to indicate that survivorship is also limited when the needs of patients are not adequately met. Alarmingly, this is again Sears data, which seems to show that suicide rate is alarmingly high in genitourinary cancers. So the implication is not only just for the physician, but also far-reaching implications for patients when their needs are not adequately met. Therefore, while we are so boastful of remission, remission rocks, but the long-term side effects can be very rocky. Therefore, obviously patients are paying a price in terms of whatever they want out of their life. And that price, unfortunately, is a huge price that patients and their families pay. This is no rocket science. If you flip through the pages of medical history, this wisdom was always there, that once we start to focus only on parts, then we are not really reaching out to the patient in a comprehensive way. And I think slowly we are beginning to reinvent the wheel all over again in this recognition that the part can never be well unless the whole is well. Therefore, there is this new area of oncology specialization that is slowly making inroads called supportive oncology. Under this umbrella, psycho-oncology, pain management, spiritual care, psychiatric help, nutritional support, rehabilitation, professionals, all of them come under this particular ambit. The buzzword now is prehabilitation, how to preempt problems for our patients so as to make sure that they do not have too many adjustment issues. In that, what happens is, you're doing the need assessment upfront as and when the diagnosis is made, so that you're able to triage and create a clinical pathway to navigate your patients through various services based on their needs. And what has been found is that embracing the new normal for patients seems to be a lot better than when they are in for the uncertainties that they generally come up with during their diagnosis or treatment. The last bit of this slide actually puts things in perspective in terms of supportive care. Quote, "They liken cancer prehabilitation to a puzzle, with individual approaches put together in combinations that best meet the needs of the individual patient. So it's no longer one blanket therapy for all. It is customized completely, and I must put this particular point in perspective as well. Mind is dynamic, needs are very dynamic, so it is not like there is one protocol that will be followed throughout the cancer journey. It has to be, you have to go on tweaking it based on individual needs." The psycho-oncology service addresses a whole series of issues, but only a couple of things I have put on this slide. Psycho-oncology is not counseling. There are hardcore therapies involved. It requires expertise to handle a whole series of issues that I put forth in terms of data, which is completely backed by science and scientific principles and models. Support group happens to be one segment of the gamut of psychological care that we offer for patients. And support groups are of multiple types. It could be self-help groups, professional supports, informational supports, and so on. Multiple benefits have also been found. Patients seem to restore themselves a lot better and integrate into community because they're all obviously, understanding things a lot better from their fellow patients who have gone through this process. Data shows that 1 out of 4 patients, actually access, just last 2 slides, access the support group on their own, and the red box is an eye-opener as well. physicians seldom seem to recommend patients for support group programs. Therefore, enough and more papers are now suggesting that the unmet needs of patients are multifold, and the red box again meets our eye. Patients reporting suicidal thoughts, anxiety and depression who warrant psychological, intervention did not receive any help. Therefore, NCCN now has mandated guidelines where emotional well-being is now considered the 6th vital sign, mandates recognizing, monitoring, documenting, and treating emotional distress of patients and their families. Therefore, there is a new era in cancer treatment now via supportive care. Bulk of the landscape of cancer treatment has changed, and I very boastfully, and I dare to say this, is because of what psycho-oncology has done in terms of hard data for medical man to take a look and make his, tweak his treatment accordingly. Because no longer a good doctor can rest with this idea of just saving lives, but the life he saves must be worth living. What is the take home then? Transition from living to life with GU cancers is of course distressing, as data indicates. Unmet psychological needs of patients results in distress that have far-reaching clinical implications, including suicide rates being very high. 64% of patients really require professional psychological assistance. NCCN strongly recommends distress management through distress screening. Patient-related outcomes and supportive care seem to indicate that planning and intervention becomes a lot better, and the benefits of psychological intervention and supportive care are multifold. Thank you.
Thank you for an excellent disposition of the facts.
Thank you.
I just want to bring in a point. Back in 90s, United States had these support groups called as USTOO. I do not know what happened to them. When I came back, and I also started thinking about this in talking to when I was in Tata Memorial. And, all these top guys who would have a diagnosis done. And I said, can we start these US survivor groups or something? But the problem was they were so reluctant. Because if people come to know that I have a cancer, I will have a difficulty, my job will go away, so many things. So nobody will really come out. But that's not happening today. Today, younger generation, progeny, is much more open than our generation then. The other thing which comes to my mind is what I'm seeing now in last 10 years or so is a loneliness. Children are abroad. Nobody's here. Why do I survive? Why do I live? One of the partners is gone. So I think these are the points, and this is a great effort. In fact, they should be included in the multi-tumor board, and perhaps our younger generation will accept that this should be included in the MTD.
Thank you, sir. You've made my day. Actually, in HCG, we are part of the tumor board, because all medical decisions are also navigated through, what we give as psychological inputs for, the treating physician. You're absolutely right. I think the whole mental health issue itself, I think there are a lot of my seniors, my mentor is right here, Dr. Gopinath. He will endorse. The beginning of psycho-oncology was very, very tough because of the stigma associated with having to meet with mental health people, because it's a double whammy. Cancer as well as, meeting us was obviously, stigmatizing. But things have changed to a large extent. And because of paucity of time, I didn't delve into how to form the support groups and so on, because I think in this country, the way we are doing with support groups, I'm sorry to say, is not the way we should be doing. Because obviously you have to screen your volunteers for their emotional well-being. They have to be trained. Ground rules have to be in place to make sure that they're not discussing medical issues, financial issues, or marketing their doctors. So it's very, very important that it has to be facilitated via a mental health professional. And I think that can be a talk for another day. Yeah, I'm actually asking for another platform. Yeah, any questions?
I have a question, ma'am. What specific methods do you employ for someone who's having a urinary leak or someone who's on a urinary diversion? and they're facing the problems?
That's a very good question. Actually, while, when I talked about the psychological elements of it and so on, of course, the first thing that I would do is, reach out to Dr. Raghunath to find out, what are the ways and means that we can do something. And if it means we have to involve, sometimes the nursing team to help them understand how exactly to manage this, or, through nutritionists, because again, many times they're not very comfortable drinking enough fluids, or, there are so many myths and misconceptions. From the psychological plane, that is why I use the word embracing the new normal. I think oftentimes the misbelief is when they go through surgery, this I see routinely, particularly with the breast cases. When we say breast conservation and plastic surgeon will be involved, I think they believe somewhere of what happens in Bollywood, or what happens with models. So there is a certain expectation that their organ is going to look very beautiful and very different, and are very disappointed. So I oftentimes tell them that across the continuum is normal, new normal, and near normal. Near normal and new normal, sorry. It's never going to be normal. Some functioning is going to be near normal, and some is going to be new normal. So new normal is a new ways of adjustment, like our own mask. It was a new normal, and now we're all kind of merrily cheating on this, and only when we are in a crowd we wear it. So that's a near normal that we have come to. So these are important things that we need to explain, and sometimes, with some patients, probably they have to just live with this leak, but making these adjustments in terms of timing, when exactly the evacuation happens, how much of fluid do they take, what is their sleep cycle like, and so on. So it is a whole lot of work that goes on actually.
Thank you.
Male support group, we don't even have the female support group in place properly. To talk about, pardon me for saying this, I think this question came up even during our master class, is that very often, even for the psychological intervention, men are a little guarded because of the societal conditioning that man ought to be very bold and he has to be very strong. And of course, when it is cancer, we all tell them be positive and be brave. To be honest, in my 30 years, I don't know what B positive is, barring the blood group. Obviously, we are giving him a very distressing news, and he can't be B positive. But having said that, when you have a one-on-one, they slowly start to open up. And I've brought up this issue of the support group. Not even a group, I'm saying, okay, you've come through this, do you want to meet this new person and help him out? They shy away, they say no. They don't want to be identified, they don't want to kind of, be known as somebody who's gone through this process.
Anyway, yeah, go ahead.
This is regarding support group, and so in Indian context, we do have a different requirement and expectation from support group. We do have a few of them at Tata Hospital where we work in different treatment groups. And we also do have one in GU. I think so Dr. Amit is there. Amit took the initiative to make that group, and it is revealing how it helps our patients. Psycho-oncology is one part of it. Amit, that will be really nice if you can share.
No, I completely agree. I am the, actually in the advisory board of the apex body of support groups. So we have close to 120 support groups in the country.
I think
you're absolutely
that is the
right.
problem, madam. I think there's some sort of a centralization. So what you told that there should be, so everyone is doing in a different way.
Correct.
So some sort of and I think since you are working in this for years, so some sort of a basic guideline that a help group should have this minimum requirement. So that will really help us. And the other aspect of so there are two aspects during treatment and then the survivorship. These are the two different aspects. While the treatment is going on, they have a different thought process. The moment they cured, and that requirement varies from the age. For a young testicular cancer survivor, their requirement will be different, and for an elderly prostate or breast cancer patient. So I think we should make the group which looks into the individual. One person can't be for all. So at some point of time, we have to make the psycho-oncologist as an age or something disease perspective, so they can serve better for that group.
I completely agree with you, sir. Actually, the guidelines are very clear. There has to be homogeneity in terms of the group. disparity of problems and issues as well. In fact, one of the reasons that prompted me to write this book, Not Out Winning the Game of Cancer, is because on a single day it happened. One gentleman came into my office and said, I think chemotherapy is not working for me, and he broke down. I said, any reason why you're saying that? He said, I'm just vomiting like hell, all the drugs have come out, so I don't think, it's touching my cancer. Okay? I finished with him, and then by late afternoon, a lady comes into my room and she's kind of crying and said, what happened? I don't think treatment is working at all. I said, oh, any reason? I read this particular, first she told me that I don't think it's working. I said, well, what happened? No, I'm not vomiting at all. So I said, where did you get that from? So they both quoted the same book, written by a patient. Okay? And I think that was when it was an eye-opener for me that while their experience is important, no doubt, it is very important, their experience need not be my experience or somebody else's, experience. So it's very important to put things in perspective. Like I said, somebody is crying for hair loss and I'm in the group, somebody is talking about their mother-in-law not treating well. Doesn't do any good, right? Or putting a male patient with a female patient or a breast patient with the brain patient doesn't make any good at all. I know that we are running short of time, so this is also an indication that next time you will give us 2 hours to talk. Now just a quick thing about this support group. I had a lady who finished her treatment with breast cancer doing extremely well. One morning she calls and she says, I have a friend who is asking me to come and meet a gentleman who has brain tumor. I just said, first of all, you're not ready for it. Then she said, no, I want to give back something to society. And I said, yeah, but yours is breast cancer, this gentleman is brain cancer. No, cancer means, they're all very worried. Okay, anyway, it is individual decision, and as long as I'm not involved in it, I was okay. She comes back very gung-ho. She called and she said, I'm so happy. It made me feel so good that he's okay to take treatment. So few visits like this, she's been making, visits home. After about 10, 12 visits, one morning she came into my office completely devastated, crying. I said, what happened? She said, yesterday I got a call from this gentleman saying, I want to meet you. So I went to his house. Obviously nobody was at home and he got physical with her. Now, we don't know whether it is because of the brain tumor. We don't know because of, treatment induced, or in therapy we know there is something called transference that happens. So we don't know whether, he just built a relationship of various sorts with her and he was fantasizing. We don't know. So why I'm saying what I'm saying is support groups have to happen under an ambit of safety. It has to be under the umbrella of a hospital. It ought not to be, ought not to make home visits. Even I get calls for home visits. We don't. Because it's not safe for us. So therefore, yes, sir, there are guidelines and I'll be happy to spell those guidelines out, and people have to be trained. And we ourselves as therapists go through something called debriefing practically every day, because it does affect us emotionally. So these are people who've gone through the experience. Obviously, there's a lot of flashback, that comes up every time they're listening to somebody else's misery or suffering, and that is not very kind on them. And particularly fear of recurrence. The moment, a survivor has come back with recurrence, you can see, the whole group starts to shake. So it's not as simple as it's made out to be. It is nice. Therefore, I would say, I think it should be called a social support group and not an emotional support group. They're not a substitute for professional, mental health people. I'm making sure my job is safe.
Thank you very much. We had a great session.
Thank you.
Thank you.
Thank you, madam. So I request the chairpersons to be on the dais. So we'll be announcing the prize winners. Kevin, can I have the slide, please? So we had 3 posters, and the first prize has been won by Dr. Ravi, and he has secured 86.25%. The topic was neurovascular structure adjacent frozen section examination technique of nerve-sparing robo-assisted radical prostatectomy, first Indian experience. I request Dr. Jain Kulkarni sir to hand over the prize, a check of 10,000 rupees to Dr. Ravi Theory. The second prize is won by Dr. Ravi Mohan with 82.5% securing, and the topic was expression of ALDH1 or 2 and ALDH1A3 isoforms may serve as a prognostic marker in patients with variant histology subtypes of urinary bladder cancer. Since Dr. Ravi is there, can I request Dr. S.K. Singh sir to collect the check on his behalf? So the second prize is for 7,500. The third prize goes to Dr. Dhirush Kannan. He has secured about 80%. The topic is neoadjuvant therapy with LHRH antagonists in locally advanced prostate cancer. So the third prize is for 5,000 rupees. Thank you, Dhiran. Thank you, chairpersons. So going on to the next topic, we have uro-oncology care in the next decade, emerging technologies or landscapes of uro-oncology cancers across 3 organs. I request Dr. Deepak Dubey, Dr. Poonam Patil, Dr. Lohit Reddy, to kindly chair this session, please. Yeah, Dr. Lohit. So Dr. Mihir he's in right now in US, he will not be joining, so he has sent the video. So we'll be playing the video. Yeah.
Good afternoon. Thank you for this invitation to present at the oncology meeting in Bangalore. I'll be talking today about enhanced cystoscopy in the diagnosis of non-muscle invasive bladder cancer. The goals of my talk is to talk about the 3 technologies currently available. I'll spend most of my time on dynamic diagnosis, DDT, or also known as
ये पहले हो चुका है. I think in narrowbanding में हो चुका. हो गया. हाँ. This is over. This has been done on first day. There's another talk.
हाँ, robotic surgery.
I think
robotic surgery. That is another talk. Another talk.
Zenith precision.
Zenith precision. Zenith precision.
Hey, Prabhu.
So yeah. So we'll go to the second topic. Chairperson, please note, we'll go to the second topic. We'll come back to the first topic later on.
So I invite Dr. Srinivas to deliver his talk on radiation, dose fraction, technique, what's coming, horizon beyond proton. So we are having a peek into the future.
Thank you, Chairpersons. The outset, I'd like to congratulate SOGO and the organizers of SOGOCON, and thank you for inviting me. In the interest of time, I've been asked to restrict myself to prostate cancer, and I'll be taking you through some of the key advances which are in the horizon in the next few years. If you see, this is a visualization of paper co-citation network. This is from papers published from 2010 to 2019, and you can see that these are the key topics which have been researched on. These are the key terms which are used for most of the clinical trials, and you can see that incidence, hypofractionation, oligometastasis, hormone therapy, prognosis, biochemical recurrence, watchful waiting. These are the a few key, key terms which were used in the last decade, and let us see what we are expecting in the next decade. We have clearly found out now that less is more as far as prostate cancer radiotherapy is concerned. What started as a matter of convenience and cost, as we all learned that it makes sense radiobiologically, that because the alpha by beta is low for prostate cancers, because of that there is a distinct advantage of using hypofractionation. And for those who are surgeons or uninitiated in the audience, you know that conventional fractionation is given over 8 weeks, moderate hypofractionation over 4 weeks, and extreme hypofractionation over 1 to 2 weeks, 1 to 3 weeks sometimes, or even over 5 weeks, depending on the schedule. But the dose per fraction increases from 2 gray, 1.8 to 2 gray per fraction to 2.4 to 4 gray per fraction in moderate hypofractionation, and 6 to 10 gray per fraction in extreme hypofractionation. And we have now clearly found out that because there are large randomized trials which have randomized more than 500 patients and clearly shown that most of these are non-inferiority trials, and most of them have clearly shown that it is indeed safe. That means biochemical progression-free survival in other metastasis-free survival, other important endpoints are similar, as well as the toxicity is almost same with conventional radiation, with increased benefit of cost and logistics and convenience. So based on these trials, moderate hypofractionation is the standard of care. Now, beyond moderate hypofractionation, we have been rapidly adopting extreme hypofractionation as well. There is now a level 1 evidence in the form of hypo-RT prostate cancer trial, which again randomized patients between 6.1 gray into 7 fractions. Of course, older technique of 3D conformal radiation was used, larger margins were used, but it gives us level 1 evidence to say that it is indeed safe and effective in this setting of low and intermediate risk prostate cancers. Now we have more contemporary PACE B as well as consortium of several 12 prospective studies which have shown that extreme hypofractionation is indeed safe and effective, and again can be considered as a standard alternative in low and intermediate risk prostate cancers. So the question now is, which is being explored, is can we go lower than 5? We are giving 5 fractions. Can we go less than 5? Is it 3, 2, 1? This is something which we need to explore. Some have hypothesized that as we increase the dose per fraction, the alpha by beta is also increasing. So I already mentioned clearly that alpha by beta, because alpha by beta for prostate cancer cells is low, there is a distinct advantage of using hypofractionation. But as we increase the dose per fraction, the alpha by beta also could vary, could increase, and thereby nullifying some of the benefits of hypofractionation. And that is why it has been hypothesized that we may lose after a particular limit. But in the horizon is when we are treating prostate only radiation therapy, it seems that it is possible to do less than 5 fractions as well, which is 8, instead of 8 gray per fraction, we are going up to 13 gray, even 24 gray per fraction in certain situations. There are multiple trials. Of course, these are small, some prospective, some retrospective studies, different fractionation regimes, different schedules, but all of them are showing that probably in a research trial setting, it is possible to do these 4, 3, 2, and 1 fraction schedules for prostate cancer in well-selected patients. This is one of the trials which was published recently, 24 gray, single fraction on a single day. It's called a PROSINT phase 2 randomized trial, which is actually a small trial, randomized 32 patients. And what it showed is randomized between standard 5 fraction schedule versus single day, single fraction schedule, that is called single dose RT. So SBRT versus compared to SDRT, and they have shown that biochemical recurrence-free survival seemed to be all right. Of course, this is very, very early, only 3-year median follow-up. Also, the physician as well as the patient reported outcomes, although it showed a little bit of dip, it seems that cumulative toxicity seems similar in both arms, paving the way for maybe phase 3 data, But of course, it is too early for us to adopt these practices. 4-year relapse-free survival is only 75 versus 64% in these both arms, definitely lower in an intermediate risk cohort. And there is definitely some concern regarding transient late urinary flare, which is occurring at 9 to 18 months and almost in 1 out of 5 patients. So there are multiple ongoing trials, but I can see this in horizon that there will be many studies which will come up with 2 fractions, 3 fraction schedule, 1 fraction schedule with various techniques, including brachytherapy as well as more modern external beam radiation therapy. Also in the horizon is extreme hypofractionation. I mentioned 5 fractions only to the prostate. But in high-risk prostate cancers, the POP-RT study has clearly shown that in patients of high-risk prostate cancer, there is a distinct advantage of irradiating the pelvic lymph nodes in PSMA negative population. But can 5 fraction schedule be used for patients who receive pelvic nodal radiation? That is the question which is being answered in few prospective studies. Again, I believe that this is in horizon, that extreme hypofractionation in the setting of pelvic nodal radiation is probably going to be more and more uptake is going to be seen in these particular cohort. And you can see that it seems reasonably safe, although the toxicity seems to be slightly more in patients receiving hypofractionation schedules for pelvic nodal radiation. This was also shown by Dr. Vedang and colleagues from data from TMH recently published in 2022 IJRO-BP. So this is being tested in a randomized fashion now. It's called PRIME trial. It's being initiated at, it's already running since last 2.5 years at TMH. TMC Kolkata has joined, and we are very happy to say that our center, Apollo Proton Center, also has joined this randomized trial, and hopefully will contribute some patients to this trial in this setting, whether extreme hypofractionation would benefit patients of pelvic nodal radiation. In the horizon, I also believe is moderate hypofractionation in the post-operative setting. We've always been adopting moderate hypofractionation as a standard in radical setting when the prostate, for intact prostate. But can the same be done in the post-operative setting? I think there are small, multiple prospective and retrospective studies. Too early to say whether moderate hypofractionation is safe. But there is some indication that this is something which is a possibility. Radicals RT, which is a randomized trial between adjuvant and salvage radiation, also have used hypofractionation schedules, although they have not published results separately, but it seems safe and effective. There is a NRG GU003 trial which is ongoing, which is randomizing patients to conventional radiation versus hypofractionation schedule. So I believe this is also in the horizon that we will be using more moderate hypofractionation schedules in the post-operative setting. We all know that there's a lot of prostatic motion, both intra-treatment, during treatment. Also there is prostatic deformation between interfractions, and there is an issue of setup errors. And we know that the volume is 4 by 3 pi r cube. So small changes in margins will lead to large changes in volume of irradiation. And higher the margins, higher is the toxicity to the normal structure. So can the margins shrink is a question which is being answered in the next few trials. There is a limitation of conventional image-guided radiation therapy. We know that IGRT is a standard way, but there are some limitations as well. Because we use CT-based planning, and when we use MR for fusion, there could be some accuracy issues when we use CT and MR fusion up to 1 to 2 millimeter. And cone beam CT, you can see it is not extremely, doesn't have a good soft tissue resolution, and real-time monitoring is not possible in all the settings. Tracking fiducials, yes, it is possible, but we cannot track the OIR. So there is some limitations of conventional IGRT, and that is why again, I believe that this is in the horizon, that MR-Linac could make an impact in prostate cancers as well. There is data to say that we can shrink margins tighter in even no margins, but of course it needs more prospective validation. Online adaptation is being performed, and this is data from Netherlands, which has shown that nearly 97% of their daily treatment plans undergo online adaptive radiation therapy. So this is something which is in the horizon. There are multiple ongoing clinical trials on MR-guided adaptive radiation therapy. It is called, there are 2 trials, which PRISM and Momentum, which are basically developing faster, easier workflow. But there is also a phase 3 randomized trials of conventional IGRT versus MRI-guided IGRT, a primary endpoint being acute grade 2 toxicity, which is called a Mirage trial, which is ongoing right now, which will answer this question whether MR guidance is better for our patients. Also in the horizon, of course, probably not in the horizon, it's already being practiced in many centers in the United States, but not yet routinely available in India. But I'm sure, again, this is something which we will use more and more often. Absorbable hydrogel spacer, there is a randomized trial which shown that it is possible to do it. There is a consistent gap which we can create between rectum and the prostate. The quality of life seems to be slightly better. There is improvement in sexual quality of life and other urinary quality of rectal GI quality of life in patients undergoing hydrogel spacer. But obviously in India we will look at cheaper alternatives. Hyaluronic acid has also been shown to be a good spacer material, and there is some data, not randomized data, but there is definitely a data which is a cheaper alternative to space OAR, which can be used, and this published few years back shown that similar results like hydrogel could be obtained on a space of maybe not 1 centimeter, but almost 1 centimeter can be achieved even with hyaluronic acid as a spacer. The next question comes is the basis for dose escalation. So there is some advantage of dose escalation, but there seems to be a plateau. There are increments in 10 gray. There is a definite increase in the biochemical progression-free survival, but there seems to be a plateau of the dose. Similar, this is a recent meta-analysis of all the randomized trials. You can see that there is, the curve has a big slope, but it flattens as the dose increases. So there seems to be a plateauing of dose-response relation. Brachytherapy dose escalation also has been evaluated in Ascend-RT up to 115 gray. And although there is significant jump in biochemical progression-free survival, there is no benefit as far as overall survival, prostate cancer survival, as well as metastasis-free survival. And of course, it has led to significantly higher cumulative grade 3 GU toxicities of over 19%, which is definitely so. So essentially, so far on dose escalation is you cannot do dose escalation as a routine unless we are able to prove that it improves biochemical progression-free survival without additional toxicities. If it comes at additional toxicity, it is not worth going in because it doesn't improve overall survival. But that is why it's been conceptualized that smarter way to escalate the dose is probably a focal dose escalation. Instead of giving whole gland dose escalated radiation therapy, if you enhance or increase the dose only to the prostatic, the prostatic lesion, there could be benefit. And this is a phase 3 randomized trial for MRI delineated DIL dose escalation up to 95 gray. I'll take a minute with permission of the chair. There seems to be a significant benefit in terms of biochemical disease-free survival, and there seems to be some benefit as you increase the dose to DIL. There seems to be better progression-free survival without adding any toxicity. So the condition was met, and there will be more and more data emerging from this concept and how to define DIL. Whether we can do hypofractionation, not just moderate, but maybe even extreme hypofractionation is something which is being explored. So 3 key radiation questions. I'll end my slides with 3 key radiation questions regarding dose escalation remain unanswered. Is there a role for dose escalation in the setting of systemic therapy intensification? Dr. Amar Kishan showed that there could be 2 waves. So with better and better systemic intensification, there could be benefit of dose escalation. This needs to be verified and this needs to be tested. Dose escalation in the post-prostatectomy setting, we definitely know that in low-risk population, those where there is only microscopic disease, no visible discernible disease, there is no advantage of dose escalation. So is it, if we see something on PSMA PET, do we have, this needs to be answered, whether is there a role for dose escalation in patients who have visible residual disease after prostatectomy. Also in the horizon is the PSMA PET integration. In almost all settings of prostate cancer, it is going to make a big impact, and we will redefine and re-explore the advantages of using PSMA PET in each setting in better clinical decision making. Of course, our interpretation of older generation trials is going to get a lot complicated because of the introduction of PSMA PET, but it will be far better, I hope. So in summary, I believe that prostate cancer radiotherapy in Horizon, probably we will be treating faster, we will be seeing better, we will be going focal and probably higher. We will be using PSMA PET for key decisions, and of course there are many others in Horizon which are beyond the scope of dose fractionation and this talk. Thank you very much.
Thank you, Dr. Srinivas, I think for an excellent talk. I have one question. So I think we as radiation oncologists have caught technology and we've evolved over the past decade. And now we are moving away from conventional fractionation to hypofractionation. Unlike the medical oncologist, we have not caught hold of genomics, the proteomics or the metabolomics. So what do you think in the next few decades, how are the radiation oncologists going to use genomics in customizing radiation treatment?
So it's a very good question, and I agree with you that there is a need for that. The radiogenomics will play an important role in, as of now, we are not differentiating patients based, the dose and fractionation is not changing, but the decision to give or not to give, or even probably volume of disease is definitely going to come with, we already have the Decipher scores which are available in the adjuvant setting, even in the radical setting, there is some benefit of using Decipher scores. As of now, the availability and access to them is very limited. I'm sure, I think you are right, absolutely, that is also in the horizon, that we will use genomics in clinical decision making in radiation oncology for prostate cancers. Maybe we need to have a cheaper alternatives, more robust validation in our context is also needed. But I think the next decade, I'm sure we will have some solutions to that as well. Thank you for pointing that out.
Yeah, so we'll go in with the next.
One sec. Dr. Deepak Dubey is unable to come. He is held up for some reasons. So I request Dr. Girish Nelvegi to chair on his behalf. May I? Yeah. Thank you. So we'll be playing that Dr. Mihir Desai's.
So the first talk.
First talk, yeah. Thank you.
Good afternoon, everyone. Again, I appreciate the opportunity to present at the Uro-Oncology meeting in Bangalore, and thank Drs. Raghu and Bakshi for this kind invitation. What I'm talking about today is the role of artificial intelligence, especially Uro-Oncology, and it's a broad topic, and I'd like to give a little glimpse in the next 15 minutes on how this is really impacting day-to-day clinical practice. Artificial intelligence is now gaining momentum. There are, many thought leaders in medicine who are really involved in really helping this develop. But it's certainly not a new thing, even though it may be a buzzword right now. In fact, way back in the 1950s, there were editorials that says that machine and medicine can help by if machines are able to think. And so artificial intelligence has been going on since then, but it was not until 2012 where the dropout return technologies were available that actually made it scalable to the user, to the end user. You don't need to be in a sophisticated computer science lab to create outputs. Now there are commercially available applications that can help you do many of the AI applications. Just a brief bit on terminology, because there's a lot of confusion and mix up here. Artificial intelligence is the overall umbrella. Anything that you can make a machine become more intelligent like humans, is the field of AI. Machine learning is a subset of AI where algorithms, as data is inputted, are created to improve outcomes. And as more data is included, the machine systems make the algorithms better and better. Artificial neural networks are a type of machine learning with multiple nodes, somewhat like how the neuronal connections occur in the brain, and that's why the terminology. And then deep learning uses multiple layers of neural networks to give us the more sophisticated outputs. And machine learning algorithms are that. That means that they have the ability to improve the more the data that you enter. And so what you do is you enter a set of predictors to get certain outputs or target which are the outcomes. The process of creating this algorithm is called training of the data. And then once you have a trained data set and algorithm created, you use separate data called the validation data set to make sure that it works in different formats. And machine learning can either be supervised, whether it is a person who's actually supervising the annotation, etc., or it can be unsupervised, whether the algorithm itself makes those differentiations. There are obviously multiple applications in medicine and oncology. We briefly touch them with examples. It's impossible in this time frame to go into everything, but ranging from diagnosis to predictive modeling, like creating risk calculators, precision medicine and genomics, analyzing big data sets, research in clinical trials, surgical AI and AI-assisted surgery is another total field, and then computer vision, which has already been present in our day-to-day life, is now getting its way into medicine to various applications. Let's talk about diagnosis. For example, AI can be used in improving radiographic diagnosis. So this is a study combined with Case Western and Mount Sinai in New York, which looked at adding AI algorithms to currently available neural networks as well as fire scoring to look at the diagnostic accuracy of predicting clinically significant prostate cancer. And by adding clinical data to deep learning algorithms, the area under the curve could be improved to 0.81. And they also found that there's also improved the ability to predict biochemical recurrence-free survival. Another area where AI can be used for diagnostics is in pathology studies. Now here you do need some kind of a computer vision software, but the way this is done is that first you have a trained pathologist that looks at slides and annotates various aspects of blood vessels. For example, in a prostate cancer example, in normal prostate gland, various lesions, patterns, smooth muscles, etc. And once you create these annotations, you can create a model, and then you start entering data into it, and the model gets refined, and then you also validate it by comparing it with a pathologist. In a recent meta-analysis, they found that the area under the curve for detecting just detection of prostate cancer was as high as 0.99, but of course the sensitivity goes down when you're trying to differentiate between these scores. So there's still some opportunity of work there. For example, certain things like uniform patterns identification is fairly high in this. One area where, in fact, AI is almost critical, and without that it's impossible to do, is for genomic studies. So whatever your source of your genetic material is, whether you do whole exome, genome sequencing, exome sequencing, or RNA sequence, or even proteins, these are hundreds and thousands of mutations. And so to be able to accurately associate these mutations with certain disease states does require AI. And so genomics is almost dependent on data science and AI. And so this transcriptomics, which is a field of correlating various gene expressions and mutations and protein expressions to clinical disease states, is one of the futures of oncology, as we all know. And at the end of it, it's not just one data source, but AI also has the ability of combining, for example, pathology data, clinical data, genomic and molecular data, radiological data, and thereby give more personalized risk assessment tools or treatment suggestion tools, for the clinician. And so the whole idea of precision medicine requires this sophisticated data science methodology. What about enhanced computer vision? One field that has really used this is radiology. This is one software called DenseNet that is able to automatically segment the prostates. For example, when you're doing MR or some fusion biopsy, if you were to manually segment the prostate into the total prostate, which is the peripheral bone, which is the central bone, it takes a lot of time for the radiologist. But these enhanced computer vision technologies are able to easily segment this automatically. In addition to this anatomic segmentation, they're able to also appreciate lesions. For example, in this case, the very large lesion on the T2 image, and you can see the corresponding image of the diffusion-weighted sequence as well as the ADC map. So, again, AI can help hold these in fairly well. How good are these? This was a study where in 100 cases, they studied the output of the radiologist assessment alone versus compared to a radiologist with AI. By adding AI, there was a better improvement in detection of greater than or equal to pi score versus less than 4. The intermediate oncologists also improved by adding that to intelligence, and the reading time was also reduced by. So I think adding AI and giving that to the radiologist as a tool will help. Of course, I'm not going into the detail of all prostate cancer studies, but I'm going to review, I think, radiomics and using machine learning tools for that. Within the work from my lab, I've really done a lot of work and published a lot on this. So instead of the standard format where you do a CT, identify small renal mass, go to surgery, look at pathology, get a diagnosis, there is a step in between where you can look at a mass not just as enhancing, not enhancing 3 centimeters, 4 centimeters. We usually get a full 3D voxel map of the entire tumor in all phases, and then you can do a variety of things. The important clinical questions that radiomics needs to address is this benign malignant, number one, and to subtype to malignant cancers, and as well as to detect, is this a grade 3 or 4 lesion? Is this likely to be upstage to PTP, in which case I might more often not do a radical nephrectomy. And so with the radiomics workflow, you first get the renal mass, the 3D mapping of all the phases, and then each of these data look for density, intensity, ecodensity, and again, the 3D space, not just a small area of interest. You look at the volume, the shape assessment tools. I'm not going to detail that, and they can actually quantify the exact shape, even though it's not a sphere. And you can also look at certain radiomic features like 3D enhancement characteristics, texture analysis, cluster analysis, fractal analysis. And based on these, you can then add layers of, if you have a biopsy from that, you can add genetics, pathology, epigenetics, and their demographic data to get, extraction of minor features. And so these are the technologies that might help you get a score that says what is the probability of this being cancer or not cancer, what is the probability of this being clear versus stability. And I think this is where the clinical value is. Predictive modeling is clearly based on these machine learning algorithms, and in fact, using these off-the-shelf softwares, we are able to actually compare different, for example, in this case, they came up with the survival quilts prostate cancer predictive model, and they want to compare it to the other existing models which will predict memorial slope creating, plus also the AUA and the SCN tool, etc. And you can easily plug these in and get comparison features to see which ones outperform what. And so I believe that creating novel risk calculating tools using artificial neural networks or AI machine learning based technologies is going to be very, very helpful. I think one space that we are at USC very much interested in is surgical training and automated surgery. Of course, automated surgery is going to be the future, but currently using artificial intelligence for assessing proficiency in surgical skills. It is one of the things that Andrew Hung in our lab has really taken to score. Now, for instance, those of you who have been on a Da Vinci simulator will know that you can do certain tasks and you get a score. That's an output, which is easy to know. Did I score an 80, and now I score a 90, I'm improved. But what about when you're doing a procedure? It's the vesical anastomosis in a model as well as on the right side in a vision. Now, when I'm doing this, how do I assess surgical competency? Now, there are these gears tools that are overall skills tools. But there's really no good way of assessing competency currently. So what we have is this black box, which basically tracks the kinematic movement and event data of the instruments. It just tracks how each of the instrument goes, how many times it flashed, how fast you move the instruments, etc. Plus you have real-time surgical video that you can use to correlate it with. And so using these black box kinematic data, you can create what are called as automated performance metrics. So for example, just if you were to graph out how the instruments move between an expert and a novice, you can see the expert is a little bit more focused in a narrow space, very few extreme motions, while the novice is kind of all over the place. In one study, we looked at predicting length of stay, and we found that the the automated performance metrics to improve our ability to predict this as a clinical outcome. And now the next study that was published was predicting urinary incontinence. So we took clinical pathological 16 parameters like age, BMI, etc., stage, and then 41 of these automated performance metrics to look at the outcomes. And one of the APM, which was needle positioning, actually outperformed quite a few of the other clinical parameters. I'm not saying that this is the absolute truth, but just to say that this may be a good surrogate for clinical skills and proficiency. And so this is something that we are absolutely focused on. As a next step, we are actually now going on to doing actual surgical movements. So for example, suturing is being, you break it down into the various steps of suturing, like needle positioning, entry, etc., and then the computer vision is able to actually, detect this. So once you have these steps identified with the surgical videos, you have crowdsourced or expert annotation of these videos for all these various domains and subskills, and then the system keeps learning to hopefully make it automated to be able to assess the confidence, but also to see if this correlates with vision outcomes. I think there's also a huge role of AI in our day-to-day lives as a surgeon. So when we create electronic medical records, when we're doing documentation, when we're creating reports, when we are sending reports to insurance companies, to other physicians, AI can help reduce our burnout rate and improve efficiency. So for example, one clear thing is speech to text. Nowadays we never almost type. We always dictate, and the machine learning for medical terminology will keep improving as you correct it. And the speech to text now is almost perfect. I almost never have to correct, even with my accent. And so I think this is one example where AI can be used, for example, creating billing documents or scheduling documents can be all automated and sent, and that's where AI is at. Final thoughts, AI is here. Now, whether it is a self-driving car or in medicine, it is going to affect all parts of healthcare and our lives. The most important aspect is the AI models and algorithms and utility is as good as the quality and quantity of data. So the data are terrible, no matter how good a software you have, it's not going to give you a good algorithm. Public domain data sets should be used. For example, the BCGA study has created, hundreds and thousands of mineable genomic features that people can use. You don't have to actually sequence genes and do them. You can use those related data, apply data science tools, and get some question answers. It improves, it needs collaboration between clinicians, basic scientists, as well as data scientists. So I think in any modern department, oncology department, having a data scientist is going to be very, very critical. Nobody has to write codes and software. Off-the-shelf programs are available, whether it's vision recognition, whether it's other forms of machine learning. Just plug in the parameters, plug in your outcomes of interest, and it gives you algorithms ready. But we have to be cautious. Then you can introduce biases from multiple testing and statistics, and so whenever you're using the large amounts of data and large number of predictors, you have to be careful. And many of these should be used as hypothesis-generating exercises rather than establishing causality. And I think if you add multiple input, clinical, radiology, pathology, molecular, the true value of AI is going to reach. Again, I thank you for your attention. I thank you for this opportunity. Given the extreme time difference, I may not be able to join in person, but I'm available by email, etc. if there are any specific questions from the audience. But again, thank you for this opportunity.
Any questions from the audience? This is a futuristic and a very important topic, so if you got any questions, you can ask, please. I got my own comment. It looks obvious that artificial intelligence is the future, and it's going to take over more and more functions from us, human beings. And to me, it looks as if there are two fields which are going to be affected more than anyone else and earlier. One is pathology, second is radiology. Probably clinical sciences come a little late, diagnostics come a little late, and surgeries, the therapeutics come even more later. The reason is radiology and pathology are basically disciplines which depend on two things. One is data crunching, second is pattern recognition. So artificial intelligence and machines are very good in these things. But when it comes to counterfactuals, what I mean by counterfactuals is anything that's outside the data. A computer is only as good as the data that you feed in. If there is no data, the question that has to be there, what if is a counterfactual? That's outside the data. Still, we don't have any artificial intelligence which can answer that question. I think probably you can, we do more and more reading, we realize that it is still in infancy, but probably it may take a long time. But for example, if you see IBM Watson was an early attempt, but they have given up because they realized that there are so many problems. When data crunching can do only so many things, but not more. So I think Dr. Mihir Desai probably will be able to talk more on what happens when the data is not there, because ultimately there is a limit to how much data you can feed. And also the quality of data that is fed in. Garbage in, garbage out. That has to be remembered.
I think two comments. I think the most important thing, as I agree with the other chairperson, is structured data. I think the most important thing is giving in the structured data so that the output is going to be very, very important. Otherwise, you're going to introduce bias. The second comment is, I think we are in an era of augmented intelligence. I think we are still not yet into the artificial intelligence space, because in the next decade, I think we are going into self-aware intelligence, wherein the computer will add another aspect of emotional intelligence, which is going to replace a lot of jobs which the doctors are doing right now. So I think in the next decade, it's going to be a little challenging. With respect to artificial intelligence, right now, I think it's still augmenting the intelligence of a human brain. So it's still a lot way to go to replace the human workforce.
Yeah. So we go to the next talk, which would be delivered by Dr. Kumar Prabhash, and he would be talking on targeted treatment is the standard of call with AI-driven treatment algorithm. Yes, indeed, AI is here to stay, but we all agree that it is in infancy right now.
No issue. Good afternoon, everyone. And at the outset, I'd like to thank the organizers for this opportunity, especially Dr. Raghunath, and a tricky topic, not something which we face every day. But yes, what was told by the previous speaker, it was right. Many of them we do face and use every day. He told about digital pathology. All the NGS report, which we do routinely today, in many tumors, including genitourinary tumors, they do come by AI, and you have algorithm, and which algorithm gives you the report, and based on which you give the treatment. So yes, we are using AI in many aspects. I'll be talking about, in general, what happens with targeted therapy, but one of the problem is that you do have very little data, as Dr. Mihir also suggested, that you have an AI, and based on AI, you give a targeted therapy. But I'll give a context to it, that targeted therapy, you don't have to have AI for have a target and to give targeted therapy. There are other ways one can use it. Starting with an introduction, regarding cancer, I'll leave aside because we have talked about it. AI, again, Dr. Mihir has talked about it, what it means. Basically, you use a machine to do your work. If they can do your work is what you mean by AI in general. But starting with the clinical decision making. So for a targeted therapy also, what you require from all the patients having the data, which is there for, like if I have treated prostate cancer for 5 years, now to go through that data of the 5 years for an individual patient and take a decision, that becomes pretty painful. And Amit is not here, and Vedang is not here. Vedang is not to be seen, and we have a discussion last week only. We get a whole lot of second opinion cards in Tata Hospital, and believe me, none of the clinician wants to see that card. One of the reason is Because those cards has patients who comes only for second opinion, who has taken treatment outside for 2 years or 3 years or 4 years, and then you have one resident going through for an hour or two to get through the details of what it is there, and Santosh is here, and my another colleague, Dr. We have a colleague here, they will say, yes, we don't want, because it's painful. So who is going to do that part, that what has happened to the patient in 5 years, can we get in the algorithm, and then you decide a treatment? Yes, we have called something called Navya, which runs at Tata Hospital with the help of a relatively philanthropic organization. And yes, they do it really. And today also, almost every week, I do get 7-8 of them, those second cards. But there, when it comes through Navya, it is totally different. It is painful, but not as painful if it doesn't come with Navya, if you get all the details, and then you or your resident has to do it. So in clinical decision making, as far as targeted therapy or immunotherapy or whatever is concerned, yes, it does help. Yes, there was a discussion regarding Watson, and yes, Watson had an issue. It does help, but there was an issue regarding how much it helps and can it replace the doctors. Looks like it can't replace the doctor, and that's why the comment was it has been out of fashion. But we can't discount it. Let's see what happens in future. But I also think most likely it won't be able to replace the doctor, because you do have a subjective component which comes into the picture. I'll come to a bit of a pathology part later. And this was a paper from Navya, which was presented in ASCO by Director Dr. Pramesh, and which suggested that if you take this AI algorithm and if you put to the clinician, it does help in having the plan which was initially taken by clinician, because you have more information. Not only information is there, you can have something compared to what you have in the guideline. So for example, if I am sitting in the clinic, I have a detail of the patient, but not necessarily every time each guideline I remember. As much I think that I do remember, but Navya does that, because what they do, not only they go through all the details of the patient, not only they enumerate, they also put it across the guideline, hey, what it looks like, what the clinician has made a decision where this patient has come from. And as you can see that almost 28% of the patient, it was not compliant with the guideline what you have. Now, if we have it, that you, based on the guideline, you change the plan, because it again comes to the clinician. So Navya not does everything. It's not replacing the doctors as yet. And subsequently, based on the information, if you decide the plan, it goes back to the primary clinician. Almost half of them, they do change the plan. Suggesting what? Yes, in the clinic today, yes, it is happening in our country that you do have AI-based algorithm, company running only on this, which can help you in summarizing the cases and also may help you in knowing how to choose the best possible treatment in this situation. So this was for patient care. Another part is clinical trial. Again, you have all those targeted therapy, immunotherapy, other drugs. They are there in a treatment, but they are there in a whole lot in the development. One of the challenges, and this challenge remains worldwide, how do you have the lot of patients coming to the clinical trial? Because not only the benefit being part of the clinical trial, second is that you choose the right patient. And how do you again choose the right patient? Because again, there is an inertia of the clinician sitting in the OPD. By and large, only 15% to 20% of the patient or less. Globally also, the patients who are eligible for clinical trial, they come in the clinical trial. So one of the way to do is, there's a whole lot of, AI based company which can go to your EMR and select what you want. For example, if I want FGFR positive bladder cancer, they can get it done in few hours and a day, and you have it, oh, these are the patients which is available for your trial. If you want a second line treatment prostate cancer, how do you go about it? You have a trial today which can get over in 6 months or 3 months. You're not able to do it, or you have a 10 clinicians looking after the patient. Again, you have an AI-based company where you can go through the EMR and you get the details, and then the patient can be in the trial again helps the patient to getting those treatment, or targeted therapy or immunotherapy, what you have. It does give you not many more information. So we did some work. In fact, I'll request anyone, high volume center, get your AI guys. If they go through MR, you will have some revealing details. We did some part in the thoracic tumor by one of those guys. I can't say the details because it has been revealing, so I leave it there. Again, augmenting that, how the clinical query you put it, the clinical trial, you get those details and how it can help you in having more patient participating in clinical trial. We talked about AI in radiomics. We'll come to that again later on for a response to targeted therapy, how it can help. But we do know that it can help you knowing what kind of patients you have, or what kind of features they have. This is for taking the example from thoracic tumor, that AI can help you knowing in the screening of these patients. Again, same thing in the breast cancer. This was something Dr. Mihir talked about, that you have those big data, and big data from genomics, proteomics, epigenetics. No individual can read it. If anyone has seen it, fine. If no one has seen it, please go ahead and see it. No one can read. When you have a million reads coming in front of you, will never be able to read it. So AI is already doing it. What it does, or which already it has done, in many tumor, including kidney cancer, prostate cancer, they have given you those targets where people can work on it and find out targeted therapy for those targets. And this was absolutely not possible without AI in these tumors. Yes, so you do have many of the targets where you do have targeted therapy. Not only that, I'll take just 1 minute, not more than that. If you have those targets and then you want targeted therapy, if you start choosing one by one, most likely it will hardly ever you will get those targeted therapy. So what people do it, you do have targets, and again you have thousands of targeted therapy. You try to see again based on AI which one looks like it will work best. One of the drug which came in this was called lorlatinib, again designer drug we call it. Dr. Poonam is there, madam will vouch for it, excellent drug. But again based on that, beforehand you know, okay, most likely this drug will work, and that drug was designer drug, will talk about it in case there is a question about it. What we want from AI, predicting outcome, the patients who will benefit or who will not benefit. You have a whole lot of data regarding that. If you use AI, you can get those patients who can benefit the treatment, who may not as good as we want. So we don't have those answers. For immunotherapy works in out of 100 patients, you give 20 of them. We all want to know who are those 20. Whole lot of AI data is there, but again, it doesn't look like we are at this position where we can use AI to predict that. Again, out of 100 patients you treat, 20 of them has got severe toxicity with these therapy. Again, we want to know who will have those. At this moment, we don't have it. And that's why we don't have it, because of these limitations, what we have with AI at this moment. So yes, AI is here to stay. Already we are using in many aspects. In future, we'll be using more. But at this moment, we will be using lots of clinical judgment to give treatment. Thank you so much.
Any questions?
Yeah, just a quick comment. Kumar here. So, I think AI in therapeutics it's a far-fetched. And why? Because we are in the era of precision medicine and precision therapeutics, which I would say that it may not work, but eventually it will work when we combine the thousands of data globally to understand that any therapeutics which has been done in the past for the patient, to understand that if it is going in the same line of thought or it may not. But deciding a AI-based targeted therapeutics or immunotherapy, I would say it may not work even upcoming future. That's my perception.
So I can't say for future, but I agree. Till now, it has not happened that you have AI data and based on you give treatment and it differentiates between people who will work and which will not work in a clinically significant difference. So yes, future, let's see.
Yeah, because personalized, we talk about the personalized. You know, the cancer is very complex. So going back side of the data, patient history, background, and making a decision for the therapeutics is a very complex process.
Yes, at present, except that, see, you do have some places where your AI gives you that, yes, this patient, you can have this drug working. It does not happen as yet. If it can start doing that, maybe, but at this moment, no, I agree with you.
Thank you.
Thank you, Dr. Kumar.
Thank
We'll go on with the next talk. So, Pathology, Artificial Intelligence, Machine Learning Driven Diagnosis by Dr. Santosh.
Very good afternoon. So after your comments, I really don't know whether you need pathology anymore or you need artificial intelligence. For quite some time I have been knowing this, and I think time will come when I'll have to retire and take a farm and start some organic farming soon with artificial intelligence. But I'll give you some overview about how in pathology artificial is come in a big way. And like rightly pointed out, it's more of a pattern recognition. So radiology and pathology are the first which are going to be impacted maximally. I hope that it's going to empower us rather than replace us, and that's my thought process. A conflict of interest, I'm involved in some AI projects, but do not have any commercial interest in that. And this presentation has most of the images are from the internet, and there are no breach of confidentiality of patients. So these terms have been already talked about. I'll not go into the details. Basically, artificial intelligence looks at using machines to imitate human intelligence. Machine learning is a subset of it, and deep learning is something which is something similar to human brain, which can connect the wires and do something on its own and give us outputs. So that's the deep learning algorithms. This has been summarized. There are several applications in GU cancers. I'm not going into the details. The previous speakers have already covered these. What is basically understanding about artificial intelligence, there has to be a lot of data. So like you said, garbage in, garbage out. The whole concept of AI will depend on big data, big, good quality data. So the idea is, if you have less data, an algorithm which is run and made on a very few number of data or little data is not going to be robust. So the more data you feed in, the more supervised annotation you do in the algorithm, that's how you get good data and good outputs, and that's how the machines are going to learn. So somebody has to train these machines initially by using big data. Somebody has to sit and annotate and give the ample data to these. The deep neural networks and the deep learning is based on these lot of neural networks which are similar to human neurons, which can connect the dots. So each of the black one which you see are different questions which the algorithm asks at a given point of time, and finally you get an output based on the input, and once it's run through the deep neural network. So coming to pathology proper, how do you implement artificial intelligence in pathology? You have to make the basic glass slides. The tissue has to be grossed. It has to go through the processing. A good glass slide, good quality is a necessity. Then comes the role of digital pathology. You have to digitize these slides. They go into high-end scanners. High-quality pixelated images are made. And then comes annotation. Somebody has to sit and annotate and tell, this is a malignant gland, this is a benign gland, this is a stroma, this is Gleason pattern 3, Gleason pattern 4. You have to train the machine that way. And then it goes into a computational software algorithm. And then there's the question of standardization, validation, pathology, and finally approval and acceptance before it comes into the market. Coming to my own department, we have these scanners from Roche, 3D Histech. We have the single scanner, which we sometimes use in frozen section, which is the Grundium, and the Philips 300 slide scanner, which is present in department. Last 2-3 years, we have been using these slide scanners. And if you look at the applications of digital pathology, there are several ones, and AI and deep learning will be totally based on digital pathology. So unless and until you digitize your slides and scan your slides on good quality scanners, you will not be able to use them. This is just a short video of what our digital pathology room looks like. So these are the different kinds of screens which we use. The images have been digitized, and the one you see here is the scanner, the small scanner from 3D Histech, and this is the digital pathology reporting room in TMH, what we have. We use them to calculate the ERPR scoring in breast cancers, just as a general thing, the Ki-67 index. And see, this is under the microscope. The brown ones are the positive nuclei, which the AI algorithm can pick up and differentiate from the negative. And it can give you a scoring system. as a output in this. So these are the algorithms which will be used in the pathology lab. In most of the labs, will start using the mundane thing. So counting of mitosis, counting of Ki-67 index, those things will be done definitely by software algorithms in the future. Quantification of the tumor is another thing which AI can easily do. And then there are the PDL1 scoring, the complex scoring, which has a lot of subjectivity among pathologists. That's something which the machine, if taught well, will be able to pick up. So these are few projects which are going on TMH, and one of them is the Gleason scoring, which we are doing with a Singapore-based company. Already a lot of automated Gleason scoring systems have come into practice via deep learning, and what they do is they digitize the images, and the algorithm breaks the images into several small pixelated. They convert it into electronic data, given a number algorithm, and then there is a common pooling of this data, and finally it stores these data in the form of electronic reports. That's the process. The images are annotated. So annotated means you mark out the tumors, separate out from benign tissue, separate from the stromal tissue. You train the system. The system will make it into patches and pixels and then combine them and store them as heat maps. So these are what you know as heat maps of pathology images, the benign, how they look at, and how the malignant look, and that's how the scoring system is coming. So this is what we are doing currently. We are going to do currently with the Singapore-based company, and this is a prostate biopsy. And when you apply the AI system, it will mark like this. So green is a benign gland, yellow is a pattern 3 Gleason, light blue is a pattern 4, dark blue is a pattern 5. So it will mark out these areas, and then it will give you a result that this is the Gleason pattern of the tumor. Again, there are several other studies which have validated the Gleason findings, and mind you, deep learning has reached a level where it can compete with pathologists, and at least in prostate biopsy, the Gleason scoring, to the extent that almost 10 years experienced pathologists and the deep learning are now at par, at least in Gleason scoring. So this is a summarized report. So I don't know whether Dr. Raghunath and Ginil and Kulkarni sir would like to see a report like this, where you get a report like this with the diagrams telling you how much a malignant gland is. So this is the output of the AI program which we are running. So this is all the 10 cores. The green ones are the benign cores, the blue ones are the pattern 4, the yellow ones are the pattern 3. You get a visual impression also. So they make an image, they give an output like this, and this might be the future of at least Gleason scoring that I can say, which is coming up. Similar in prostatectomy, it can give you where the tumor is, what part of the gland, and how it looks, what is the areas of that part of the gland. This can all be done by machines which are trained. I think I might lose my job and I need to push up my panic button, and maybe by next third or fourth SOGOCON, I might be standing in line and some robot might be standing here and teaching Gleason grading instead of me. So that's a possibility, but I don't know. But at the end of the day, I would say that AI is going to empower pathologists. It will make us more efficient. It will take us all the mundane work from them. So currently what is happening in the US and other some European countries is that a pathologist walks into his room, he opens his screen, there are 20 cases of prostates which are lying there, and it clearly mentions that 3 of them are benign, completely benign, 4 cores are positive, there are 2-3 which are atypical, which a pathologist will have to look into again. So it will put your work in a very, very systematic manner, more logistically. You will be able to look, you will have less fatigue. So there will be clear-cut benign which you can quickly run through and finish it based on the AI. So it will definitely help us with fatigue and make us more productive. So hopefully we will be able to. So not only in pathology, if you have clinical informatics, molecular pathology, you can do a lot of other things and prediction of outcomes of this is also. I'll just give an example. This is a study by Daniel Spratt presented at ASCO GU 22, in which pre-treatment biopsy slides were digitized from 5 big trials, and they were compared radiotherapy with or without ADT. And they developed an AI-based algorithm, predictive biomarker based on AI. And this was the study validation done by them. And you look at the prediction model, you get a hazard ratio of 0.33, 0.26 in favor of RT alone. So they said many of these patients actually did not need ADT for a long term. Only RT was suffice for this patient. So these kind of things cannot be done by routine trials. So AI is going to empower based on pathology. So as a pathologist, I can see 10 features in a slide. AI-based algorithm can say 110 features in a slide. So that's going to happen. Just a word about issues and limitations. We need large file size, so each slide is around 1 to 3 GB. We need storage space, heavily dependent on graphics, boost computing capacity has to be there, and all these medical devices have to be cleared by FDA before they come into practice. A very important thing which many people don't come to is the ethics. A lot of data is being transferred to cloud. We don't know the security of that, patient confidentiality. Patient should know whether his data, where it is going. So those things have to be talked about, and those have to come into practice, because that's a very, very important issue when it comes to patient rights. Thank you very much. I hope I gave you a very small overview of it. Thank you. Any questions, chairpersons?
No question, but please.
So are there any regulations as to which steps of a final report can be carried out by the AI, and which has to be kind of independently verified by the pathologist? Obviously, the final diagnosis, but how does one ensure that the slide is of adequate quality? Do they need to repeat the biopsy, something like that?
So like I said, the most important thing to use AI in pathology lab is to digitize the images. So if your quality of formalin fixation is bad, if your tissue is bad, if your slide is bad, and the final slide quality is bad, I think you just cannot proceed further without any of these. A very quick question to maybe Dr. Ginil, Dr. Raghunath. So there will be hundreds of AI programs. So for a given prostate patient, there will be hundreds of AI programs which are going to come up in the market. There will be several companies saying my AI is best. So it will finally boil down to the same question: is one pathologist better than the other, or one AI better than the other? So you will have to believe somebody in that context also. So that's going to happen definitely. It's not only one company which is making AI in prostate or say bladder or kidney. There will be hundreds of things. So again, there will be a subjectivity or a relative subjectivity between different AI programs and their usability.
So the question back, Santosh, then how are you going to validate these different AI programs?
So
is it possible?
Currently we are doing
because we are not getting the basic data based on which the AI program is coming. So how you are going
finally, Ginil, at the end of the day, we will be looking up to the best companies. See, there are certain, like Google AI is probably going to be one of the best ones, which are going to develop certain programs, and we'll have to believe them that their data is going to be more robust. See, finally, at the end of the day, it's a training of big data. So any algorithm which is trained on big data is going to be more robust compared to a smaller company, say in a smaller country, which has been developed on those. So that's the question which will be a big. So it's a believability by the clinician on this pathology.
Santosh, Dr. Kulkarni here.
Yes, sir.
I mean, how are you going to prevent the transfer of data from here to anywhere? It can be used by anybody.
Can be used. So security questions are a big thing, sir. Currently, we are doing several projects on AI and part of AI, where the images are being digitized, they are being annotated, they are being sent on a third-party cloud. So we really don't know whether somebody has access to that. But they say there is all security and all, but then there might be security breach in this, and that's a huge question of patient ethics and confidentiality, and the information is all integrated there. So those things will have to be addressed if we before we adopt AI.
Thank you very much, Dr. Santosh. It was a very interesting discussion.
Thank you.
May I call upon the...
Can I have
we'll discuss later on because we are running short of time. Thank you very much. Next speaker, Dr. Aditya Vinod Kumar will speak on technology to bridge the gap between patient and doctor. This will be the last topic of the day.
Hello, everybody. Good afternoon to all of you. I think I'm the last speaker. I'll try to be short. I have some conflicts. I'm a co-founder of GIF companies, and I'm working primarily in Germany, and I would like to present to you certain tools that we're using for patient. So today's topic was more about how doctors are improving their treatment, how doctors are improving their care using AI and technology. So I would like to come up with from a perspective of a patient. I'd like to show you what happens from a patient's perspective when he's got cancer, and what happens when we can use digital technologies and use digital health solutions to kind of help him in that journey and try to provide some kind of assistance. Cancer, as we know, it's a very stressful event for the patient himself and the relatives as well. And there's a lack of understanding, right? We ourselves are talking about AI difficulties in understanding the disease. So look at patient's side. It's very complicated and he won't really know everything because he's got a lot of questions to ask. There's no time which is available from the doctor's perspective. And also the material that's available on the internet, it's confusing, it's very difficult to comprehend all of this. This is a regular problem that we are facing around the world. And anxiety is something that results in such kind of lack of knowledge, lack of communication. And there are papers showing that anxiety, temporary anxiety preoperatively is associated with pain, and there's also lack of consenting which is happening around the world, and that results in various strategies that can be used to cope up. And of course some papers are also showing that adequate consenting helps in relieving patients' anxiety, and that's what we're trying to solve using some products. So now we are in the era of digital health, right? We're using a lot of digital solutions, and a lot of companies are coming up offering some services. And I think the core features that would be focused on is like kind of the consenting process, sorry, and also to provide personalized care pathways and kind of help patients to see if they've got symptoms right at the time when the symptoms are occurring, and then rather not come up later during the follow-up, and look at patients remotely. So I have a solution which I can show you today where we can use information from the reports or CT scans, MRI scans or whatever, and convert into very easy to understand models, something which is here, which is explaining visually what exactly the problem is going on in the patient's side, right? This is a kidney tumor, self-explanatory. When the patient knows he's got a tumor, it's a small one, then basically that gives him some kind of knowledge. This is kind of a product that helps only in the understanding, but if you want to go for hyper-accurate models, I work with a company based in the UK where you can send CT scans and they convert into very hyper-accurate 3D models which can explain what exactly the problem is, where the tumor is sitting. You see in this case, he's got a complicated situation. On the right side, he's got a small kidney. Sorry, on the right side, he's got a big tumor. On the left kidney, there's a cyst, and the patient knows why it's important to preserve the right kidney and try to get the tumor out, because the other side, the kidney is small and he might have problems with his kidney function. So it is an easy tool where the surgeon can actually explain the complexity of the surgery and tell him, look, we are trying to achieve a partial nephrectomy, but in case this is going to be complicated, you might be ending up in a nephrectomy. So that's kind of a very useful tool that we are using right now in counseling, and understanding the problem from the patient's perspective is easy. And not only that, we can use these kind of images, these 3D models, and then produce kind of a personalized, animations of the whole procedure. For example, I think this is a kidney tumor surgery where the patient is being shown how he would be lying down, if it's on the left side, if it's on the right side, how the patient would be positioned, and also this would go on to make personalized animation of his, clipping of his vessels. It can explain to him in multilingual methods how exactly the surgery will be happening and how the steps will be conducted. For example, here is a robot-assisted partial nephrectomy where the surgeon is kind of getting the tumor out and is personalized to the particular condition of the patient. And this is the surgery where we'll close and do the rhinography and then close the tumor. So after this video, the patient is able to understand what exactly the procedure is, how complicated it is, and how the treatment is going to occur. So this is another tool that we are using commonly nowadays, and I'm seeing that patients are able to understand a lot more than previously how the surgery is being happening in his body. And there are other personalized animations tools available now on various surgeries like the prostate, where you can see the prostate tumor personalized according to the MRI, and provides the personalized animation of the problem. And other bladder tumor, for example, if it's muscle infiltrative, you can easily show using animations how exactly it's going to be performed, right? Apart from that, you can actually guide a patient on the surgical care pathway, providing him a solution where he installs an app and kind of looks at it as a complete care pathway where he knows, okay, if 14 days before surgery, I get kind of a personalized, assessment, and I get to know what exactly is going on, like the surgical procedure I showed you could happen much before the doctor-patient contact is happening. He can understand the problem, not something out from the internet, personalized to his problem, and then understand exactly what's going to happen, and then actually go on to get the surgery done. And through these tools, we can connect with the patient and look at symptoms if he's got some. So symptom checker, nowadays AI is offering the possibility to algorithmize the symptoms that the patient might have and produce very classical differentials from the symptoms which a patient's got. One product which I work with from the US, Maya, kind of evolved after 25,000 hours of training and providing very clear algorithms that will provide outputs which says, okay, this patient has got hematuria, he's a 75-year-old male smoker, could be bladder cancer, and he could then get assessment done. So this is like at-home symptom checking which is happening right now. And we do see that a study from University of Michigan shows Maya could actually find out symptoms much better than an ER physician or an ER assistant. So it gets to look at the complete perspective of the symptoms and come up with complicated outputs. Not only that, we can use tools like these digital health tools which we can remotely monitor patient's health condition on an app where the patient can then see how the blood pressure or the blood saturation is moving or is improving or decreasing, and then we can use these outputs and with AI algorithms kind of catch hold of people much earlier if they have some problems. And of course, nowadays after Corona, we see that telemedicine is coming in really well to communicate with the patient, to talk to him on virtual mediums, and using the tools that I showed you before, understand from home what is his health condition, how much is he understanding the problem, what's his issue, and consent or kind of follow up the patient from telemedicine systems. So I feel that today, what we as surgeons we are using, although the Da Vinci is a nice tool, it's still a very expensive knife. We're not really using something beyond that and to help patients and treat them with systems. So what will happen is in the future, we will be seeing a lot of assisted, like for example, what we saw before earlier, and also tools like Maya, which will help the patient connect with the doctor anytime, anywhere, and give him that personalized support and assistance when needed. And when there is a problem, catch hold of him much earlier than before it occurs and it's too late. If he's got wound infection, if he's got fever, if he's got problems after surgery, catch hold of that right away and bring him to the hospital, triage him using support systems like this, and then give him that help that he needs for the cancer care, right? So summary, I think that digital health solutions help to connect the patient and surgeons, and we are moving towards patient-centric care than from a surgeon-centric support to a patient, right? And then patient has complete control these days if he's using these tools, and health is now at his fingertips using his smartphone. We must now adapt to these technology which is evolving and emerging and try to adapt this in our practice and use it more and more so that the patient feels comfortable and confident about the treatment. And I think a lot of companies are coming up which is going to help us in achieving this. Thanks a lot for your time.
Thank you very much. Any questions from the audience?
Hello, doctor.
Very well said. Only one question in my mind. What is the medico-legal status vis-a-vis India is concerned when these so many things are explored to the patient, told to them?
Correct.
And, how are we going to manage that?
So in Germany, it's a compulsion. It's a must that he understands the problem and consents, and we document that. And now the problem is that it's the other way around. If we don't give him adequate information and we give him half-baked information, that is a medico-legal situation. Now India has mandated consenting. That's why I guess products like this can help to clarify and give that assistance the doctor needs to sort out his medico-legal, the mandation that it should be done. So I think it's important.
Sir, वो front में mic है.
A lot of times patients are asking us the pen drive to be given to them, especially after robotic radical prostatectomy. They want it, and in fact, when I say no to them, they are not happy with that.
Correct. So I think this is something that it's a future, it's going to be all documented, and there are, as I know, an app which will give him access to all the data, and blockchain is coming up which will give him that ownership as well. So in the future we will see that all his data will be stored in his app, and he will be accessing that data, and then tomorrow it will be secured through blockchain and nobody can access it. Even if we want to see that, we won't be able to do it. So I guess this is where we are trying to achieve, and in the next few years we will be seeing a lot of this situation. Yeah, that's what I mentioned, control from the patient than us. Yeah, thank you.
So, thank you very much. We close this session. Thank you.
Thank you, chairpersons. It's the end of this session and the conference. Thank you all here right up to this time. Thank you the AV team who has supported us very well. And if anybody has any experience to share, please go ahead and speak few words. You are welcome. The lunch is already outside. Anybody can speak any few words here, please.
I think maybe
at the end of conference, Dr. Jagdish Kulkarni sir also, we request you to speak. आप बोलिए sir.
I think that's actually we are very much privileged and very lucky. I will say very fortunate and very, again, progressive to have such a step which we have taken. The scientific program here has been very, very, very excellent, nicely charted out. And what I appreciate is the organizing committee, how they have been contacting the faculties and the people, again, for last 1.5 months, telephone, email, WhatsApp. And everything has been available. I didn't worry at all till end. And everything has been superb. Very conference venue is superb. The scientific program is very superb. I wish more and more people would have availed it. So I think I really appreciate and I'm grateful that I have a very nice opportunity to be here. I enjoyed all 3 days here. The scientific program as well as hospitality and the weather of Bangalore. Thank you very much.
As a president, I have to say that all the 10 boxes I have ticked off, that hats off to you, Dr. Raghunath, Dr. Ginil, all the guys, and you made me proud. This was my dream years ago in 1986, which I made mention in yesterday, my presidential remark. But this is what I lived for 35 years. Thank you very much, and we had a great time. And well, we should give him a standing ovation, please. Thank you.
Congratulations to the team and executive team for executive team. All of them have
I would like to share all these things with
Ganesh. Yes.
All our team.
Let's have it. Let's have it. Yeah, I think togetherness worked very nicely. Yeah, teamwork. Yes, the teamwork. Thank you. See you in Mumbai next year. Midterm also, right? Very good. Great, congratulations. Great, congratulations. Thank you very much for the perseverance, keeping questions and making sense. He says, thank you. Look, this is now these documentation is so important for now. Now this is going to put another stress on us. Surgeon. So surgeon, every time you do everything, our team gets engaged.